So initially we used to use 0.225, but you know that few of the wires now 0.225 also we have wires which have good insulation. But previously what 0.225 wire was there, insulation was not good. So cutting was cut, even though you use pure cut or auto cut, cutting was not great. But 0.235 goes easily.
Dr. Nile, putting two wires through one cystotome sometimes is not possible.
No.
So if you want to place two wires in cyst, that is a technical issue. How to place sometimes?
Very easy. Do a cystotome in routine manner. Then do a dilatation. If you are so now you are putting plastic stent when you say two stents. So do a 10 French 10 millimeter dilatation. And then either you use that 10 French delivery system outer sheath over that wire, but it's blunt. So now I always use Haber rem. So you put a Haber rem, and because it's a tapered thing. So and then it has two more holes, so you can put as many wires as you can. So Haber rem is my first preference. If you don't have Haber rem, use 10 French stent system outer sheath.
Neela, you said that for 80% necrosis, you would do this. Would you not refer this patient to surgery?
So basically, there is nothing like I would send this patient to surgery and I would do this on my own. I always see where is the necrosis? Is it behind the stomach? Is it localized? If it is going into central mesentery, if it is significant necrosis going down, I would not touch. I'll ask my surgeon to go in. But if it's just a localized behind stomach, I would not ask my surgeon. I can easily take care of that.
Can you conclude the session now, please? Thank you.
Hello.
Yes, please.
Sir, I wanted to ask a question regarding antegrade stenting. If you are planning, what is the type of wire that you use? You use a straight tip wire, or you prefer to use an angle tip wire, or you use a Terumo for initial?
See, so basically we always start with the Terumo for any procedure. So our differentiating point is cystotome. So once you have Terumo either down or in the opposite duct, so you start it from the left duct. The wire goes into the right duct, no problem. Just make a loop there and then take a cystotome. Once cystotome goes up, then you can exchange it with any wire.
No, for negotiating it across the lower end structure,
so
which is
again same thing. You can do it on Terumo, go down with the cystotome, and then exchange the wire.
Is there any difference in using different types of wires? Some people say
any stiff wire is good.
Any stiff wire.
Any stiff wire is good, but you have to have a stiff wire. You can't put a stent across the stomach, across the Gleason's capsule, liver tissue on Terumo. No.
Yes. My second question is that, sir, for antegrade.
We are exceeding the time. I think we should stop at this point.
For antegrade stenting, sir, do you always prefer to use a metal stent, or you can also place plastic stents?
Always metal stent.
Always metal stent.
For US procedure, use metal stent. Don't use plastic stent except pancreas.
Okay, sir.
Thank you, chairpersons. Please conclude, please.
Thanks to all the speakers for giving excellent presentation. Thank you.
I would like to thank the speakers and chairpersons for their wisdom and guidance on the topics discussed. For the next 3 discussion sessions, I would like to invite as chairpersons Dr. Ashish Gandhi, sir, Dr. Shalapati Rao, sir, Dr. Swapnil Dhampalwar, sir, Dr. Radhika Chavan, ma'am, and Dr. Nitin Bahl, sir.
At the utmost, thanks to the organizing team for such a wonderful meeting. Now, for this next session, we have a wonderful 3 talks. I request the first speaker, Dr. Vipul Roy Rathod, to kindly come on the stage and enlighten the audience from his experiences on the topic of endoscopic management of ampullary lesions, optimizing the outcomes. Right to sir.
Namaskar. Thank you very much, Rajesh and Manoj. Thank you, chairpersons. I don't think I can give a talk on this subject in 12 minutes. So you'll have to excuse me. I'll try and finish. It will be a little rush. I don't mind. Anyway, so let's talk about endoscopic management of ampullary lesion. We know that very limited data is published on this. So I feel that whatever experientially what I have shared over the next few minutes, I will try to cover in this topic. The most important part is the complex anatomy. We are looking at a very complex anatomy, and that makes everything difficult. Okay. So what are the indications for endoscopic resection of ampullary lesions? I think endoscopic, any adenoma lesion which is not suggestive of malignancy, and endoscopy should have a proper staging and then resection. So my personal feeling is that some reporters have already reported. In fact, Ken, I wanted to refer to his study, that there is low morbidity, low mortality, and I think endoscopy should be given a first choice. So what are the outline and objectives of this talk? Lesion assessment, technique of resection, optimizing outcomes, bleeding, pancreatitis, and avoiding and managing complications. And I think advanced resection of laterally spreading lesion around the ampulla. I think this is something which we need to discuss. So ampullary tumors are not so common. And majority of premalignant tubulovillous adenomas, I think the 10% which we have, anything less than 2 centimeter usually looks benign, and they usually are. And even if you attempt an endoscopic resection, you are not taking away the surgical option. So this is very important. How do you stage this? So we have certain imaging criteria with MRCP and CT, EUS, or perhaps even IDUS can be done, So intraductal ultrasound we have done in few cases, but there are always some challenges. I don't want to go into the details. But yes, you need to assess the depth of the tumor. Now, there are some telltale signs on endoscopic vision where you have granular or villiform exophytic lesions, where you can have some idea as to what kind of pathology we are dealing with. And umbilicated lesion and infiltrating lesion, I think you should be extremely careful. So MRCP, we can do some assessment of the ampulla and how much it has gone into the bile duct. And endoscopically, sometimes you have to do intraductal biopsy to find out whether there is any benign extension into the bile duct, benign adenoma, which I have seen. Malignancy is suspected, and we know that biopsy is sometimes unreliable. Spontaneous bleeding, ulceration can happen, friability, depression, retraction and induration of the lesion is possible. And fixation of the lesion of the underlying tissue of the duodenum, I think we suspect malignancy. Ideal endoscopic resection, it's every, I think, individual based technique, but for me, I will describe some of the technical points that I always try to opacify the PD prior, and then especially in a laterally spreading lesion. Stiff wire snares are very, very important. Fulcrum technique, always go on the top apex of the ampullary lesion and then slide down your snare. I'll show you in a little. Complete excision of the ampulla is mandatory, complete. Immediate pancreatic ductal stenting for sure, and observe for bleeding and coagulation. I'll show you in some of the cases. So start from when you inject submucosal plane, you have to make sure you mark that area and elevate each segment and hook your snare in that area. So I'll show you that in the technical part. So just to give you an idea, I hope I can play this video. Can you play? Yeah, but I can't control the video. Can somebody from technical team come? How to control the, yeah, I got it. So a neuroendocrine tumor, I always use very little data on EUS and NET or ampullary lesion staging, very little data on this. I know that. So I've been using this for goddamn so many years, and I really identified You can see here, this is a small NET and pancreatic duct going in, gallbladder is fine. And a classical NET, I would say, oh shit, what's happening? Okay. There is some issue. I can't use this, huh? Can I have somebody? Yeah. I wanted to control this from here. Don't control from there. Please, for God's sake, I need to show the video. So always we do this kind of a clear-cut lesion, round lesions, looks like a classical NET. We resect and then, of course, do pancreatic cannulation and stenting for. Can you allow me to play the video? Somebody can allow me to play the video, or else I'll lose a lot of time. So we always use a wire-guided technique in pancreatic duct and no contrast. Even for advanced pancreatic endotherapy, I've stopped putting contrast unless absolutely necessary. So this is something which you need to understand. I would like to share this particular case with you. A 28-year-old lady who came to me. Can you just take out? Yeah. Please allow me to play. So you see, can I have a pointer, laser pointer? Can I have a laser pointer? So you can see intraductal extension of the lesion there, very small extension. Huh? No other imaging would pick up this beautifully except endosonography. So we managed to pick this up in a 28-year-old lady. Look at this, a papillomatous lesion in the lower bile duct. You can see the whole bile duct, that's a gallbladder, beautiful. I need to control my video. Can you allow me? Can you allow me to do that? Okay. So what we did was, we managed to do ampulectomy. We wanted to remove the ampulla, and then we cannulated and we dragged out this papillomatous lesion. It was papillomatous lesion with mild dysplasia. I did this in 2012. This lady, after 8 years, I told her that there is a dysplasia, we need to consider resection. And she said, no, I'm too young for any major pancreatobiliary surgery. After 8 years, she came with an ampullary tumor with obstructive jaundice to me. It was an adenocarcinoma. So what I'm trying to highlight here is that a follow-up, if you do an ampullary resection, a stringent follow-up is very, very important. At least the patient should have faith in you. So this is the kind of papillomatous lesion you can see. I dragged out, I stented the pancreatic duct, and I snared this particular tumor. And then we brought her back after putting a 10-French stent in the bile duct. After 6, again, there is a problem. Can you allow me to control my videos, please? Please. Can you allow me the videos to be controlled? I should be able to control, na? Yeah. So nahi hoga. Jaise I click here, it goes away. Okay. So then we placed a 10-French stent. I want you to show the follow-up video. So after 4 months, 3 or 4 months, she came back. We removed the stent. And you see, I'm staging the prepapillary area. It's completely clear of the lesion. Huh? We followed her up for some time, and then we lost to follow up. When she developed jaundice, she came back to me. So I learned an important lesson that any ampullary lesion with dysplasia, you need surgery. Okay. So contraindication, as I said, appears benign, and extension of biliary ducts or pancreatic ducts, we need to be very, very careful. I just show you this particular video because this patient had a pancreatitis. And it was a schwannoma occluding the pancreatic duct here. You can see a very clear, smooth tumor. So we managed to resect it, and we went deep. Again, there is a problem. Huh? This side. Yeah. Okay, okay. So we managed to resect it. You can see how my snare is going. Thin wire snare going from the below and then pulling the ampulla. You have to pull ampulla towards you. Otherwise, you'll catch the deeper layers, you'll not be able to pull it. So this is important. Pull the ampulla towards you, and then you can resect this very, very easily. We managed to resect. Of course, pancreatic duct was cannulated, and you can see the muscle layer here after the resection. You can see there was some oozing here. So we managed to control that. I'm going to skip this, but I'm going to show you that what is the trick of a laterally spreading tumor. I remember this patient was sent to me with a stent inside, a huge laterally spreading adenoma. And why we need to remove it completely and block. Start from the periphery, coming down all the way to the ampulla, resect, and you'll have some bleeding. You'll keep having some resection. As you can see here, I'm resecting. I'm going to go ahead. You can see how the snare goes down and lifts it up. So always lift the lesion towards you. And if you don't lift it, you will have serious problems. So I'm resecting here. You can see EMR, widespread EMR. You continue. Okay, now I'm going to just come to this main part. Now ampulla is isolated. So we've resected all around. And now we are just going to do an ampulectomy. Take out the whole ampulla from the root. Then do management of the bleeding as you go along. And it's very, very important to have a proper staged procedure. So I'm doing ampulectomy now, and ampulla is removed, and then you cannulate the pancreatic duct. This is the technique. I want to share this particular video with you. The reason is, I can't see, you can see that 5 by 8 centimeter duodenal ampullary lesion. Just give me a minute, I'm over. Look at the size of this lesion. Now, this guy went to 15 centers of India. Everybody advised Vipul. What did we do? We staged with EUS and radial EUS because I want perpendicular axis of the tumor. I want you to see, this is EUS CRCP meeting. We need to learn that. So we started doing EUS. You can see the bile duct coming down. I want you to focus attention here. This is the feeding artery in the tumor. This is the pancreatic duct. So I realized there's a mucosal lesion. When you do radial EUS, you have perpendicular access to the scope, to the lesion. And then I found that on color Doppler, there was only one feeding vessel I had to tackle. So this was the mapping. This kind of mapping is not possible with conventional imaging. And therefore, nobody will do it. So please use radial EUS in duodenal and ampullary lesions if you want to do massive resections. So after the resection, this is the picture. We did the EMR for this giant lesion. And believe me, the patient is still under follow-up with me. And we cleared everything, of course, in 2 sittings. So what I'm trying to highlight here is complications can happen, bleeding, pancreatitis, perforation, papillary stenosis. But yes, you can. I'm just going to skip this, but probably EF, full thickness resection. I don't know how safe it's going to be, especially with the pancreatic head there, but there is a possibility if there is a duodenal lesion. So in summary, endoscopic treatment of ampullary, periampullary, and duodenal lesion are safe and effective in expert hands. Valuable staging tool should be applied prior to resection. Definitive therapy for majority of benign lesions. I think endoscopic resection is effective in carefully large giant tumors, which can avoid a Whipple. Detailed mapping of lesion necessary with EUS. That is what I do for the last 20 odd years. Optimal equipment, accessories, and electrosurgical unit, and of course, experienced endoscopists. Thank you very much, ladies and gentlemen.
We allow only one question because of the want of time.
So there's one question.
Yeah.
Which patients on the basis of histopathology you refer to the surgeons if you have done the ampulectomy after histopathology reports?
Any patient with mild dysplasia, moderate dysplasia, because if you are not sure of the depth of invasion of this lesion into the bile duct or the pancreatic duct, this patient will go for resection.
So most of the patient, because they are adenomas, they will have dysplasia. So what about the margins, sir? If the margins...
No, so therefore a follow-up endoscopy is required. So if you do every 3 months, just a duodenoscopy and see everything is clean, then you can increase the follow-up to 1 year and then 3 years. I think they can be managed. But the histology is very important. If you have dysplasia, I will not take chances. I will ask this patient for surgery.
Thank you so much, sir.
Thank you.
We invite the next speaker of the day. The topic is EUS hepatology, advancing technology for better diagnosis and liver biopsies. Dr. Nirmajil Singh Malli. He is the chairman and chief of gastroenterology at AGI Gastrocity, Ludhiana. The stage is yours, sir.
Yeah.
Thanks, Alpati. Good morning, everyone. At the outset, my sincere thanks to Dr. Rajesh Puri, Manoj Sahu, and the entire team for this wonderful event and giving me opportunity to speak on a topic which I believe is gaining more and more ground and becoming more relevant in our practice, and that is on endo or US hepatology, with a specific emphasis on US-guided liver biopsy. So if you look at the literature, the term endohepatology came in vogue way back in 2012. And there was actually to describe the integration of the endoscopy within the practice of hepatology. But that was a time when it was purely endoscopy, looking for varices and variceal management, and role of EUS was very preliminary in the management of liver diseases. And now, a decade down the line in 2023, we have variety of EUS applications, both for diagnosis and for treatment. Even if you see in this cartoon diagram, which shows on one side elastography and contrast EUS, to portal pressure gradient measurements, to EUS liver biopsy, which will be my main aim, to coiling and gluing, to name a few. But this slide, I think, very aptly gives you, it might appear a very busy slide, but this is the entire repertoire of the EUS guided interventions in the treatment of liver diseases. So thereby today, endohepatology or EUS hepatology are used synonymously or interchangeably. So I'll basically discuss more about liver biopsy and partly about the role of EUS shear wave elastography in the management of liver disease. And on the other hand, EUS one part, if you look at the liver disease in our own practice, the one disease which has leapfrogged, which is, I think, grown by leaps and bounds, is non-alcoholic fatty liver disease. And in NAFLD, we have so many unmet needs or gaps in our knowledge. For example, you talk about a plain steatosis versus people with steatosis and varying degree of fibrosis, and then fibrosis differentiating between early to an advanced cirrhosis with or without portal hypertension. So how this EUS hepatology is going to bridge those gaps to differentiate between steatosis and steatosis with fibrosis, we are coming the role of EUS elastography. Once you have advanced fibrosis and maybe early cirrhosis, you'll need a portal pressure gradient measurement, which again can be done very safely with EUS, and role of EUS liver biopsy. Once you have the varices, you can do a wonderful management with the help of EUS. And then if you have focal lesion coming up in the liver and that lesion is indeterminate, you can do a contrast EUS, and maybe very soon in future, we are going to have EUS-guided ablative therapies for treatment of HCC also. This is something which we do in our practice day in and day out. This is FibroScan, or the vibration-controlled transient elastography, which is done transcutaneous. But we also know the limitations, which include people, if increasing obesity, your values, they start going haywire. Gross ascites, you don't get the right values. You only access the right lobe and can't do the left lobe. And there's significant discordance with the histology. So there has come the role of the EUS-guided shear wave elastography of the liver parenchyma, which is a real-time procedure. And this is now, this year, in the month of January, GI endoscopy, we had a proof of concept, head-to-head comparison of FibroScan with EUS elasto, and all these patients actually underwent a liver biopsy on the same day as well. And when you look at the parameters of comparison of sensitivity or specificity or positive or negative predictive value, actually EUS elasto did wonderfully well as far as the FibroScan and the liver histology was concerned. And this is what the conclusion of this study also was. But more importantly, in 8 patients out of those 42, where you had a FibroScan which was quite unreliable, they successfully underwent an elastography measurement with the help of EUS. So EUS elasto for liver, I still believe early days, looks promising. It's a real-time procedure, and you can do an elasto both of right and the left lobe. And more importantly, where you have a suboptimal examination with FibroScan, you can complement it with EUS elasto. This is my major part of the talk, which will be EUS liver biopsy. Why? How it fares as far as percutaneous or transjugular, do for all or select subgroup of patients, procedural details, and the literature available to us. We have two age-old standard of care modalities. One is the percutaneous and other being transjugular. But what I think EUS liver biopsy has given up the option is, on one hand, its safety fairly matches that of a percutaneous or a transjugular approach, as it's a real-time procedure. You apply a Doppler, and in Doppler, you go with your needle and do a biopsy. Efficacy, I'll show you in the subsequent slides. It's equal or a touch superior, both to percutaneous and maybe transjugular. Needless to say, there's an improved patient experience because you are doing it under sedation. And for people who are obese, children and pregnant ladies, there's an additional advantage. And more importantly, there's a big benefit to your own unit, as everything will be done as a single procedure in the same setting under sedation. And once we look at the data, that is basically the largest meta-analysis we have with us, which collated 9 studies and 427 patients. And this is what we look at: the diagnostic yield, which is almost 94%, and adverse effects, which are barely 1 to 2%. And this is now the comparison basically with the percutaneous and the transjugular approach. If you look at the specimen adequacy, which is measured either with the portal triad count and the total specimen length, it actually, even in the initial studies, showed it is comparable or it is a touch superior. And then we had the large meta-analysis, which was published in 2020, which showed a very comparative safety and the efficacy profile with both these approaches. But more importantly, if you see a subgroup analysis, EUS liver biopsy actually gives a longer total specimen length compared to percutaneous. And if you compare it with EUS LB, it actually had more complete portal tract. So actually, you're getting a longer tissue and better histological examination by a margin compared to the previous 2 routes of liver biopsy. And this is the selection criteria where you can straight away go with an EUS liver biopsy over and above a percutaneous approach. Patient who needs an EGD, for example, for varices or some other indication, where you need a concurrent EUS, you need sedation or a bilobar sampling, or where you want to do a portal pressure gradient measurements. Few details about the needles which are going to use for EUS liver biopsy. We go to the entire data. We have a large body of data available to us, which clearly shows for EUS liver biopsy, it has to be an FNB, which is superior over an FNA. It's 19 gauge, which is superior over a 22 gauge. And if you look at the make of that needle, the data shows the Francine tip needles tend to do better than the fork tip needle when you look at the specimen adequacy. Suction versus no suction, enough data, and the most of the data is supportive. It has to be with suction, and suction has to be a wet suction. And in wet, whether to use saline or heparin, data is favoring wet heparin section gives the best specimen with minimum degree of fragmentation. And this was again that paper which showed you had a higher aggregate specimen length, you had more complete portal tracts compared to a dry heparin versus a dry ear suction, and there was a least degree of fragmentation of the tissue. And now another detail about the pass and the actuations. This is, I think, very important to understand. Pass is if we actually go and puncture the liver parenchyma. So each time with needle, you puncture the liver capsule is actually 1 pass. And then any to and fro movements you make after that pass are your actuations. So you need to puncture capsule once and do 3 to and fro movements is 1 pass and 3 actuations. And only a single deep movement is 1:1, 1 pass and 1 actuation. So this is a study which clearly looked at that. And it showed if you make 1 pass with 3 actuations, you tend to get a longer specimen and better histological yield. And what about a bilobar or a unilobar sampling? Again, one study in the context of NASH. So if you do a unilobar, you miss fibrosis, inflammation, and ballooning in a substantial subset of people. So possibly in a setting of NASH, you should be doing a bilobar sampling. And this one is now the conclusion of what I told about the needles and others. It's a 19 gauge FNB, Francine tip, wet suction with heparin, 1 pass and 3 actuations, and bilobar when it is indicated, especially in a setting of NASH. And this is how we do in our own setup. These are things we require. We actually use a 19G with a linear echo endoscope, remove the stylet first. We use a wet heparin suction. It's our own preference, want to go a transgastric if we want to do a left lobe biopsy. So this is a patient of a persistently elevated liver enzyme for more than 3 months. So we're doing just underneath the cardia, focusing the left lobe, and then we actually draw a line, which is a line through which our needle path is going to be there. And we want to choose the most avascular plane. So the risk of bleeding or complications is minimum. So this is this is needle tip, and then it's going in. We actually make a long and a deep actuation. We tend to go almost 4.5, 5 centimeter into the liver parenchyma, then try to do a little fanning with the help of a up-knob movement. Again, the most important thing in US liver biopsies, whole time you're actually supervising the entire actuation you are making. And then again, I'll be finishing, I think, in another 1 minute. So this is the third actuation. And then once you withdraw, you don't take out needle immediately. You keep it at the liver capsule for maybe 30 seconds, apply your Doppler to see there is no blood in that path, and then you take out your needle. And then there is a specimen retrieval, which is basically as Vikram also told. So we actually use a heparin saline. So I'll go a little faster, and you just take out. And then once we clean this, and this is this is almost a 5.5 centimeter single uninterrupted core we got in the same patient. And this is actually found to be an autoimmune chronic pancreatitis. So ladies and gentlemen, I'm just going to finish that US liver biopsy is becoming a more preferred technique because of certain advantages. Can be done simultaneously with an EGD US. You need a 19G FNB, wet suction, 1-pass-3 actuation with a proper specimen handling. And endohepatology on a whole has really arrived in a big way. On a same day, you can do an endoscopy, look for varices. You can do an US coil and glue embolization. If you need, you can do a shear wave elastography of both the lobes and do a portal pressure gradient measurement. And then, of course, you can do an US guided liver biopsy, uni or bilobar, to get the best histological yield. Thank you, and thank you so very much.
Thank you, Dr. Nirmal, for a wonderful talk. Any questions from the house?
Yeah, I have a comment, like, I've done enough liver biopsy percutaneous,
Right.
and I stopped it because patient got a severe pain and vasovagal thing. So I
Right.
think where this, forget about everything else, but the patient pain is 0 after US, and that probably would score over all other parameters. Second thing is about the processing of the sample. You put it straight away into the whatever space.
Saline or heparin
What
saline.
I would suggest, take a sieve-like thing from your pathologist and put it over there and put some water. So the tissue remains in that sieve container and the water
Right.
comes out or the blood comes out. So you get a better clear tissue. Otherwise, I don't do 3, I do only 2, and I don't
Okay.
use wet section. Just clean the needle with a heparinized saline or water.
Right.
And then just dry suction. I think it's equally good. So I tried both and I think it's equally good.
Right. So I think point is very well taken. So biggest advantage, I think, is patient doesn't get any pain at all. In percutaneous, you have to actually go through the tissue and the muscle plane, and you can discharge the patient as early as once patient is out of sedation. So maybe at 1 hour, patient can go back home.
Thank you, sir.
So very nice, excellent talk, Dr. Nirmalji. My
Right.
query is, what's the logic of using heparin here? I mean, let the blood clot. So why do we use heparin? Heparinize.
So I think the whole concept is once we're not using heparin, the blood in the needle gets the tendency to clot and you form a blood noodle along with that. So you have to actually do a more tissue cleaning. But once we are using heparin, so that blood rarely clots. So moment that washing and tissue handling post-procedure becomes much simpler. So if we use either a sieve or keep anywhere, so just flush it, you get a nice tissue and blood just flows away.
Fair enough. So again, what Dr. Nile said that it all comes down to what you are going to do with your aspirate after you take a aspirate. So maybe it's part of the whole thing.
Right.
Thank you, sir.
Thank you.
Our next speaker is Dr. Surindra Rana. He will be speaking on disconnected pancreatic duct syndrome. Is US guided intervention the answer? Please, sir.
Thank you, chairpersons. Good morning, ladies and gentlemen. At the outset, I would like to thank Rajesh and Dr. Sahu for this kind invitation and giving me an opportunity to be here. Today, I've been asked to speak on disconnected pancreatic duct syndrome. Is the US guided intervention the answer for these patients? Disconnected pancreatic duct syndrome is often an overlooked complication of necrotizing pancreatitis, because at that time we are focusing on the management of necrotizing pancreatitis and not looking at the consequence of disruption of the duct. But whenever there is necrosis of the pancreas, there would be necrosis of duct, and this would lead on to complications later on. And why is it important to timely recognize it? Because delay in its diagnosis would lead on to a lot of complications, and studies have shown that it increases the patient's morbidity, it prolongs the hospital stay, and subsequently adds to the cost of the treatment. So this is how this disease evolves. In an acute phase, once there is necrotizing pancreatitis, both the duct and parenchyma will be necrosed. The focus will be on managing the complications of parenchymal and extraparenchymal necrosis, but then subsequently the part of the duct which is upstream to the disruption would get dilated and lead on to disconnected pancreatic duct syndrome. So this is what will happen if you do an ERCP in early stage in a disconnected duct. There will be a blowout. You won't be able to fill the upstream duct. But if you do an MR, you will find that there is a dilated upstream duct. So this is the spectrum of the disconnection in acute and chronic stage. First of all, before we start intervening, it's important to differentiate between the disconnection and the syndrome, because these are two different entities. When there is extensive necrosis of pancreatic parenchyma, they'll, along with the disruption of the duct, it will lead on to disconnected duct, but there will be no symptoms because there is no parenchyma left upstream to cause secretion of the pancreatic juice and cause symptoms. And if there is ductal necrosis with preserved and functional upstream parenchyma, it will lead on to disconnected pancreatic duct syndrome. So this is what will happen. In this first scenario, you see there is extensive necrosis, but you can see that the parenchyma upstream is viable. So this patient will have a disconnected pancreatic duct syndrome, and you can see the dilated duct. On the other hand, when there is extensive necrosis, there will be ductal disconnection also, but these patients will not have any symptoms because of the subsequent atrophy of the upstream pancreatic parenchyma. Now, once we have learned about DPD and DPDS, what are the consequences of disconnected pancreatic duct syndrome? The patients may present to you with various symptoms and syndromes. First would be persistent peripancreatic fluid collection or an enlarging collection. That's the common scenario which we see in these patients. Or patients may have a pancreatic ascites or pancreatic pleural effusion. And patients who have undergone a percutaneous drainage will have a persistent external pancreatic fistula with a high amylase value in those fluids. And then patients who have initially undergone a drainage or have resolution of the symptoms will again come back with either recurrent pancreatitis or recurrent fluid collections. Just to show you one example, here was the same patient who had a disconnection with a viable parenchyma. This patient was treated with a transmural drainage. So you can see the collection is resolved. This is a plastic stent in place. The upstream duct is dilated. So at this patient will develop a disconnected pancreatic duct syndrome if this stent migrates. And this is what happened. The patient had migration of the stent within 3 months. The patient came back with pain. So you can see this is a dilated duct and you have a fluid collection at the splenic hilum. So there's a recurrent fluid collection. So that's a common scenario how disconnected duct syndrome will come to you. So how to manage these patients? Watchful expectancy will not work because the upstream parenchyma will continue to secrete pancreatic juice. So there is no role of conservative treatment. You will have to do some intervention. Percutaneous drainage might help in resolution of symptoms at that point of time, but subsequently you will have a persistent external pancreatic fistula, which will increase the morbidity and trouble for the patient. Transpapillary drainage, which all we do for a lot of pancreatic duct diseases, is ineffective because the upstream duct cannot be drained. And the only option remaining was to do a surgical drainage. And that's what most of these patients used to undergo a couple of years back. But now EUS, especially therapeutic EUS, has changed the management landscape of DPDS. And that's what I'm going to show you in the next 4 to 5 minutes. This is what we used to do when there is a ductal stricture or a ductal disruption, which is partial. Do a minor papillotomy, bridge, and place a stent, and the symptoms will resolve. But this will not work in disconnected duct, because if you do it in acute stage, this is what I showed you, you will have a blowout. And if you do it in a chronic stage, you will have a complete cutoff. So the upstream duct will not be visualized on ERCP. On an MRCP, you will see that the upstream duct is dilated. And this is the duct which has to be drained if you want the patient's symptoms to resolve. So now this upstream duct can be accessed using an EUS, and that's actually turning out to be a panacea for management of these difficult to treat patients who can be managed with EUS guided therapy. So the endoscopic approach using an EUS depends upon the clinical presentation of the patient. If the patients may present to you in one of the three scenarios, one, it will be non-resolving peripancreatic fluid collection. Second would be a persistent external pancreatic fistula. And third would be either a recurrent attacks of pancreatitis or recurrent or a persistent abdominal pain, that means type A or type B pain with a dilated upstream pancreatic duct. So I'm going to talk about the management of these three situations briefly. Non-resolving PFC is easy to treat. We all are draining pancreatic fluid collections under EUS guidance, whether they are bulging, non-bulging. So you just have to place a stent. If you place a metallic stent, replace it with a plastic stent. Or if you have placed a plastic stent, let the plastic stent be there. There is a little debate if you have drained with using a metallic stent, do you need a plastic stent or not? But that's for a separate day. I'm not going to discuss that debate. But right now, at most of the centers, if you have a disconnected duct, you have drained the fluid collection, it's better to leave a plastic stent in place, because even if 10% or 15% of patients do develop complications later on, they will be very difficult to manage. And studies have shown that leaving the permanent transmural plastic stents don't have any safety issues or any significant adverse effects. Just to show you an example, the disconnected duct with a recurrent large pancreatic fluid collection, put a plastic stent, everything is gone. You do an MRCP, there is a disconnected duct, but patient is asymptomatic because of this transmural stent which you have placed. External pancreatic fistula with a disconnected duct is a little tricky. It depends whether you have a coexisting pancreatic fluid collection, which we call as a capsulated EPF. If you have a capsulated EPF, you can attempt to drain that fluid collection, and that will help in internalization of the pancreatic fistula. If there is no pancreatic fluid collection, it is pretty difficult. There are various ways in which you can do it. Either you can take a help of radiologist, or you can do it all on your own. I'll just briefly talk about those things. So if you have a capsulated EPF, it's easier to drain. What you have to do is that whenever there is any fluid collection, just try to target that. So this is a patient who had a external pancreatic fistula, underwent a surgical fistulojejenostomy. 3 months later, again came back with a recurrent EPF. So when we did in CT, you can see there are a lot of collaterals, but you could see a small fluid collection near the hilum. So we targeted that on EUS, put a wire, put a single stent, and you have been able to internalize the external pancreatic fistula. Another patient, you can see there is a pancreatic pleural effusion, underwent pigtail drainage. Now you can see a hydropneumothorax on. So this was a pancreatic pleural effusion. ERCP was done. Obviously, transpapillary will fail, but still a short stent was placed in the pancreatic duct. But luckily, this patient had a small fluid collection in the body, and you can see upstream dilated duct. Do an EUS, a very small pancreatic fluid collections. These are a little tricky to dilate, to put a stent because of the small diameter of these fluid collections. So one has to be a little careful while placing the stents. Put a wire, coil the wire carefully inside these cavities, put a stent. So you can see on this fluoroscopic image, this is a transpapillary stent, which was not bridging the disconnected duct, and you have placed a transmural stent into the collection, and then follow-up CT scan shows resolution of the collection as well as fistula. Non-capsulated EPF, they are difficult things to manage. The first step, what we do is, this is what we published, is first clamp the catheter. About 30 to 40% of patients will have a small fluid collection developing. So once the fluid collection develop, drain it transmurally, and you will be able to internalize the fistula. If that doesn't happen, the second step is try to instill small amount of saline or distilled water and try to create an artificial cavity, as being done in this case. Once you have created the cavity, coil the wire and place a stent. Sometimes nothing works, but you are lucky that the percutaneous catheter is close to the stomach. So you can directly visualize the percutaneous catheter on EUS, puncture with a needle, inject contrast, and thereby coil the wire there and dilate. Just to show you again more carefully, you can see the tip of the catheter is close to the stomach. That's the most important criteria when you are directly puncturing the fistulous tract. Distend the stomach, you will find you are very close. Coil the wire there and place a stent. That will help in resolution of the external pancreatic fistula. Now, the patients who have abdominal pain or recurrent pancreatitis are the most difficult to manage, and majority of patients with disconnected duct will present with this. So the only available endoscopic option for these patients is to try to drain the main pancreatic duct internally by doing a pancreaticogastrostomy or pancreaticoduodenostomy. But believe me, it is difficult in these patients because the duct is not dilated much. It will be usually 6 or 7 mm, and then it becomes very difficult to do a pancreaticoduodenostomy or gastrostomy. But then Moreover, the data on efficacy of this treatment is very limited. There are very few studies which have looked at the pancreatic duct drainage in setting of disconnected duct, and patients who are not amenable for endoscopic therapy can be offered surgery. So this is what we try to do, is put a stent in the upstream duct and drain it into the stomach. So just to give you one example, this is a patient who had a necrosis at the neck. So this is a watershed area. These patients will develop a disconnected pancreatic duct syndrome, and this is what is there at that point. At week 5, there is a large collection. So this patient undergoes a axial stent placement at other center, and 4 weeks later, after the resolution, the stent has been removed. And this is a CT scan at the time of stent resolution. You can see there is a disconnected duct with dilated duct. And then patient again comes back to us with pain, no fluid collection on MR done one. So planned for an EUS guided drainage, but luckily there was a small fluid collection which we could see. So this fluid collection was drained with a plastic stent. Collection is gone. Patient is asymptomatic now 9 months after this procedure, and we have let the stent in place. But sometimes you will not be lucky. There will be no fluid collection. Then you will have to do a pancreaticogastroscopy, as has been done in this patient with a disconnected duct. Visualize the duct on EUS. It's a small duct, just 5 millimeter. Dilate and place a plastic stent. Sometimes the duct may be more dilated, as in this case, and you can place a plastic stent, but plastic stents do tend to migrate. And off late, we are placing clips along with the stent so that they don't migrate outwards. But still, there are a lot of unanswered questions. How long to leave these transmural stents in place? We really don't know the efficacy of long-term stent drainage. We have just published a data which have looked at the parenchymal changes in these patients who have undergone a transmural drainage. Almost 30% of these patients in 5 years are developing chronic pancreatitis of the upstream duct. That means the drainage which we are providing is not effective. It might be controlling symptoms, but not the parenchymal changes. So we are not able to prevent the atrophy. We really don't know how long to keep the stents, and we are still looking for the best plastic stents which don't migrate in this setting. So to conclude, we have learned DPDS is an important but often overlooked complication. Early diagnosis is critical. That will help what management you want to give. Interventional EUS has expanded the spectrum for endoscopists to manage disconnected duct. However, we need to understand a multidisciplinary approach involving radiologists and surgeons is important in its effective management. Thank you so much for your patience here.
Very nice talk, sir. I have one question. So in case of DPD, should we treat the imaging or symptom? Because most of the patients, 70–80% remain asymptomatic.
Yeah, that's what before I started, I said it's important to treat the symptoms, not the imaging. Just leave the imaging, because we really don't know whatever we are doing, is it preventing the long-term complications or not? Because for any effective drainage, you don't want the patient to either develop diabetes or steatorrhea. But the evidence currently which we have is that whenever we drain, we are not able to prevent that. Still, the patients are developing diabetes, still the steatorrhea is there, and pancreatic functions are deteriorating over a period of time. So I think it's important currently to treat symptoms, not imaging.
So sometimes these patients will have a very small collection and there is already surrounding inflammation so when you re-intervene to put a plastic stent, so it will be very difficult sometimes to exchange the axes or place the stent.
Yeah, I think that's what I said. These are very small fluid collections. Sometimes we will fail, the stents will not go in because the pigtail require at least 2–2.5 centimeter to get deployed. So many times you will not be able to deploy. So you have to carefully look at the imaging, at least have a 2.5 centimeter of the fluid collection before you go in. Otherwise, you will not be able to deploy your pigtails, and use a 3 centimeter double pigtail stents rather than using 5 or 7 centimeter double pigtail stents.
So during that situation, do you feel like a single time aspiration might help?
No, the single time aspiration will not happen, because the aim is to internally drain the duct, not drain the fluid collection. And then other trick is don't balloon dilate. You just do a cystotome and place a 7 French or a 5 French stent, because the aim is internal drainage of duct, not the drainage of a necrotic collection.
You showed us that you don't see anything, you just see stent, you try to puncture. It's not so easy.
That's why I said it is the last resort. It is very difficult.
Yeah, in different planes, you are at different places and you think you are near stent, you are nowhere near the stent. Because now you are doing 3-dimensional thing into 2-dimensional thing. So
3 important steps are: 1, you should see the percutaneous catheter on EUS. 2, the stomach you should distend stomach full with a scope inside, and the distance between the pigtail catheter and the gastric wall should be negligible. And 3rd, inject little contrast to see that it is not, freely going into one of the space. It will just collect there. So once you have done these 3 checklists, you will invariably succeed.
And we do what Vikas Shingla first showed us, that going from the track and doing.
That's what I said. I am not talking about the radiologist because other approach is to use a TIPS. No, there you put a TIPS catheter or through the
Nasal
catheter.
scope.
Yeah, you can put a thin scope, look at the bulge there and puncture from there. That also can be done.
Last question.
Talk as always. See, I have one issue with pancreatic gastrostomy. I had faced this problem in few cases. What happens is then you place a 7 French stent. See, doing it as a bridge to surgery is fine. For example, patient is having pain, patient is nutritionally compromised, so you want to buy time. But what happens when the stent gets blocked, then sometimes it becomes difficult to replace it with another stent because generally we are ending up putting a 7 French stent. 10 French is difficult to maneuver. So what's your take on it? I mean, you will use it as a primary therapy or you will use it as a bridge therapy in most of the cases?
No, the same problem we used to face when we started early, but then we have learned that when you are creating a transmural tract, use a cautery, because once you use a cautery, that tract will remain patent for a longer period of time, and you will be able to take a wire across the stent. And the second intervention should be within 2 months. Don't wait longer to do the second intervention.
Thank you, Dr. Rana, for a excellent talk.
Thank you.
And thank you all the speakers. It was a wonderful session. Now we move on to the live transmission. Thank you so much.
I would like to thank the speakers and chairperson for their active participation in the discussion and giving their valuable inputs, which have given an edge to everyone's knowledge. This marks the end of discussion phase. This will be followed by live demonstrations and a working tea break. Now we will be going live to Medanta.
Good morning.
The next experts for the live demonstration will be Dr. G.S. Lamba sir, Dr. Gaurav Chawla, Dr. Mandhir Kumar, Dr. Sawan sir, and Dr. Sabir Hussain. Hello.
Good morning and welcome you all. And we will going to start with the live demonstration and we are going to show the nine cases. And I request to start with the Dr. Vinay Dheer room, and Dr. Jayanta is going to be with Dr. Vinay Dheer. So we can start with the history and start the room number, Dr. Vinay Dheer, room number 2.
Good morning, everyone. So our first case is a 34-year-old female without any comorbid illness, who is a known case of recurrent acute pancreatitis for the last 2 years without any history of jaundice, steatorrhea, loss of appetite, and loss of weight. Evaluated elsewhere, CT revealed the diffusely bulky pancreatic head and oncinate process, which shows homogeneous enhancement on arterial phase. The MPD is 2 mm, CBD is slightly prominent and prominent central IHBR. So the provisional diagnosis was suspicion for malignancy or focal pancreatitis. On investigation, however, the alkaline phosphatase is raised and the IgG4 is significantly raised. The patient is referred for US guided FMB. So our plan is to demonstrate the normal pancreaticobiliary anatomy and to do pancreatic FMB.
Good morning.
Good morning, sir. You are on.
Okay, thank you. Am I audible well? Can you see me well?
Yeah, we can see you. We can hear you.
So I have Jayant with me,
Hello.
standing next to me, and my job is to show you the anatomy that is relevant to
interventional EUS. So this is the only case in the whole conference that we have kept for anatomy. After this, immediately the therapeutics starts. So please concentrate on this. This is basic. This is very, very important. What I'm using is a GF UCT 180 Olympus and a EU ME3 processor. So as you know, ME3 processor is the newly launched processor by Olympus. It's a excellent processor. I've been using it, I think, for last 2 months, and I will show you why I feel it is far superior to ME2, the previous version. So let us go in and then we will take it as it is. So this may not be easy. So and you see I'm standing behind, pushing in with the EUS. I take the help of EUS. See, you can see the tongue here, and then you see the air part. Go down towards the air part. It helps me, you can see a posterior coming to the wall, posteriorly, and the tongue anteriorly, and gently millimeter by millimeter going down. And now I am at the arytenoid cartilage. This is the white line at 6 o'clock. This is the arytenoid cartilage. And next to it is thyroid. You can see the thyroid. Yes. I am still in the neck, but we can see the thyroid. Below that is the sternocleidomastoid. This is an important area. This is an important area because you will see dead nodes. Yes. Yeah. Often when we pass EUS, so we are anxious and we start checking at 23, 24 centimeters. And by that, we miss vital information. So my suggestion is use both endoscope and EUS for investigation, and then we try to go into it. Now you see the thyroid. You see the sternocleidomastoid below that, and below that is the carotid. This is a common carotid artery. We are still in the neck. You gently go in. And placed in the carotid. So this is station 1 and 2 of the mediastinal lymph node that we are seeing. See? And then we go a little more in. We place the artery gently. It should land in. This is the subclavian vein. See this? Yes, sir. This is a big subclavian vein, station 2. Yes. Yeah? Yes, sir. And below that, you are actually there is a small lymph node. You can see over there. Yes. There is a lymph node. Yes. We can biopsy this. So if I had gone straight to 23, 24, I would have missed this. So gently go in. Now here you will see two interesting things. One is the aorta. Yes. This is the left pulmonary artery. This is the IPBS. In this case, so this is the easiest way. Just turn little anti-clockwise. The traditional methods create a lot of trouble for the patient. They have to hook the scope up. So this I suggest you try it, just turn little anti-clockwise, press the carotid artery, look at the subclavian vein. This is the left pulmonary. So station 4, 5, 6, lymph node will be here. Will be finished. Yeah. Yes. So see this beautifully you can see the pulmonary artery crossing the arch of your. Yes. You will never see it the way traditionally it has been taught to look for 4, 5, 6. Now once you are in, this is another thing I quickly show you. You make a tubular view of the exam. And you can see both of them. So it is not. This is, I am making a tubular view. Yes. Is it? So you are seeing both the wall, both the walls. Okay. Oh, yeah. You are tracing the isophagus down. And you are in the B junction. This is a beautiful view of the B junction. Is it? That's a great junction. You will not see it in your traditional place. Right. So this patient seems to be having a hiatus condition. See, this is a part of the stomach above the gas coming out. Yes. This is there is a little hiatus here. Yes. This part is coming out. Yeah. Yes. And this is the stomach. Once you are in to the stomach, turn and think upward, look at the liver, go towards the edge of the liver. See this is the edge of the liver, and slowly start moving. Now you will see a long vein. This is the left portal vein. Left portal vein, you divide the liver into segment 2 and segment 3. Right. So if you want to do hepatogastroscopy, choose segment 3. Yes. Now this gives us idea about intervention. With segment 2, you can do a little bit of therapeutic procedures, but if you place a stent, it may come out through the esophagus. Yeah, and here you see the ligamentum teres. Yes. And you see the liver echo texture. See the liver echo texture appears quite okay. Also, with this any three, we can do shear wave. Yeah, let us quickly show the shear wave. Yeah, so this shear wave is a nice way of doing elastography. And at stretch of a button, you can sample one area. You see, and the shear wave is being calculated. You calculate about 10 readings from little below the surface. Okay. If you want, you can do it at multiple ways. Now you see what are the kind of readings coming? The IQR is 9.82. Maybe this is not a normal level. So next, yeah. So this is how you do a shear wave elastography. So this is the advantage of the new MEV. You can do a lot of endohepatology. Actually. Yeah. So this is now this is not a normal. Not normal. It looks normal, but it is a steep reverse. Can we also put the normal elastography here quickly? Routine elastography. We can do a routine elastography and try to show choose one area and do histogram.
Dr. Dheer, are the E values different in this as compared to a percutaneous? And
There are studies and don't have biological.
are the values comparable, or this has got a different nomogram as compared to?
So if you see here, we get a graph now. This is another thing, an histogram. It tells us that this is a heterogeneous issue, not a log. Right. So now we turn back, look towards the portal vein. Right. See this is the portal vein. Turn back, come back, patient another See, this is a hepatic vein, this is a hepatic vein.
Yes.
So this is where you do the portal pressure measurement. Anthony will tell you, look at 25 veins, right, turn clockwise, and it's the portal. Put the baby again in the portal, and then see the pressure. Patient is having a lot of veins. Can you see the higher veins? Below the portal vein? Yes. Yeah. See that in the lymph node here. So now here, you can do portal pressure measurement, and you can do elastography, you can do shear wave, so and you can do liver biopsy as you will see later. All of them are applications that we done. Now, now look at the portal vein, and below that the thin binder. Right. Bile duct is normal. See this is the bile duct. And we go a little down, we are seeing the head of the duct. The head looks very heavy. Yes. See this? The head of the duct. Very heavy. It looks like it has had a acute bacteria. Sometimes duct is regular. See this? Hyper margin is irregular. So if it is not an acute episode of appendicitis, then very suggestive of an autoimmune disease. Hypoechoic bulky folder. See this? There's fluid all around. See that? Yes. Fluid all around. If there are acute pancreatitis going on, trace it towards the vein or the vein. Yes. See here we don't hear pancreatitis. So this is the pancreatic duct. So if you want to do a pancreatic duct, hey, this is the side. Choose the side which is at the junction of neck and body, because then you get a longer function.
IBU levels are high and possible for pancreatitis. The plan is to take the FND if you feel comfortable, and then we are going to shift to the another room. So if you demonstrate the pancreatic FND, because this is one of the very important indications of suspected autoimmune pancreatitis.
If we can raise the volume of Dr. D's mic, please. It's gone down. The volume has gone down. Yeah. Now it's.
Inside, yes. A lot of good findings here. And I go into the duodenum and take biopsy from here. Right. So I'm going to go to the duodenum and take a biopsy. So the summary is primarily that the tail is atrophic. There's a lot of heterogeneity in the pancreas. The liver is slightly stiff, but there is no biliary obstruction. And the pancreatic duct seems tortuous and dilated. Right, sir? Yeah. It is bile duct, so thick wall. Yes, so thick wall. Is that correct? So this all fits into autoimmune. Very thick wall bile duct with a hyperechoic inner margin. Yes. So this all fits into an autoimmune kind of process. There's a cystic duct, no insertion of cystic duct. Anyway, so let's now show the biopsy. So we have seen the anatomy well. We have found out what is the problem. This is not a good site for puncture. See, big vessels here. So probably think lots of vessels. Okay, 22. What vessel? So you're going to use a biopsy needle. Can you tell me about it? So this is a, can just focus on this needle. This is a 22 gauge biopsy needle. And you can focus, this comes from electronic with the name of Covillium, right? So this is a 22 gauge biopsy needle. We have multiple biopsy needles of the current generation, multiple biopsy needles are there, and all of them have a design that the crown has a different design, right? So acquire will have a different design. The sharp code has an asymmetrical design, just designed like a sharp code. So here, if you can find it over here, so the design is typically like this, where you can get a good A by function. So Dr. David is going to demonstrate that. So we are using a 22 gauge sharp code. Yes, this comes from electronic. So we can take biopsy from head or body in this case, because the body is also abnormal. Right. So, but we will focus on the head because it is bulky. Let us see. Give me the needle. So for the beginners, sir, during the biopsy, what is the size of the vessel where you think it is okay? Is okay to. So large vessels, right? Avoid. If it is compulsory that you need a biopsy, make one single pass. Right. Small vessels don't work. So the advantage of this needle is that you can keep the sheath and keep changing the needle. Yes. So suppose I want to do a 19 days after this, I can just remove the needle from here and use the 19. So I am just arranging the sheet. You should see the sheet coming up. See the sheet on the ultrasound picture? Yes. So we lock it here and the sheet is coming out. We release the lock. Lock. Pull back the side slightly. And now finally position. Position should be afterwards. Position is changing with the patient, so we have to keep it fixed. Right. Now that थोड़ा action. थोड़ा scope of it. See, there is a lot of different. So the needle is out. And then, so we are inside. So this all has to be under vision, slow withdrawal, slow withdrawal. So what sir is using is a slow stylic pull technique, even focus the camera on that. Sir is using a slow stylic pull technique. So what are the usual techniques that is used for the utilization is very unstable. Yes, we are not able to rest in the neck. So you go in, intracellular, yeah? Then I withdraw, see that? Then I change direction and go again. Don't go in the same area again. Yes. Come out. So that's a classical panning technique that sir is demonstrating. Go in another area. Yes. Come back. Right. Come out. Go into another area. Use your up down control. Yes. That is the important aspect that sir is demonstrating is that for the panning technique, it's preferable to use the up down wheel rather than using the elevator. I have illustrated and then we are going to express the issue on the slide and it's. This is so. Send both the sides, all sides will prepare and then they said block it. Yes. This figure, nice figure. I think you need to move to the next room. Okay. What is the gallbladder? See that? Yes. Gallbladder beautifully clean. Yeah, any3 resolution is very, very good. Okay, I think we'll move on. Thank you. Sorry. Can you go to people?
Good morning, dear friends. I welcome you all. And I hope things are doing well and you had pleasant travel and everything is being looked after. Rajesh has put in a lot of effort to make everything work perfectly and you to enjoy your stay while you are here for these 2 days. And so I am the second opening batsman after Vinay for live demo. This is you must have been briefed. This is this was type 1 thyroid block. Elderly person, not susceptible because of comorbidity. So we are purpose is to go and create him and build him up and see whether we can bring him to a level where we can do a definitive surgery and evaluate him for kind of a disease subsequently. So for those, the ERCPs have to keep on improving now because we have a strong competition from US. Because otherwise, if you are not, as good or better, then everything will be done by through the US scope, and the people like me who only know ERCP and do not know US will be having no work to do. So for those who are the postgraduates, the first thing is how to do an ERCP. Just focus on my hand, please. See, I hold the scope in my left hand between the thumb and the index finger, and it's like a hanger, and put my palm on it, and then I'm holding the other end at least 20 centimeters behind the tip, and both the knobs, small and big knobs, are free. And I'm introducing patient is sedated, by my colleague with propofol. He's quite thin person. In elderly, be careful while you're introducing, going through the throat. Take the history of dysphagia, take the history of vomiting, because many of these patients who may be this one but could be having gastric outlet obstruction. But one clue which you will get is from the MRCP. If your stomach is not dilated, you don't have gastric outlet obstruction. So look at the gastric shadow. So what I have done is I have raised my left hand up to, so you will always face the pylorus. You won't get lost in the fundus, and you just have to progress into the duodenum. I'm cleaning the length of my throat, and I'm going beyond the angle of the first and second part. Then I'm, turning my small knob towards right, and the big knob up with my thumb, and that's how I, have focused my papilla. Now I'm not going too close to the papilla before I put in my devices, and I've created space by adjusting my big knob so that I'm not. So I evaluate the papillary orifice to decide which device to use. I have already decided now that because you see that there is a long dural part of the technology now, that I need a stop device. So I'll go with the papillary loaded with a J thermo wire, and I will calculate with the tip of the guide wire. I'll show you the difficulties which you face in calculating such patients. Yeah, slightly, we can focus that. I told you that fine tuning will be done after the device is down, because there's no point of doing it when you are pushing the device down. So there's no, you have time to do that later. So what I do make my small knob, to the right. Now this is important. You see this? This is the intradural. Papillary looks to be slightly bent on the wrong side. Now you put in the wire, sedate. See this? What do I do? Actually, this papillary is a little angulated. I might have to change it if it doesn't work. See, I'm not pushing the papillary. I'm sucking the papilla onto my device. And now I'll ask my assistant, the one who is very experienced in maneuvering and manipulating the wire, just to put in the wire so that we know whether we are the PD or we are the bilateral. If once your wire goes beyond the scope, then you are the CBD. Right? That I don't think there is any question. So see, if you choose the right axis, if you choose the right device, you don't have a problem.
We don't have the fluoro.
And now I will show you contrast-free opacification of the proximal duct. So we are going to the J curve.
We don't have the fluoroscopic picture, sir.
We still don't have the fluoro.
You're not getting fluoro there?
We are not
No, sir.
getting it.
Yeah,
Okay.
we have it now. We can, but it's a still photo.
Now can you see it?
Still, it's a still kind of picture. It's not a video.
Okay, you're not getting the right picture, and please use the camera rather than
I think now we have the floor, so we can see it.
There seems to be a tight picture. So we are not using any contrast, but we may have to use it in case. Now, in this situation, I might take over the guideline myself. So I take off the glove, and use the maneuvering of, take over the maneuvering of the guide wire myself. Floor, please. And what I do differently is nothing but little more, floor, please. The new fluoro we are not very accustomed to, but that doesn't make a difference. And then, you know, you have to come down, because what you may be struggling in the cylinder. So we will come down and go from here. Otherwise, because this was one, we can use contrast safely. That should not be a problem.
So how exactly are you maneuvering it with your hands, sir?
Show my hand, please. I'm putting that. Because the only reason there could be is that now I think we'll just inject some contrast. Give me the person. So straight wire? No. We should have the roadmap. So we'll inject some contrast, keeping the, because this is a tripod, so we have the luxury of using contrast. Inject. This looks like this figure, so we'll come back. We'll do a tracheotomy so that our entrance is easy, because in any case we have to do it so that in case we in our maneuvering we come down, we should not be losing our access to the bile. Now, see, now the one challenge which you realize that I'm having is that I'm having a eccentric position. You know what I've done? Can you understand it? I pushed the peplodrome down and was pushing the wire to the left so that I can cut in the middle. This is because the peplodrome I showed you was a little skewed. Now it will not have a problem. Okay. Because now we'll come actually down. Give me a cannula, please. And now you try. Withdraw the wire. Go in this direction. The one trick is that when you are faced like with a situation like this, you go with a balloon catheter so that you can do an occlusion angiogram which will tell you where the picture is. So get me a retrieval balloon catheter, please. Put in the wire in. Both of the bilateral. Fluoro. Take out the wire there from the top. और वो करके आप चलो. So we'll use fluid balloon. Keep the wire in, keep a room of the wire in. We'll have changed on the unhook. You see, you should remember that your spokes have a V groove if you are using Olympus 190 or 190 series, and you should elevate your elevator fully up so that you're holding the guide wire firmly, in spite of having a very experienced assistant. The responsibility of retaining the wire lies with you, not only with him. Actually, in higher blocks, this is never a major problem unless you have a very tight picture. So we'll see that. No. It's a malignant picture. There's a mark in the highlight. So now we are going with the balloon catheter. Without no. Yes, and in place. This is the testing that you see that. Here's the system. You know. We go from plate through. The plate. Come back. The plate through. So that we are right at the tip. Now you will get it. So it's just this state. So plate. How many plate through? I'll die out. See that? Now you see where the picture is. You see that it's routed, sort of a cystic space beyond which the picture goes. So now we know where it is. So take out now put in the wire, deflate it. So tip has to go not into the cystic but into the Yes, going. Now we have found the way. We can use actually a state password. That might be better. Okay, now you go to find it. Wait, just go there. Yes. No, this is good. No. Keep the O2 ready. O2 5 ready. No. O2 thermo O2 5. Once you have got a child that now you are committed to train it. Now you have no going back. Okay, give me the go to 5 and the camera. Maybe the petrol is fine with me because I can rotate it here. Okay, so keep the wire. So go to 5. That is petrol
I-
with O2 5. Thermo.
I would like to thank the experts Now we would like to invite the next experts, chairpersons. That will be Dr. Jayanta, who is already there, Dr. Harit Kothari sir, Dr. Suraj Kumar, Dr. Sandeep Goyal sir, and Dr. Piyush Ranjan sir.
Are you taken? No,
Am I audible? So we are changing the room to Professor Anthony Pure room. And I will request Dr. Nirmal to present and when he comes back, we'll Dr. Gokulas. Come over to the.
Move on to our second okay. The 36-year-old male who underwent radical total gastrectomy with dual esophageal on October 2020 for CS stoma presented with painless cholestatic jaundice for the last 20 days. On investigation, his total bilirubin was 5 and alkaline phosphate is 208. On radiological investigation, MRCP revealed moderate bilobar HBRD with abrupt cutoff of right and left hepatic duct and non-visualization of the common hepatic duct and proximal CVD. So our plan is to US guided biliary tendon.
Hi. Hello, can you hear me?
Yes, you're audible.
Yes, sir, you're audible.
Hi, so I have a difficult case here. So Dr. Biliary has just now presented the history. So patient with total gastrectomy done, and then now has suspected recurrence in the liver hilum, causing biliary obstruction. So my scope, I'm using an NE3 scope right here. You can see the image quality is much better than the NE2. I am in the ruling, so this is in the jejunum, it's not in the regular stomach. So my scope position is here. You can see the left lobe of the liver. Both segment 2 and 3 are 2 and 3 ducts are dilated. If you trace the segment 2 and 3 ducts to the almost a higher area, you can see here. There is no connection. Okay, so this is probably a lesion, probably a liver metastases, causing the obstruction of both segment 2 and segment 3 ducts. And then you trace the segment 3 all the way here. It's dilated a bit more towards the periphery, and then it's maximally dilated here. So, and of course, the right side, since the patient has a total gastrectomy, we are not able to, won't be able to access it from the US. So, what do you think are our options? So I'm Professor Theo was discussing, clearly, I mean, antigen is going to be a difficult, and maybe the intervention would be a problem. Right now, we know that it's able to drain entirely. Actually, segment 2 and 3 are also disconnected. So, yeah, the option again, we thought was maybe even SGS, when the track mature, and if required, maybe we can do a bridging stent through the SGS at a later date. But then again, the length of duct for APS is very, very limited. So, yeah, what there is tricky. So, the 7 duct is around 5.4, and the 7.2 duct is a bit more than that. What about the length of function? What's your preference? I mean, how much do you want to? Hopefully around maybe 2 centimeters for here. Okay. I'm thinking, if we puncture it, if we do HGS, my needle is probably coming from around here. Right. So we will puncture around this level. Right. But we need some landing for the HGS stent. So if I trace this up to here, it's a stricture already, so it's a very minimal amount of stuff that I can place the stent. If I go further down, I'm worried that my wire will just keep on going periphery. So try to culture from here. But I didn't do a cholangiogram, but I think this is very tight, even for HPS. So if HPS is not possible, we'll see how the wire goes around this area. If not, then we'll try to puncture the second two up and see. I mean, this is trying a bit higher. So yeah. All right. Any comments from the panel moderators?
Professor Anthony, can we sit for 2 to 3 minutes to Dr. Sood, whom he has gone across the picture?
Please.
Then we'll come back.
Yes.
We shift to the, to Dr. Sood. Dr. Sood, you are on.
So what we are, this is a very tight picture, even the pachyodome is not going across it. So we have decided that, the options in such a situation are that you can either dilate it with a PD dilator and then do a dilation with a Biliary balloon, or you can, one technique I thought we will show you is using a cystotome, which you US guys are very fond of using in punctures through EUS. We also use cystotome, to see our, to get across such tight picture. So we are going with a 7 French cystotome over a 6 French cystotome over a 425 thermo guide wire. The only trick is that you should keep your guide wire set so that it does not bend, so that you have a very coaxial, passage, and you don't create a tear or a leak. Please, you see this? Because this has gone on its own. So we'll change the wire now. Whatever. So we have on a clock, even without using the cystotome as a catheter itself is bent. The cystotome was not going, but because it has gone, we don't have to use the thermal energy. So now we will put in a stiffer guide wire, which is a rigid guide wire, because we have to use we'll use now we are going to put an exchange wire. So OC5 and then do a dilation with a 4 millimeter hurricane balloon. Always keep enough wire inside. See, when you are faced with a situation which you are faced with, what do you need to do? We need to change the device through which we were putting the guide wire, that we change to a different pachyodome, because the previous pachyodome was slightly short and was hooked to a different direction. So we were unable to go in the right direction where we wanted. And we changed from O32 thermo to O25 thermo, which goes through narrow stitches very easily. And we could, but it was still a J thermo. We could go across. Once we are across, then you have various options. One option is that you go with a pancreatic dilator for create passage and then dilate with a hurricane balloon, or you go with a cystotome. It is very tight picture, and the only condition is that you have to have a very straight and taut guide wire so that you don't create a false passage. There have been evidence of some bleeding created by the cystotome in Biliary picture approach, when they were all malignant, and the incidence is less than 2%. But you should know that, because if it happens, then you need to know how to treat it. Now we have gone across the picture with a hurricane balloon. And you see the mark, the radiopaque marker, that we are across the picture, we will dilate it.
Sir, one question, any preferences between, Sohendra Biliary Buzi dilator versus hurricane balloon?
I've not got that. So
Yeah.
Indra versus hurricane.
Yes.
Well, hurricane has the advantage that you can go right up to, now we have gone up to 12 millimeters with a single dilatation. So Indra, you would need much longer space above it to dilate up to 10. Yes, once again, yeah, we'll dilate here again. See, there was neck, but it got obliterated very quickly. Okay, so now we'll put in a 10. None of you have commented that we are not seeing the lacquer.
Any questions or comments from the audience? Anything?
If there was no mass and you are trying to figure out whether it's a benign or malignant picture, then primary cholangioscopy with the first ERCP is the answer today, because it has been shown that you can reduce the number of procedures by almost 30% if you use the cholangioscope upfront. The first ERCP to detect whether it's a malignancy or a benign picture and take a call on how to treat it.
So there's a question from Dr. Amit Singhal.
Sir, if you use a cystotome over a teremo, will it work because it's a conducting wire with no?
It works. The hydrophilic core, the internal core is nitinol, but over it is a hydrophilic, coating which is non-conducting.
So cystotome will work over a
It
teremo.
will work. We have used it earlier, but we prefer a taper wire like a Biliary or Zebra, or Jag, so that we have a more insulated, and a better insulated core wire. Now you change the picture from the auto to feed, so that you can see the scope inside the lumen very well. Now we will start releasing this stent because we are above the picture. But once you are releasing the stent, you keep observing the lower end. We have chosen an 8 centimeter stent. The problem is that this is a fluoro I'm not too used to. It has a magnification part to it. So, but I think it's the right stent. You can see this yellow mark on the endoscopy view, which which shows that the lower end where the deployed angle be. So you see the neck, the shouldering of the picture. So we are well ahead, well above the picture, and now we are going to release it and keep only about a centimeter and a half down there.
Your room to change.
The picture is small. The problem is right here. Maybe the angulation.
Yeah, you are online, Professor.
Okay. Yeah.
You are on, sir, Professor Anthony.
Over to you, Professor Anthony.
Hi, so we're back now to a patient with a highlight block. She's digestive cancer, 7-3, non-communicating. We're discussing whether we want to do HDS, hepatocytostomy versus a antigrade. So for hepatocytostomy here, the puncture site is very close to the block. So our landing site for the hepatocytostomy stent will be quite tight. But I do an antigrade stent, it means it's very hard to do subsequent intervention. So we will try to puncture the 7-3 duct first. Here it's more dilated, but it's quite periphery. So We may have difficulty passing the wire, so maybe somewhere around here. So that we have maximal amount of liver. We try to come around here. Okay, that's right. The bio, contract, X-ray. Contract, X-ray.
Can you enlarge the fluoro picture?
So we magnified it, X-ray. Zoom up, back up, okay. So you can see. The right of the left, go to it. So you can see it's very narrow, less than maybe just around 1 centimeter. Okay. Anyway, we try to pass the wire first. Can we have a signal? So any comments from the panel? X-ray. X-ray. So they're very tight. Okay. Stop. We usually have our assistant do it first. If they have difficulty, then we'll do it ourselves. Going to the other side. So I think I'm here at this picture. This is this picture, right? Very tight. What do you do to avoid shearing? Yeah, so if you really feel the shear, you can pull back the needle into the liver pancreato. Right. And disinfect the wire. Yeah, like the plastic technique. Yeah. But if you really stuck, then you have to clear everything up. So seems like I'm going on to the same duct all the time. We can always do a shift like this way to gain more distance. What do you think? I don't know. They will be able to take go back from the panel.
Any comments from the audience?
So the question is whether we should do it or not. What's the block? Dr. Beard?
Anthony, Neela over here. Why don't you just keep the wire there, loop it, and then pass a cystotome, and then try to maneuver the wire further?
Can definitely do that. You can go to the wire, and then I think it works up to work. Our then can go up.
Second question is, can you put the two stents, one in segment 2 and the other one in segment 3?
You can definitely do that, but it will limit our access to the right duct. So Of course, we can try that. Okay, that's the change.
So this is VisiGlide wire, right? Is it VisiGlide wire? Yeah. So did you try with Terumo first?
No, I tried to remove it, but for me, I always go to the multiply. For me, it's better.
Okay. That's because you are using new wire every time.
You can do a angle to remove as well. Yeah.
Sridhar, was this a bismuth type 4? Sridhar? Sadipta here. Was this a bismuth type 4?
It's actually from gastric cancer, the pathogen, so. Yeah.
It's yeah. So yeah, but it's almost like all the ducts are disconnected. In these circumstances, would PTBD be a safer option instead of an EUSBD?
I think I and you had that discussion.
What are the chances of cholangitis, and if cholangitis occurs, what would you do?
Even if you do a single balloon ERCP, for example, I train the right up.
Okay. What is the performance status of this patient?
Very young guy.
Okay. And then you must be seeing a lot of gastric cancers. Has chemotherapy evolved? Because if you have such an aggressive disease, you take biopsy and you do various studies, can we do targeted chemotherapy nowadays?
Yeah, I think gastric cancer first line still a 5-AU ovarian campaign. But of course, immune.
Yeah, I'm talking about immune therapy, depending on some markers and then give immune therapy.
All right, I'm ready for see how it goes. Okay.
For metastatic disease, you always do HER2 new and then see.
Yeah.
You can use that. So
Yeah, HER2 is very important. Yeah.
So
even in
that is-
esophageal cancers nowadays,
Yeah.
they do that and give targeted
for
immunotherapy.
gastric, this thing HER2 new is specifically important. So, I mean, Anthony, does this patient have cholangitis? I mean, to begin with, does this patient have cholangitis?
Is the cystotome not working because it's VisiGlide?
Maybe using an angled Terumo would be a better option. You can probably rotate it down.
All right. Questions? Change? Contract, Gaurav?
Sridhar, what are the current settings?
What about 120 watts? So which kind of performance? end of next. So immediately I will discuss for maybe network expert I guess.
See, I never use Visiglide if I am using cystotome. One, it is not fully insulated. Second, if you change the axis, your cystotome will never go. So it was another cystotome before. Okay.
See whether it's a system issue or guideline issue, but right now it's not even moving a little bit, so it's a little bit unusual. Even for, do you think it's a system issue? I mean, do you think it's a?
Yeah, I think it's a guide wire issue and cystotome too. And you can reduce the current to 100 because 120, it should not happen that it peels off the outer layer of Visiglide.
I'm still at the wall.
It's gone. Yeah.
Yeah. Okay. Yeah. And Gaurav, please.
The next case.
Okay.
Room number.
Gaurav, please.
Let's do that. Room number 2. You are online. You are online. Room number 2. Yeah, you are online.
Hi, Pankaj, we can see you. We can't hear you.
Dr. Pankaj voice is not audible here.
You can go inside for some time.
Hello. Next is non-alcoholic without a comorbid basically complaints of pain, the right upper body last 2 years without any issue of chronic vomiting or undergo. Here we found to raise liver index on multiple occasions. In the routine investigation, is the AST and ALT, they are raised 178 and 128, and triglyceride is high. And viral markers, they are negative. On autoimmune profile investigation, ANA was negative, asthma, FCN, they were negative, IgG total was in normal limit, cellular was in normal. Ultrasound revealed only grade 2 fatty liver, total brain and liver they are all as normal. And MRI raises perfusion of RCLD. For which fibroscan was done, fibroscan shows cap of 200 and KP value of 8.8. So the patient was in the case of transaminases under evaluation, probably next, the plan is to do US guided liver value.
The fibroscan values do not support that. The cap is 200.
Thank you. Yes, sir. Only triglyceride is high. After doing the US guided.
But your sonography shows cirrhosis actually. When you have Kodetlov enlargement, it is almost always cirrhosis. You are saying Kodetlov is enlarged. So there is some discrepancy between the fibroscan and
The CT scan, MRI finding, I know it is not going to that is the reason because.
yeah, it's liver biopsy is absolutely indicated. Yeah.
So why choosing a US guided biopsy over a per
celiac block, not utilized because this is a benign lesion. Normally, I use the surgical approach. We're just injecting here at the base, just here at the base of the celiac trunk. So we have the right. This is a very open question. What do you think? So we have. We will ask you. We will ask the chair a question. We have two options. Either to try to put my needle just here. I'm using normally for the celiac block a cooked needle, a spray needle, which is a CPN needle, which accommodate right and left holes. This is a scenario. Or we have a very good other option we need to discuss with you, is to first of all aspirate this small collection to be able even to inject better. So what's your opinion? We need to take the opinion of the chairperson.
So which patients of chronic pancreatitis would you
the
advise
patient had
for
chronic pancreatitis.
celiac access block?
Yeah, aspiration, this small cyst, not its cyst, it's a WON actually. It has some necrosis and there is some fluid. Putting a needle will definitely give you infection. Putting a needle into the so-called celiac plexus also is dangerous over here because you are going to put steroid. So chances of infections are how much?
So what? So yeah. So what's the chair opinion? So sure, I will personally. I'm thinking not to aspirate this. We have a space here where I put my arrow now that I can inject. For example, and then I will show you a little bit. So we have the liver here, and if we torque a little bit, also we have a lot of collaterals. I will just go a little bit deep. If I go to the spleen side, you can see this is splenic hilum with a lot also of collateral. So this is very clear, and you can see the body of the pancreas just here. I will have a better picture in 1 second. Yes, with a dilated duct. So the duct is dilated. Is
Does
just
this
here.
patient have PD stent in place? That
So
stent
it's
is not
a
there.
patient with a severe chronic pancreatitis with at the celiac at just the area of the celiac trunk. We have this collection. So what do you think? We should start.
I think hope I'm audible.
Yes.
The problem is not only, I mean, we can do a celiac block, but the patient has various issues here. He has perhaps a lower CBD stricture also as mentioned, and has collections. So merely putting a block may not help this patient, and it is anyway going to be a temporary measure.
Yes.
And if you see the stomach wall and surrounding, there is some component of acute pancreatitis. So this is basically an acute on chronic pancreatitis.
Yes.
I
Yes.
would not do anything. I would just give patients oral analgesics and keep this patient under conservative management.
So this is another option to do nothing. You mean, huh?
Yeah, I think I would not touch this patient.
Definitely.
Are we all right?
This patient has got an element of acute pancreatitis.
Can you hear us?
Should be left alone for the time being.
Yes.
Okay. So hello, can you hear us? Yes, you are on. And
Right, so we try to cannulate the hilar
just a
area.
minute. We can see you, we can hear you, but nothing else. Just the Olympus scope. No EUS image, nothing. Now we
Please
can.
show the-
Now, yes. No fluid.
So just now, we were
EUS.
able to cannulate the hilar area, and we showed some contrast of the right duct. So we tried to
Can we
manipulate
have
the wire
fluoro
to,
image, please? IITV image, please.
we
And
tried to manipulate the wire to the right duct, but
and we are seeing external image of the other case. Can you just take it out? Oh, that's great.
so Nile, so can you see some contrast below?
Yes, we can. We
You know, and also a little bit of contrast in the right duct.
Yes.
So we were trying to negotiate through that area, but we're not sure where we are. So we were.
at
So
least-
finally, the
But
why
at
we
least your
decided
marker
to,
is in the liver, so you are good. That uncovered marker is in the liver. It's not. Yeah. So
but we were saying the landing site is very short. So in fact, if you see from the furrow, the uncovered portion is much longer than our landing site. So I think this position is quite good. So we're going to open the stent. Okay, open.
To your room.
In fact, it will go in, right, when you are deploying the stent.
Yeah, I think in this case, okay, stop.
Yeah, it is, it is. So you are
In this
good.
case, you may not be able to go to the right side.
I think we should not do nothing. What do you say?
Just here.
So Anthony, that was the uncovered part, right? That you are at the marker where
yes.
the uncovered
My
part
feeling
ends
there
and
is
the
a
covered part
inflammation,
starts.
risk of
So
infection
is
very
it true?
high.
Yes.
My feeling
yes.
is.
The middle marker is the uncovered
My
portion
feeling
at
is,
the airport.
No, it's not the middle marker. It is 70,
This
30.
is still 3/4.
Yeah.
Okay,
The-
so my stand is
Better
completely open. I'm gonna push up from the,
So can we have the endoscopy picture now, please?
Yeah, we are showing the endoscopy picture.
I agree. You can show this and this.
Sura, please.
Agreed.
Please endo picture, please. It's just the EUS picture. We want endoscopic image in endoscopic picture.
Patient आ गया? जो भी चाहिए उनको.
Rajesh.
can you see the endoscopic picture?
चलो बहुत.
No, we don't. We are just seeing EUS picture, not the endoscopy picture. Rajesh, you are heard over here.
Can you show the endoscopy picture, please? Endoscopy picture, please.
Endoscopic picture?
Yeah, we're still not getting it.
Yeah.
Either don't take out the stent, huh? We are not seeing endoscopy picture. We want to see.
Yeah. So
We are waiting
Yes,
for you.
now.
waiting
now-
for you.
No, I think we are seeing the other room right now with that WON and aorta and celiac. We want Anthony and Sridhar's room, endo and EUS picture, not the other room. Now we are seeing Anthony's EUS picture, but not the endo picture. Why don't you just start PIP? No, don't change the room.
We've already made.
Abhi, start PIP. Someone on the processor, press 1. Press 1.
देखो वापस करके. हाँ.
Can you see now?
Can you see now?
Can you see it?
No, we cannot see the endo picture. We are seeing the US picture.
How about now? What are
Now?
you seeing?
No, we are not seeing endo picture.
How about the US? Are you seeing the US?
Yeah, just EUS picture.
Only US, no
Only
endoscopic.
EUS. Not you, not endo.
Okay.
And EUS because you are now away. So again, we do see gastric wall and also part of the stent, 1 centimeter of the stent.
So can you see it now? The
No endo
Endoscopy
picture.
picture?
No endo
No, no,
picture.
not yet, not yet.
Not yet? Okay. Someone can help us, please?
Now we see your fluoro picture. Can't you do PIP in endo so EUS becomes smaller and
we did already.
We're not seeing the US
It
picture.
doesn't
actually.
work.
okay. So we are just seeing the EUS picture.
Ah.
So we should restart here.
Please change the room.
They are still discussing the other case.
क्योंकि वो online है यहाँ से. Mustafa. Professor Mustafa, you are online, please. Professor Mustafa, you are online. Professor Mustafa, you are online.
Yes, I'm ready. Okay, could you show my EOS picture? Yes.
Come on, last step.
The one with the Doppler image. Yes, this one. Okay. the plan, as you heard, that it was to do celiac block, and just I feed this picture, so you can see the aorta here, and this is the start of the celiac trunk. Normally, if I do celiac block, I inject here in this area using a CPN needle or a 19 gauge needle, my mixture of solution here. But the problem, especially in this patient, that we think that this patient pain is not due to the chronic pancreatitis, which I'm going to show you. It's more about this necrotic area. So I will just show you this again. So this is celiac trunk, and this is the aorta, and this is where I should inject. So we were thinking here, to be honest, that this is maybe more of the problem here of this patient is more of the inflammatory necrotic area here. This is causing him pain. So I will vote for not to inject, to be honest, anything here, because there is a risk of, if I inject in this area, there is a risk of increasing of this necrosis. There was another idea to aspirate first this necrotic
Why don't
area,
you
and
just
then
aspirate the necrotic area?
yes. So, however, this is very controversial. If I aspirate here, I will have an area to inject, yes. On the other side, there is also the risk of increasing infection. So what do you think?
Patient apparently.
So the fluoroscopy.
Main problem is pain.
Deployment.
Yeah, then we could have aspirated and sent the material for culture and other.
Professor Mustafa,
Yes.
in which patients of chronic pancreatitis with pain will you advise celiac plexus block?
So
which
it is
subsets?
the typical patient that the patient had a chronic pancreatitis without necrosis, that is already not responding on analgesia, morphine, everything. Normally, I will do for him the celiac block. And the very important message I would tell the patient before, that this should be repeated. It's something not only one time. I always repeat it every day, be it 3-4 months. I use a CPN needle.
You are on, sir. Hi, so let's go. Let's just use the X-ray fluoroscopy for deployment, because I don't think we can. Oh, you see it?
Can you see the endoscopy view?
Yeah, we can see the endoscopy view.
Great.
So actually, we are deploying here. Okay, fluoroscopy.
Can you?
Okay, I'm pushing the stand out a little bit.
This is like an intra-channel deployment. So
you can see this is the stand here.
Yeah, we can see now. Yeah.
I'm going to push out the stand slightly, pull back the scope.
So can you tell us how you are deploying this stand? That is very
Push out the stand slightly.
Okay.
And then pull back the scope. You can see my stand now.
Yeah.
Push out the stand more. Pull back the scope.
So
push out the stand more.
Actually, it's open in the scope channel, right?
Yes, intrascope deployment. Yeah.
Okay.
So up to a certain point, I think we can just push out the entire stand. Okay.
Yeah.
All right. Okay, let's do a cholangiogram, sister. Why?
You can inject.
Oh, okay.
Yeah.
Okay, inject. Okay.
Yeah, I think the wire is a hinge.
Okay, so we're gonna do a quick cholangiogram because I always do that.
Yeah. Okay, great.
Okay, so no leak.
No leak. Yeah.
All right.
Yeah.
Okay,
Great.
looks good.
Excellent.
Okay, back to the chronic pancreatitis patient. So as I said, so the plan was to do the celiac block in this area. I just show you the needle which normally I use is the Cook needle, the CPN needle, a 20 gauge CPN needle, which accommodates lateral holes normally, because I use the central approach. So I will put theoretically my needle here and then do the central approach. I inject 15 to 20 milliliter of bupivacaine. However, I don't think that we should do this in this patient, because this patient pain is due to this necrotic area more than the chronic pancreatitis. So what do you think? I would love to hear I will just continue examination a little bit so you can see this is the body of the pancreas where chronic pancreatitis and dilated duct. However, if I torque a little bit clockwise, pulling back by scope a little bit, you see the spleen and the splenic hilum with collaterals. And when we go back to the aorta here, and then we see this collection just at the area of the celiac trunk. So my opinion, my message that yes, this patient is indicated if it doesn't have this necrotic area.
Case of diabetes, hypertension, CDM, medical.
If you are able to do that, then for how long you expect this block is likely to work?
I don't think we are on.
You can hear us or not?
If you happen to do that, for how long this block is going to work with this patient? In a normal patient, not in this patient, because you are not performing the procedure. For how long the block is going to act?
Mustafa's room? Hello.
Professor Mustafa, let me put this way, like what will be the durability for the celiac plexus block in terms of relief of
They are
pain?
asking if at all we would have done this, how long will it last?
3 months. 3 months, I will repeat it every 3-4 months. However, as I said, there is a very high risk in this patient because of this necrotic area that you can really increase the necrosis. So the patient pain in this patient is not due to the chronic pancreatitis. It's mainly due to the compression of the celiac ganglia by this fluid collection necrotic area. You can see now just lateral to the celiac trunk.
So
what is the underlying etiology here? Is this alcohol-related pancreatitis that we are dealing with here?
Yes.
So do you think this patient is having ongoing acute or chronic pancreatitis and
Yes.
repeated attacks because of ongoing alcohol use? In which
I
case,
totally agree.
and
Yes.
and I think probably that should be the one we tackle first before we tackle the fluid collections, because with ongoing alcohol use, this gentleman is having recurrent episodes of pancreatitis.
Yes, I totally agree. So this is why my decision is not to aspirate this fluid. This is really we will infect it. And the other thing, not to do the celiac block, because if I do the celiac block in this area with this collection, number one, the patient will not really have any advantage because of I will increase the necrosis in this area, and plus technically the collection is in the same area where I should inject.
So I think the decision is okay and we will not do.
Yes.
And we start with the Dr. Vipul case.
Okay.
And I request Dr. Bimal to present the history, please.
I just want to thank our chairpersons and I'd like to
next
call our
present
next
is
set of
63 year-
chairpersons, Dr. Sanjay Khanna, Dr. Arvind Kurana, Dr. Amit Singhal, Dr. Ashok Janjiria.
So our
Sir,
next
please
case is a
behave.
63-year-old female who presented with pain abdomen since 2016 with significant loss of weight and loss of appetite. No history of any fever. And PET CT shows multiple mediastinal and abdominal FDG-avid lymph nodes. IR guided FNAC done twice, but the results were non-contributory. So our plan was to do US guided FNB of the abdominal lymph node.
Yes, you are on, sir.
Dr. Bipul, you are on.
Okay. Good afternoon, ladies and gentlemen. Thank you, Rajesh, for the opportunity. I'm sure you heard the history, and I'm seeing some lymph nodes here. I'm in the duodenum, and you can see the portal vein. You can see the bile duct here. Can I have a cursor? Cursor? Pointer. Okay. So here is the bile duct here and the pancreatic duct here. And you can see the portal vein. So there is some periportal lymph nodes I could see. These are the lymph nodes.
Hello.
And this patient does not have a diagnosis as of yet
Hello.
as to why she is having fever. I was also told that there are lymph nodes in the mediastinum.
सेट करनी पड़ती
So let us see.
तुरंत
You're helping me? Okay.
रिमोट में थोड़ी ना
So there are some lymph nodes in the
select करना पड़ता
mediastinum.
है।
This is pancreas.
बता दो ना कि ऐसे थोड़ी
I
ना
can
होता
see
है।
pancreas little hypoechoic. क्या किया आपने? हाँ? सेटिंग चेंज किया। हाँ तो कॉन्ट्रास्ट बढ़ा दो, थोड़ा डार्क कर दो। So I'm not able to see any lymph nodes here. There's pancreatic, little bulky pancreas. Huh? And now I'm seeing the mediastinum. So we are seeing the chamber, the left atrium, and now I'm flipping my scope all the way to the aorta. I'm not able to see much lymph node subcarinal. I'm coming up and I can see huge lymph nodes in this area. See this? Mediastinal nodes and with some amount of necrosis here. So I've seen porta nodes, I've seen aortocaval nodes, but looking at this lymph node, I will go for a mediastinal node, okay? So I want 7.5 megahertz.
Vipul, how would you decide whether to take Vipul?
Sorry?
I'm Nilay over here. How would you decide whether to take biopsy from mediastinal node or from the abdominal node?
See, what I realize is that patient has pyrexia of unknown origin. Patient has diffuse hypoechoic node in the porta and the or aortocaval area, but they are small nodes. Here I can see in the mediastinum a conglomerate of nodes with some necrosis, and patient with pyrexia of unknown origin in India. We have to suspect.
I agree with you, but how would you decide that you want to take biopsy from mediastinal node and not that hepatogastric node which you showed just now, which also was a big one? So any lymph node is fine, or this is better.
So Nilay, this is the conglomerate of node with some necrotic material. So I may get some material for culture also, and also for we will get something for proper histology. So I'm going to use a 20 gauge Procore needle from the mediastinum. Can you open the 20 gauge? And I want magnification a little bit here.
Dr. Vipul, wouldn't it be better to take biopsy from both the nodes?
Sorry?
Can we take biopsy from both the nodes?
Well, we can take, but I'll first target this node because I'm given very limited time here by Rajesh. So I will first target this node and then go to the.
Yeah, that's okay. No,
using a Procore needle with biopsy, with histology, immunohistochemistry, culture, and whatever TB related investigation we need. Open.
So why Procore and not why FNB needle? Why Procore and not any other FNB needle?
Because we want histology, we want immunohistochemistry, and as I mentioned, why I'll tell you the reason. Since 1999, I've been having first time FNA happened in the nation of this part of the world. I've learned lessons through that. And therefore, I'm using a needle, which is a standard needle. It is a large node. I need histology. I need cytology. I need fluid, everything in one needle. And therefore, I'm using it. Okay, so no conflict of interest with any of the companies, but I feel this is the best needle currently for me, for my work. And I think it is very flexible, and it is so what I need also, as you saw, the hepatogastric ligament node is a very, very round node, and it would not measure maybe around 1.8 to 2 centimeter. Here what I'm doing is I'm locking the up and down wheel. Beta, isko barabar pakdo. No, I will remove it. I'll remove it. So now I'm coming down. My sheath will come down here. Okay. The sheath will come down here. Yes, the sheath is here. And what I'll do is a conglomerate of nodes. So I'll puncture one node and then the second node and the third node in one go. Okay, let us see if we can do that. Okay, now wait. Now I'm going to puncture the second node. Okay, wait here. I'm going to puncture the second node. See, in the long trajectory, I'm gone to the third node. This is the beauty, and I'll show you how beautifully you can see the aspirate. Magnify it. Magnify for me. One more magnification. That's it. A little less, one less. Okay, so now you can see this Procore needle is there. I'm putting the stylet in. Take out the stylet. Get a negative pressure. See, a lot of talk of suction, no suction. Believe me, I'm talking of experience of 24 years of aspiration. 24 years of thousands of aspiration. Believe me, I have always used a suction needle, and it has worked for my patient. ये नेगेटिव नहीं किया था पक्का नहीं वापस करके करो वापस करो लॉक करो इसको यहाँ लॉक करो बेटा हाँ अभी नेगेटिव करो आई विल चेक फॉर माई सेल्फ लगा दो अभी लगा दो so what you can do when you have a conglomerate of node you can puncture all in one line and you start aspirating okay see I'm going to go little deeper see that how deep you go and you can see the aspiration happening can you see the aspiration happening when you see the parallel lines of the needle this is a 20 gauge needle guys so it is better in between 20 and 19 believe me 22 and 19 ke beech mein hai ye so this is probably one of the finest needles I think I have come across so far and I use it very very regularly for my aspirate work irrespective lymph node large lymph node pancreatic head tumors and we are just going to have a quick evaluation whether aspiration is happening or not and see I'm doing the fanning technique so see what I do I go up I change the trajectory I go down come to the center I go down I go to the periphery of the lymph node okay so this is called the fanning technique at the lymph node I'm just going to aspirate and then let's see whether aspiration has stopped so within the channel I can see that if aspiration has stopped then we will stop here we'll take off the needle quickly sheath back so essentially EUS FNB is a 5-minute job actually once you master it so let us see what material we have if there are any questions I am willing to take but let me tell you FNB is the future not FNAC I want a histology bottle yeah can you push the needle को push करो stylet नहीं needle को push करो okay start pushing
So are you collecting specimen in saline or formalin?
wait I am taking directly the specimen in formalin look at the core you get beautiful core wait okay so I will take ले लो हो गया एक में हो गया you don't need any other FNAB I will still go and get from the gastrohepatic ligament but they can go off air no problem stop now I'll take some slides for cytology also just in case I do always histology and cytology together for all patients always the same nil थोड़ा flush कर दो बेटा थोड़ा
So our next case is a 72-year-old female weeks on investigation there is circumferential mural thickening of the pylorus of the stomach with multiple perigastric and retroperitoneal lymph nodes ultrasound revealed ulcerative growth at pylorus and it was not negotiable with scope biopsy suggestive adenocarcinoma so the patient is unfit for surgery due to poor ECOG status patient is planned for USGJ
Hi. With me is Jayanta. Praveer is hiding behind. He's trying to hide. Yeah, Flora, please. And so as you heard the story, this lady has gastric outlet obstruction because of carcinoma of stomach. Can we turn it the floor other way around? Laterally invert kar sakte? No. एक और घुमा third.
Sandeep.
Just a minute, please.
So can we do till Sandeep is putting the tube? We can start Dr. Amol Bapai room.
Left, right. Yeah, that's better. Thank you. एक बार पूरा वायर टिप से दिखाती हैं
Dr. Sandeep.
Yes, Rajesh.
Till you are putting the tube, can we start Dr. Amol Bapai room?
Yes, please go ahead.
विमल को बोलो
डीप है ना हमारा
हाँ बस ठीक है, हाँ और डीप कर दे यार, बहुत अच्छा है, जितना डीप जाए उतना अच्छा है।
डॉक्टर बिमल को बोलो बोल रहे हैं।
So our next case is 71-year-old female without any comorbid
एक मिनट।
illness,
हाँ step.
presented with painless progressive jaundice with loss of appetite and loss of weight associated with non-projectile non-bilious vomiting. Investigation shows CA99 of 785 and C of 79.8. And on radiological investigation, a heterogeneous enhancing soft tissue lesion of approximately 38 and 25 mm is seen in the periampullary region, causing abrupt cutoff of the terminal end of CBD with upstream dilatation and dilated MPD with multiple enlarged abdominal lymph nodes. And side viewing endoscopy shows a large mass at the papilla. So the plan is ERCP with biliary SMS placement. If the plan fails, then our second plan is US guided antegrade biliary drainage.
Dr. Amol Bapai, Dr. Amol, please start the case.
It has to go down only, no? The tip of the wire jahan pe. I think I've looped in the last loop.
Amol, you are seen. Pankaj, you are seen.
Our loop, I think I'll pull back.
But we can't hear you, Amol.
Okay, I am
Now
trying
we
to
can.
speak.
Now we can.
Okay. So Nilay, are you getting the endoscopy image?
No.
Okay, can somebody give the endoscopy image? I'm still
Now
not
we
in
can,
the
now
right
we
now.
can see the endoscopy image. You are at the pylorus. We can see
Yes.
that.
So I am at the pylorus. I'm just getting the scope inside. You saw the history. Now, actually speaking, I was supposed to do an direct EUS guided procedure in this lady, but I think it's always good to try with an ERCP before, doing a primary EUS guided procedure. So we will attempt doing an EUS guided an ERCP. But if we fail, then we may have to go ahead with the EUSBD. So let's see.
Amol, they told us that the plan is put a biliary metal stent. This is an.
Nila, I can't hear you very well.
Yeah.
I can't hear you very well.
So now can I? Now do you hear me properly?
Yeah, I can hear
Okay.
you.
So the plan which we were told was to put a biliary SEMS. This is a bulky ampullary tumor. Would
Yes.
you use a SEMS or just a plastic stent would suffice?
Nila, now she is probably inoperable because she is quite frail and she's got lymph nodes. So she's going to require a long-term palliation. I agree that sometimes definitely not an uncovered stent. If at all we have to use a fully covered stent, and there also the chances that the fully covered stent can migrate is quite high. So I agree with you that sometimes the 10 French stent also works better.
Yeah,
in these
and more than
situations.
that, plastic stent works for years together in ampullary
It can
tumor.
sometimes, yes, it can work well. So now this is, are you getting the image of the papilla?
Dr. Amol, submit this side. See, I know there's a debate in the afternoon on this topic. See, you have extensive growth where chances of getting access as well as problem like bleeding is more likely, and even pancreatitis. Don't you think primary EUS guided biliary drainage in this case specifically would have been much better with a very limited time attempt at ERCP? What do you think? If I mean, because of the morphology.
I think there is, if you look at the program, we are coming up with a debate at 4 o'clock. So I would prefer to answer your question at that time rather than just now.
Amol, before you touch that ampulla, please tell us what you are going to do, where you are going to poke for the orifice.
Nilay, I was hoping that you tell me where I should poke, but now that you are asking
push
me,
the scope. First, you push the scope. Show us.
No, yes. Yeah. So I'm going to definitely inspect the papilla first. Now, in this kind of a situation, when there is a proliferative growth of the papilla, it is important that you should not hurriedly begin your attempt at cannulation. You should inspect the papilla completely. You should inspect the tumor completely. Here you can see that the tumor is going almost down up to the D3 level and also involving the uncinate, that kind of a thing. Now I am coming up. Now I am also going to look at the bulging portion of the intramural bile duct. Now this is the bulging portion of the intramural bile duct, and that is something which might give me some direction as to where I should.
But when you are touching, it looks like the tumor is in the bile duct too, because when you
Yes.
touch, you can feel the tumor.
Yes, but it is a relatively soft tumor. So I have Pankaj with me, and Pankaj and I, we are going to debate, and I agree to a certain extent that I would not try with a cannulation for too long in this kind of a case. If in the first 5 to 10 minutes we cannot get into the bile duct, and if the tumor is very friable and starts oozing, then probably it is a good time to shift to a EUS guided procedure or an alternative procedure.
Yeah, if you are planning US guided procedure, would you do CDS or you would do anti-grade?
I would do do a CDS here.
Yeah.
Yeah. So has Buscopan been given to this patient? Okay, because there's still some quite a bit
Delay.
of peristalsis.
Yeah.
Yeah. Usually in such cases, the best chance of finding your biliary orifice is at the junction where you see the normal bulging mucosa and the tumor margin.
So probably, yeah. What you see over is papillary epithelium or it's a tumor?
This is a tumor.
Yeah.
This is a tumor. Yeah. Now, most likely we will try over here. This is what, these two areas, the ear or then over here, are the most likely two areas where we are going to hopefully get the papillary opening. Let me see now. So gently I'm going to ask Ashwini to bow the sphincterdome. Don't push the wire too early. Okay, I'm just going to try and see if we can get an access and entry. Okay, now bend karo thoda, bow karo. Okay, let us see. And I push my scope down and let us see. Okay, no. Okay, slipped. I think I will try on this side. Here it appears to be more firm. थोड़ा सिर आगे करो.
Scope पकड़ लेना एक बार. थोड़ा सा scope पकड़ लेना. Position.
I'm going to try over here. Wait, थोड़ा पानी मार दो.
Can you try between those papillary projections with
Yes, that is where I'm just going to probe and see. Now, most likely here. Now, can you bow the sphincterdome? Bow karo, bend karo, thoda sa. Okay. Okay.
I think you are in.
Let's see.
No, you will come out.
Yeah, I'm coming out
Yeah.
over here.
I think that is the
bulging portion.
polypoid lesion
Polypoidal
is
lesion.
coming out. So
But-
probably try from
Probably I could also see a drop of bile over there. So I'm going to change the direction, go in the same direction, but probably change the direction and see if we are lucky. Bend karo, or bend karo, or bend karo.
We are not seeing any fluoro picture, huh?
No, we have not.
Oh, you have not started. Okay.
Not started it yet.
ऊपर में पकड़ो. ऊपर नहीं.
So do you feel that with this kind of a tumor in place, transluminal stent, again, an US guided, the same, debate would be better for long-term patency?
Okay, now just.
I am holding.
Okay,
Can we
fluoro.
have the fluoro, please? Can you try wire?
क्या wire try करोगे?
It is going somewhere. No.
नहीं जा रहा है.
Hitting. Can you show the fluoro to them?
Can you enlarge the fluoro image?
Okay.
Now we see only fluoro picture, no endoscopy. Now we see small endoscopy picture.
Bend.
Bend करो पूरा full bend करो.
Okay. Try
अभी
now.
देखो.
Fluoro.
नहीं एक काम करो अभी unbend करो धीरे. Okay. अभी देखो.
Fluoro, please. Wire.
Fluoro on. Yeah.
Perum है कौन सा है wire?
करूँ. देखो. अभी देखो.
So you are trying to change the direction.
No, wire is coming out from here. So unbend. Yeah. So wire is coming out of the
Can
proliferative
you
tumor.
just go up
Yeah, I'm going to go on the fold now and try and go
where the
between
wire
the
is?
fold. That area is a little bit too lateral Nilay, for my liking. Yes,
Can we shift to Dr. Sandeep Lakhtakia room?
I am okay, no problem.
Not on, just a bit right. Yeah.
Dr. Sandeep is online.
But we are still having Amol's room. Yeah.
Okay. Now बीच में ना contrast डालेंगे इस पे से
Sandeep, we are back with you.
हाँ ऐसे डालना contrast.
We are back with you. Please
Nilay,
tell
you
us
have
what
the-
you did.
Nila, you have the fluoro image?
Yes, we have the.
So you can see on the screen, there are two balloons which are filled with contrast. This is called as E-pass balloon or occluder balloon, which is made by Takao Itoe, and he has lent these balloons to us to do GJs. Which Vinay and Anthony T also have a lot of experience in this procedure. हाँ इसमें contrast डालेंगे. So एक मिनट रुकेंगे, एक मिनट, just hold on for a second. So what we have done before it, before we came on the screen, we did an endoscopy to check how the stomach is. It was clean, and the blockage is because of gastric antral malignancy, which is a very tight malignancy, and the wire went with little difficulty, but we were able to cross it. Once we passed the guide wire deep inside beyond the DJ flexure, we injected little bit of contrast that you can see on the X-ray also to see how the loop is. Because sometimes we find surprises during the procedure of malrotations. We wanted to be doubly sure on how deep we are going. Then we exchanged to a long wire, 450 centimeter standard jag wire was used. And then over the jag wire, we passed this E-pass balloon. This E-pass balloon is a very floppy balloon. If the cameraman can show here, or I can just lift it up. So what I'm holding, you have the room camera?
Yes, we can see.
So what I'm holding is a over tube, which is a over tube borrowed from the enteroscopy, the short single balloon enteroscopy, which allows the endoscope to go in. So it has a balloon in front that's not of any use. The short over tube takes the scope. So we go with the over tube and the endoscope together as one assembly, go till the proximal end of the stricture, cannulate the stricture, pass the guide wire deep inside. The purpose of the over tube is only one, because this E-pass balloon, which is about 2 meters long, is very floppy, and it happens to coil in the stomach. So if you are not using over tube, it will coil in the stomach and we will not be able to cross the stricture. So the purpose is only to allow to the E-pass balloon to go across. The double balloon assembly should go across. Having done that, now I pulled it back, but it's hanging on the over tube because we also other end is that it can't come out now. Now we have the E-pass balloon in position, which you can see on the X-ray. It's across the DJ flexure. The lead balls at the tip, about 5 centimeters behind that is a forward balloon, and the other balloon is in the D3 area, which is a back balloon. Between the two balloons is about 20 centimeter segment, which will now fill with contrast. So can you inject some contrast? So this is basically trapped a small bowel loop. Inject, please. So that becomes a target organ. You can see the contrast getting filled up.
Yes, we can.
So this is a trapped segment of the bowel around the DJ flexure. So we will fill it about 100 cc straight away.
Sandeep?
Methylene blue.
Yeah, methylene. The solution after contrast should be methylene blue and saline, and we can now inject some glucagon or a buscopan, please. Let the endoscope be ready. EUS scope is ready now. We can keep it ready, and the stent is also ready.
Dr. Sandeep?
So while everything is getting, yes, Rajesh.
Just want to know what is the advantage of this over metallic stenting? If you go simple SEM stenting, enter stenting, what is the advantage of this?
I'm sorry.
So he is asking why to do EUS-GJ and not just put an enteral stent.
That's a different debate altogether. I think that's a theoretical debate we will discuss in the hall when we meet next. But I think current aim is to show the procedure and how it can be done safely. There are several ways to skin a cat, and same is for GJ.
What is the position of the patient?
The patient is prone, not intubated, under good sedation, and she's lying very comfortably with everything in control. We'll put the
Any
pad now.
specific reason why you want the patient in prone and not supine?
Nila, you have very pointed questions. So So Nila, the reason I prefer prone is that it kind of compresses the stomach, and I can also do in supine, but sometimes there's a risk of aspiration, then we need to intubate. I prefer prone for avoiding the risk of aspiration and compressing the anteroposterior wall.
It somehow fixes the stomach.
Yeah. So how much have you put in?
50 only.
50. Oh, okay. So anyway, that keeps going on, and I'm ready now. Buscopan has been given, please, and so I'm inserting now the EUS scope, and stent is open, ready. Keep it.
So which stent you will
20 mm Axios, hot Axios. It's only hot Axios, and that's it.
You use 20 mm hot spexes. Any experience with that?
I don't have personal experience with. I had only once I had used in a conference, and it's also very decent stent. It can be placed. It has to be a hot system, not a cold system. What I meant to say was.
Lamps should be hot nowadays,
Yeah.
right?
Can I have the EUS image?
US image.
On the screen, you have the.
Yeah, we have the US image now.
Acha, you
So we
got it
can
before.
see you, and we have the US image.
And the pointer is here, and I'll just park in this D. That's my parking space for the right left is okay, because I'm in Rajesh territory. There are a lot of lymph nodes you can see there.
Yes, and they look
Pre-aortic
pathological
lymph nodes. And they look pathological, yes. And I'm trying to find the loop of the bowel. Fluoro, please. Can I have the fluoro? So this is the, I can see the tube also. So that's
Yes.
the tube and the distended loop. And I can cross-check on fluoroscopy. So I'm using both the images now, but I would like to go more towards the, on the right side of the screen. Not this way. So I use fluoro at this point of time and keep digging my way.
So you want near DJ?
I beyond DJ, and a vertical loop is the most preferred target.
Okay.
Any particular reason why more towards DJ?
I'll tell you. I'll just give me a minute. That's why I wanted somebody. Pravir was my. Pravir is hiding. Pravir is expert at. Yeah. Pravir is well protected. You are hiding behind me, so you can get protected. I'm sorry. I just pulled. I tried pulling leg of Pravir, and Pravir talks well. And I thought sometimes when I get stuck, I ask somebody else to talk, and I let me do the procedure only, because too much of both sometimes. Yeah, that looks to be a decent segment. I was looking that descending segment. Pravir, what do you think?
Sir, 1 minute, can we shift to Amol who is putting the stent?
Yes, please. Yes.
Yeah, shift to Amol Bapai room, please.
So Amol, you are on. We can see you. We don't see any endoscopy picture.
So till you see the endoscopy and fluoro picture, you will have to trust me that we cannulated by ERCP. Hopefully, you will get the endoscopy and fluoro image to confirm that. But I would want to show you the endoscopy picture and where we cannulated, because that is very important.
Yeah. So initially you were on the right and top. You went down, and
but
then you could find
then
the
So the idea is to go from top low downward and then keep assessing where you are getting a puncture and where this thing is going. Now we are in the direction of the bile duct. We are going to inject contrast. We aspirated bile.
Amol, so you aspirated the bile. That's the most important thing in dilated bile duct, right? Otherwise, bile and contrast doesn't mix, and
Doesn't
you
mix,
not.
and then you will not get this thing. So we aspirated a little bit of bile. Thoda inject karo yahan pe. Contrast. I'm at the lower end because I want to see the distal end of the bile duct very well. But you can see that the bile duct is filling up well. I think that's good.
Yes.
And we will use a short stent, but I would want to use a
8 centimeters.
6 centimeters. 6 centimeters stent.
So are you using covered, uncovered? If covered, just covered, or something else?
I would use a bare head, preferably bare head covered stent.
So you mean both bare, where the
both sides, both ends are bare. Yes.
Yeah.
But so if we have either an MITech or an anaro, the stent, or which stent is this?
it looks like Java.
But is it a fully covered stent or a uncovered stent? Uncovered will get blocked in no time. Preferably if we have a covered stent. Otherwise, we will put in a 10 French plastic stent.
Yeah. Give a double pick till 10 French
Yeah.
plastic.
If you don't have a fully covered stent, I would prefer to put in a 10 French plastic stent, because uncovered stent over here within 2 to 4 weeks, this patient will come back with cholangitis because of tumor ingrowth. Because this is a very proliferative lesion. One should not use uncovered stents in this situation. What do you think, Nilay?
I fully agree with you. I almost always put nowadays plastic stent because in amphiluridectomy it's a different ball game. They last for 6 months, 1 year, 1.5 months, 1.5 years, and you just change it after that.
Dr. Amol,
Yes.
For few minutes, can we shift to, if you are completing, because Sandeep is also ready.
No problem. We are just waiting for the stent.
So till that we can shift to Sandeep room.
Yeah.
Over to Sandeep room.
We'll exchange until then.
Sandeep, you are on.
Okay. So you have the fluoro image and the EUS image there.
Yes.
And you have a distended bowel loop there. You
We
can see
don't
that
have
that's why-
EUS image. We just have a fluoro image, which
Acha.
tells us that you are somewhere near the descending segment of the not the duodenum, jejunum, probably just beyond the DJ flexure, and your channel would be somewhere at the DJ flexure. That's what we can see. And now we have a small
Once
EUS
you have-
picture.
Yeah, once you get the EUS image, let me know.
Yeah, we have PIP small EUS picture. If we can enlarge it, it would be great. Yes, so now we have EUS picture, but nothing else, not you. Now we have fluoro picture and EUS picture.
Both?
Yeah, both, yeah. So pretty well seen.
That's
Both.
okay, that's a small one. थोड़ा डाल दे, पानी डालना. All set. So you can see the turbulence happening as he's filling some water.
Yes.
That's important. So it's in the trapped area.
Yes.
And that's our target organ. So I bring the stent out.
But
Stent
tell
is-
us, how would you decide where to puncture?
Whichever is closest to the stomach with minimum of intervening tissue, and a long segment is always better. So I'll just try to go in. She's breathing little.
So you need at
rapid.
least 3.5 centimeter, 3 to 3.5 centimeter of bowel, because axios would need that kind of length.
Can you look okay? Okay. So it's just now ready. Okay, nikal the part.
So you are in.
Yes.
That we can see. You are still pushing a bit.
I'll pushing it little bit to the almost
Yes,
opposite wall,
perfect. Yeah.
but not overshooting it. That's a very crucial thing because it may still be warm. It can burn the other area. And now I think it's okay.
So you've taken out the cautery.
Yeah, cautery is out. I'll deploy the inner flange.
Just a minute. Show us the steps, if you can. Make the external bigger. Take out the fluoro. We don't need fluoro. We need only 2.
Okay.
I think we have a mark of 1, 2, 3, 4 on this hot axial stent. What Dr. Sandeep has done right now is the 1 mark, that is the distal flange in, and then he has used the deployed the distal flange, and then
Waiting for it to open. That a little takes time. So
Yeah.
distal flange has been deployed.
Deployed.
But it's not fully open as yet. I'm just waiting it to open
Now
up.
it is open, yeah.
So that's another important thing that you should be aware of, that it takes little time sometimes to open up, and there should be no hurry to finish off the procedure quickly. I am in a good position.
So
I can
probably
check
now
my-
the next step, yeah.
So you have the fluoro image also. You can see the inner.
Yes,
flange is
we
opened up.
can see everything.
So the third step is to position the stent right, which Dr. Sandeep will do. So he's pulling
I'm pulling
back.
it back.
Yes.
Okay, so now I've pulled back. I've deformed the inner flange now, which you can show. Nila, if you have a pointer there, you can show on the screen there to the audience.
Yes, so what you see, yes, there is a pointer
Right
there.
here.
And so
Yeah.
there is
Thank
now
you, Anthony.
hardly space between the transducer and the stent. That is what you want.
Yeah, and now I will deploy the final step, which I will happen to do in the channel itself. So I have unlocked the fourth step, that is the deployment of the proximal flange.
Yes.
Dr.
And I will
Sandeep, what
deploy-
is the optimal degree of deformity that you call optimal deformity? When do you say it's optimally deformed?
So Sudipto, I think it's just the shape of a bell, you can
Ah.
say. This.
I think we can discuss the video later. Let me finish this
Yeah.
case because we are at a very crucial step. Sorry, Sudipta.
Can we
So I'll
shift
now
to, can we shift to Amol for a minute?
No, you can't
no,
shift.
no.
You can't shift right now.
Okay.
Floor off, no? Just for fun, because that causes some. So I'm now withdrawing the scope, pulling it away, as well as pushing out the
Endoscopy view.
So you have endoscopy view there,
Yes, we have endoscopy view.
and I should see the blue color which I see, and I'm pushing the stent out, and that is opened up. Yeah, that's fine.
I think excellent, Dr. Sandeep.
So Sandeep, can you please now?
अरे भाई एक मिनट ताली तो सुन लेने दे मेरे को. I haven't even heard the claps, boss. Sorry. Sorry,
Okay,
Rajesh.
great,
Yes, yes, we
great
can
job.
be-
So lot of claps, Dr. Sandeep,
Thank
and
you.
we shift to Amol Bapai
Yeah,
room
please,
now.
please do that. I'm just joking. Sorry.
Hello.
All you are on.
Yeah. So I'm using the Java stent, which is a fully covered stent. I would have preferred actually to use a bare head, but just now the bare head is not available. I think it was used in the last case. So because the bare head will anchor better inside the duct. But this stent, the advantage is that the coating is from inside, so that the outside is quite rough. So the anchoring will be better. You should never use a stent which has a coating from outside, because there that stent is very likely has a high
But
chance of migration.
Amol, I have a question. If that is the case, does that mean you would be putting this stent in other benign biliary stricture? Because taking out maybe would be a difficult thing, or it should not be.
Well, Nila, this is the first time I am seeing this stent, so I honestly have no experience of using it in benign biliary strictures. But we do use fully covered special stents like the Kafi stent or the Babbi stent for benign biliary strictures and for benign pancreatic strictures as well. As well as we use the Hematex stents also, the fully covered stents. This stent also probably, if it fits the configuration, it could be probably used, but then I need to understand before the configuration a little bit better before I can justify its use. So that is how it is. But another important thing is we are using a 6 centimeter stent.
Can we have the fluoro
this is an
picture?
8 point.
Yeah.
Fluoro, please.
8.5 delivery system. This thing is there. Now you can see the yellow marker.
Yes, we
Now we
can.
will start deploying, but I am going to pull the stent backwards.
Amol, I have a question. Sometimes this, because of the light of the scope, this yellow marker is not seen properly. What would you do?
In that case, look at the radiographic marker,
And
the distal marker.
And probably we
and
can
also
deploy
we
it
can
inside
deploy
the stent.
it
What
inside
what
the
I
stent.
would do, I'll tell you, just start the iris from auto. You just start the iris and you will start seeing, because then the light will go down and you will
Right.
see the yellow marker better. So
Yeah.
on iris, start the iris function of the scope.
Yeah.
Processor.
The other thing, Nilay, since this is an ampullary tumor, I want the stent to be lying fairly across this thing in the
Yes.
duodenum.
A little
I'm
bit
going to
more than what you
probably-
usually get.
Yeah, more than what I would usually this thing.
Nilay, this is already on peak.
Yeah,
You
yeah.
are already seeing a
Yeah.
light. This is a
This
brighter
is
picture.
normal. And now
Yeah,
you
this
start
is-
Yeah.
iris and you see
Normal.
yellow.
Yeah, we have started it. Yeah.
Yeah.
This is normal now.
Now this is normal. This is the peak. So start deploying.
See, you can see the yellow marker very well when you start.
Fluoro, keep the fluoro continuous
Yeah.
on, Abhi. Now you maintain the yellow marker at the elevator.
There is a tendency of a metal stand going down,
Inside.
up,
Yeah.
inside. Yeah.
And also the tendency differs from stent to stent. That is
Yes.
something
Yeah.
that you have to remember.
Yeah.
Yeah,
Deploy.
slowly, yeah, slowly. क्योंकि stent थोड़ा jump कर रहा है. Okay, fluoro on. तो खुला नहीं है अंदर.
And the most
It is not
important thing,
opened
Nilay,
inside.
It
Wait a
doesn't
minute.
open up.
It has not opened
Yeah.
inside. Why is this not
Doesn't
happening?
open up.
It has not opened up.
It will open probably. Come out.
No, but unless it opens, we can't deploy the full stent, because then it will be a big mess. The stent is not opening despite deployment. Sometimes
I
this can happen,
I think you have to take it out, huh, Amol?
possibly, because if it is not opening, then I am not deploying the rest
Yeah,
of
yeah,
the
you
stent.
can't, because then you are stuck.
What I'm going to do is I'm going to go inside, outside, and just try and wriggle. Sometimes if it is a little bit stuck, it might open up after a few of these things. But if it doesn't, then we'll have to pull the stent out. And we'll have to use another stent. Maybe we can use a 10 French stent, not a problem. ठीक है, recapture कर दो. Recapture करो. चलो. Okay. Okay. Push the wire.
And the most important thing, Nilay, I think in this cases is you have to keep the wire inside.
Yes.
Never lose the wire. Never lose the fight.
Lucky once by getting the wire across.
In
I don't know whether
procedure.
I'll get lucky again.
Dr. Amol, if we don't have a bare end stents and we are putting in a fully covered stents, then to prevent migration, can we put a plastic stent after putting a metal stent?
You can, but there is no data to
Double pigtail.
suggest that that prevents migration.
Like we do in CDS, means the same
Yeah, but-
principle.
Yeah,
No, but
capillary
this is
tumor
a different anatomy. This
Yeah.
is a different this thing. So it does not necessarily prevent migration.
You saw
We have
without
put in.
papillary, yeah, you saw without papillary, without anything, the ampulla had opened up and
Yes.
bile was coming out so easily. So putting
Right.
double pigtail stent probably may not be a great thing
Yeah,
to prevent the migration.
yeah.
Yeah, because Neela, I think
Because
this is bulk
Double
actually.
pigtail stent. Another problem with the double pigtail stent is that the duodenal peristalsis acts on the double pigtail stent and pulls the double pigtail stent downwards, and that will further pull your metal stent downwards. That is what is going to happen. 10 French stent, le lo. 10 French double.
They are
stent.
getting it.
I have a
Yeah.
small announcement that at 2 our lunch is also ready. So while we finish the case, we can also, in case somebody wants to start with the lunch, they
So-
can do lunch.
yeah.
And there's an Olympus lunch symposium also. Thank you.
Sir, but if,
So Niloy,
Yes.
sir,
as always, I am following whatever you tell me. So I am going to put in a 10 French stent now.
It was nice to hear it, but which is not true.
sir, but wouldn't the same principle will apply once you are putting in this 10 French stent, double pigtails, that duodenal peristalsis will again pull it down?
But
That is
will-
true, but
that will not
see,
get
but
the upper pigtail out.
Yeah, that will not bring the upper pigtail out. The
Below.
stent will migrate partially and it will lie in D3. Definitely. But the proximal pigtail will still remain inside the bile duct.
Problem is the pigtail stent is that the patient is having the gastric outlet obstruction features. Then you can't do the again stenting if you need the.
Then you
stents
can
blocked.
even get a stenting later on,
That is optional.
Dr. Amol,
if required.
Dr. Amol,
Yes,
submit this side. I wanted to ask you, the stricture is very short.
yeah.
Don't you think that chances of migration will be much higher, whichever covered stent you use? Number one. Number two, the growth is protruding into the duodenum. How will you trade off between adequate stent length outside the growth versus the opposing wall? There's a very high risk of if you put
We
too much stent-
usually, no, okay. So for your second question, if you're putting in a metal stent, keep about 3 centimeters of stent outside in the duodenum and push it downward so that it is going towards the D3. That
Okay.
is the principle.
Okay,
And I agree with you that
Fluoro-
the picture is very short. Fluoron.
Okay.
Okay. Release.
This is a 10
This is a 10
centimeter 5.
10 French 5 centimeter stent. Double pigtail. Marker एक है कि दो है?
This is the
This is the
first marker.
one.
And that's
Okay,
the second
that's the
marker.
marker. Now make sure that your marker and your pigtail goes downward. So can I have the iris?
pull out?
Yeah, light is better now.
Pull out the
Pull
whole
out
thing.
the deploy. Deploy कर दो. And go away from the papilla and make sure you keep your elevator completely open and push it out so that the pigtail forms
Fantastic.
well in the duodenum.
Very good. Nilay, I
So,
always
please
follow
follow
one
here.
principle that whenever in doubt, always put a plastic stent.
Yeah, that is the safety always.
Never venture with metal stents when you have a semblance of a doubt. Thank you.
Thank you. Any questions from that side?
No.
You were wonderful, sir.
Okay.
Skills and the steps we have enjoyed. It was a wonderful presentation.
Thank you.
Thank you.
Thank you.
So the faculty lunch is in the Ebony area and we will restart at 2:45. Thank you. Yeah. Thank you. 2:45.
So our next case is 63-year-old male who presented with painless radiology on Blood investigation CA99 was very high, and on radiological investigation, there is a mass on the pancreatic head encasing the SMA. And USFNAC is suggestive of adenocarcinoma, so plan is US choledochoduodenostomy.
Dr. Praveen, you are on.
Yeah.
Over to Dr. Praveen.
I would like to thank Dr. Puri for this and his team for this wonderful opportunity. So we have a 63 male who is a case of pancreatic adenocarcinoma, FNA proven. And here we are going ahead to do a choledochoduodenostomy for this patient. So still the patient is being sedated. I think we need to wait for just a minute and then we will start. So I'm using a linear EUS scope, and that's the tool that you use to do therapeutic EUS procedures. So the patient is in a semi-prone position, and the reason why is in semi-prone is the reason is primarily this is the way that I've been trained, and this is the way how I do the procedure. I don't think it really makes a difference whether you do in a semi-prone, in a lateral, or in a supine position. So can I know who is on the chair?
Sir, I am here. Dr. Zubin, I'm here. Dr. Manoj Sahu is here, sir.
Okay. So am I audible there?
Yes, yes, you're audible, sir.
Okay. So Sridhar is with me to support me and see whether the things are being done in the right way. Can we go ahead?
What is your usual preferred position? Do you prefer doing it in supine or?
Yeah, so I just told that usually I prefer doing in a semi-prone position.
Right.
And no specific reason for that. This is how I have been trained, and I'm comfortable with.
Right, right.
So still the patient is not yet sedated. We are just waiting for that.
So, sir, usually you keep in semi-prone, and does it interfere with your fluoro visions via?
So I don't think usually you have any problem in a semi-prone position. We'll just see that. Can I block it? थोड़ा सा इसको हटाई जाए. So I have passed in the US scope, and I have just did the up down on the up down knob, and this is primarily so that I can visualize the mucosa well while passing my scope, just to look for varices if any. So I'm down in the stomach. So once you are in the stomach, just suck if there is any fluid. I don't think here there is any significant amount of fluid. Some fluid is there, so I will just suck that before I insert the scope further.
Dr. Praveen, presence of varices, will it change our decision to do the procedure, or?
So I think if we intend to do a choledochoduodenostomy, it doesn't make a difference. We are going through the first part of the duodenum, so that should not be an issue. So ये थोड़ा एयर ऑन है, CO2 ऑन है, ये थोड़ा सा लीक कर रहा है, जानकारी.
Probably the valve is leaking. So.
ये लीक कर रहा है, नया क्या चाहिए मुझे. So I think we are
Almost in
not able
the
to
donor bulb.
insufflate it properly.
Yeah. Looks like you are in the duodenum.
Can we have a better wall, please?
So, sir, when you are planning for a CDS, what are the things that you look for while planning your intervention?
So what I'm trying here is to position my scope well, that is in the first part of the duodenum, and we intend to position ourselves in the apex of the bulb. This is what I'm trying to locate. I think this should be D1.
Right.
And then this should be the apex. And let CO2 off, please. Can we have the US image now?
I think there is some eccentric.
Yeah. So what we have done is we have. So the valve was leaking, so we couldn't get much good air. Now I have passed my scope in the first portion of the duodenum, positioned it at the apex of the bulb. We can see a large anechoic linear structure just adjacent to the probe needle. Just adjacent to the probe. That's what the location of the bile duct should be. Or can you?
Dr. Praveen, is there a size of the bile duct beyond below which you will not do or a prefer CDS?
Okay. So as you can see right now, we are just positioned it well. I'm passing the needle right now. And then the first step is you pass the needle. And here we choose a 19 gauge. Can we have dimmer lights, please? So 19 gauge FNA needle is what we have, what we are using right now. So this right now we are using the needle from Olympus. This is what I have been given. So as you can see, once you are in the bile duct, you apply Doppler. Just see that there is no large vessel, and you can see some vessel there. So just position your scope right. No, up, slightly more up towards the probe. Yes, more up.
Dr.
Yeah.
Praveer, can we see the fluoro image also?
Yeah.
Fluoro.
So we'll just see that in a minute. So let me just try to see on EUS that I'm in the correct position. And no, slightly more up. Yes, 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 that's fine. Okay. So now once I know that the position to me looks right based on the EUS image, then I want to see the fluoro image. And what I want to be sure on the fluoro image, that the scope position is towards the hilum and not facing down or in a horizontal position, but it should be towards the hilum. Fluoro. So fluoro, please. So you can see now the position looks good.
Yes.
The reason why it should be facing towards the hilum is that once you puncture and you try to pass a wire, if you don't have a good position, then you will have tough time for the wire to pass to the hilum. Now, once we are positioned, I just first try to.
So usually the bevel of the needle will face downward. So you want to make sure that you're facing the hilum, right? So I think that way it will pass towards the hilum.
Yeah. Okay. So now you can see the tip of the sheath coming out. Are you able to appreciate that?
Yes, yes, we can.
Okay. Once that's the case, now I again want to see on fluoro that everything is right, which it is. Now, before puncturing, I'll again put Doppler to ensure that there is no vessel there. So Doppler again, please. So there is some vessel there. So I'll just try to adjust it a bit. Adjust it a bit. Now, please remove that Doppler. So there is a small vessel, I think. but I don't think that should be a major issue because ultimately you are going to deploy a metal stent and that it should be taken care of. Doppler again, please.
Those look like small vessels on the wall.
So can you see that now there is no large vessel there? So I think I'm comfortable, and once I think I'm okay, I'll just go ahead and puncture. Fluoro, please. And you can see the position of the scope, position of the sheet, everything looks fine to me till now. And then we go in. Once we are in, I'll aspirate first. So aspirate first. You can see the bile coming up.
Yes, yes, you can see that.
So once we are convinced that there is bile coming up, we want to instill contrast. Please contrast.
Fluoro, please.
Contrast. Yeah, please. So I need a lot of contrast just to be sure that we are in the bile duct, not in the gallbladder. And I want to see the intrahepatic ducts. I need better sedation for the patient, please. Okay. So I need to be sure that we are in the bile duct and not in the gallbladder. This looks like a bile duct. I want to see the intrahepatic ducts as well.
Right.
So,
like
does it look okay? Can you see the intrahepatic ducts?
Yes.
Yes. It looks
Okay.
good.
So now with me is Bhagwan, who is trying to pass the wire, and the position of the needle is such that I'm quite convinced that this needle will go to the hilum. And moreover, when you have Bhagwan along with you, I think things will be in your favor. Let's see.
Dr. Praveen, would you like to always look for cystic duct when you are doing a cholangio?
So right now, I think I'm quite convinced that we are in the bile duct. So can you see the wire going up?
Yes,
Yes,
we
we
can
can
see
see.
that. Nicely done, sir.
Take minute. Push over.
Yeah, like you mentioned, sometimes there can be an inadvertent cystic duct puncture instead of puncturing
Yeah.
the CBD.
Yeah.
So yeah, that is something that
Wire
you have to
done.
be careful
Wire
about.
Wire.
So Sridhar, what are the points that you would like suggest while somebody who is new to for this procedure to identify cystic versus CBD?
Right.
Sorry, can you a bit more clearer now?
So I'm saying that some few points for somebody who is new to this procedure to
Yes.
identify cystic versus a CBD while doing a puncture.
Right.
So I think if you trace the bile duct should go towards the hilum and the liver. Cystic duct, if you trace, it will go to the gallbladder. And when you do an EUS on from apex of the bulb, you can see very clearly that the cystic is bile duct. Main bile duct is just adjacent to the probe, while cystic duct is just ahead of it. So this is how you see that. So you can see some amount of bile leaking out possibly. So I'm still not seeing good amount of contrast in the intrahepatic duct, which I wanted to.
Right.
But that looks should be okay.
So there's a small. I think we should not be too worried about that much amount of bile leak. Maybe not be clinically significant.
Cystotome. So now once we have the wire in, we'll pass the cystotome. This is a 6 French cystotome.
Dr. Praveen,
Yes.
is the little bit of the bile is leaking or?
Yeah, little it is leaking for sure. But I'm not worried about it. We should try to do the procedure as early as quickly as possible.
Yeah, I think the quick procedure is important.
You can keep the stent arranged.
So I think the issue is once you have a quick procedure, small amount of bile that leaks is well covered, taken care of by antibiotics, should not be a cause of major concern. Right now, we are passing the 6 French cystotome, and the intention is to ensure that this goes towards the in the bile duct. So let's see. So position looks quite good. As I mentioned, I would have loved to see more of intrahepatic ducts. Anyways, so now I'll just position it right, and then
Yeah, using cartridge.
okay. So we'll use cautery now. And the positioning is very, very important. So as you can see, we have entered into the bile duct. And now I would ask Bhagwan to just manipulate the wire some deep into the system, because so we are in the bile duct.
We cannot see the.
Fluoro picture, can we have it little bigger?
Fluoro picture, please.
Slightly bigger.
Yes.
Yes, now.
The US image has gone.
US
Okay,
picture,
right.
US image also, please. It's not
US
visible.
You always
can
try
be
to keep
made-
the
US
wire
can be
at
made
a
smaller
photo-
and the floor can
Yeah.
be kept larger. Yeah, thank you.
वहां से लो, यहाँ से लो,
हाँ अभी जाएगा.
यहाँ थोड़ा contrast डाल दो. And I just want to see intrahepatic ducts. So the reason this I'm stopping right now is I just want to see more of intrahepatic ducts if possible. Otherwise, things looks quite good. You can see on EUS that the bile duct, dilated bile duct, you are well through the bile duct, and so intra.
We can see the left-sided ductal system.
So now it's good.
Yeah.
Okay. So we are now what I'll do is the last step, that is the deployment of the stent. So it's okay. It's okay. So
Which stent you are deploying?
yeah.
So we're using a tubular 6 centimeter fully covered stent.
So normally my choice is to deploy a 6 centimeter partially covered stent, and the reason why I prefer this stent is that this is just a concern of the migration. However, right now we are using a 6 centimeter fully covered stent. Wallplex. This is by Boston Scientific. So I think we will just take 2 or 3 more minutes. I think Rajesh, that's okay. 2-3 more minutes.
More and then we should finish.
Okay. So this is the last step, and wire inside, please. So once you have wire, what usually I do is now good.
Excellent.
So I'll just pull the cystotome out. एक दो बार अंदर भर ले जाएंगे. So normally the problem is you have this 6 millimeter cystotome and 6 French, sorry. And what you're trying to do is to pass a stent, which is delivery system is 7.5. So sometimes what can happen is you can struggle. So what do you usually do? And I don't prefer anything else after using the cystotome. And the reason is because it prolongs the time. It prolongs the time, and then you may have the increased risk of bile leak. So that's the concern I have. So we usually use only the 6 French cystotome, and usually that suffices for most of the procedures. So we are well inside, and I'll just position it right. So positioning is very, very important, because if the position is not good, then you may have dilated, but even then you will struggle to pass the stent. So I think this looks okay. Dr. Sridhar, how's that?
It looks good.
Okay.
Looks good.
So now the last step, that is the deployment of the stent. We are exchanging the cystotome on the wire, and then we will deploy the 6 centimeter fully covered stent by Boston Scientific. Fluoro, please. Fluoro, please. So here you have to be very cautious that you don't lose on the wire, because again, if you lose the wire, the whole procedure gets spoiled, and then you will have to repuncture. That becomes really a headache.
Right.
So we have the wire well deep inside. My scope position is good, and till now everything looks good. So as I say that this procedure again has a very low margin of error. If you go wrong in one of the steps, it becomes a problem. So till the procedure is completed, you can't be sure that everything will go on well. So last step, that is the deployment of the stent. The reason why this step is important, because you have to ensure that the proximal end of the stent should be below the hilum. And that's the reason we use a 6 centimeter partially covered. You have a margin of 0.5 centimeters on one side. Here we are using a fully covered stent, and we want to be very sure that the stent is below the hilum so that it does not block the other duct. Fluoro, please.
This is a rapid exchange.
So till now, the position looks good. Wire, please, wire stiff, please.
Can we have endoscopic image little larger?
Oh. Okay.
Can we have endoscopic image larger, please?
So I'm exchanging now, passing in the stent, and till now things look good.
Can we have a larger endoscopic image, please?
I don't need an endoscopic image right now. We'll show you the endoscopic image. Just wait a minute, please. So till now I am doing based on fluoro. And then we are about to reach. So you can see we are just trying to struggle here because the okay. Position. So I'll just position my scope right before we pass the stent, because this looks like some angulation that has happened here.
wire दिख नहीं रहा है.
Just we'll just do it. I think that should not be an issue. I think what has happened is we have possibly US image we have lost actually. So we'll just try to figure it right again. Let me just do that. ये वायर कौन सी है? ये तो विजिट लाइट ठीक रहता है यार. हाँ? नहीं, just.
Yeah, I think you're losing wire.
So maybe if we keep the wire and
just
dilate
a minute. Okay. Okay. Just so here.
Yeah.
So normally it's not like this.
You're in the retroperitoneum, not in the duct. So
no. Just Dr. Okay. So let me. So I think we are just we have fallen back on the scope, and that's the reason we are struggling.
You can remove the stent again and maybe sir pass the wire and repass it, get a reposition again. And
Okay.
Then do it. Yeah, I think the tip has gone in. Okay, that tip from the stent is not tapered anymore. पीछे tip दिख रहा है क्या?
Just a minute, please. We'll just get in. No issues. Okay. Yes.
You're going to fall likely.
What is? Just wait. Just wait, please. Just wait.
नहीं wire.
Wire has come out.
Your
नहीं वायर क्यों निकल जाएगा?
ये रेट्रोपेरिटोनियम में ही है सर, ये इसमें नहीं घूम रहा है. You're between the bile duct and the
I'll do it.
So,
So I
we
think
are
we can,
winding up with this case. Probably we'll have lunch. Then after that, we will start again.
thank you.
Thank you.
So 2:45 sharp, we are starting. So kindly take your lunch and come back immediately. Thank you very much.
Good afternoon. After lunch, let's get back in the game and start with the next phase of the conference, which comprises of 6 discussion sessions back to back in the same format as conducted in the morning session. Each session will be of 12 minutes talk by the speaker, followed by 3 minutes of discussion. It is a kind request to all the speakers and chairpersons to kindly adhere strictly to the timeline. There will be a alarm bell at 11 minutes of the talk and second alarm bell at the 12 minutes of the talk. For the first 2 sessions, I am pleased to invite as chairpersons Dr. Kunal Das, Dr. Sukrit Sood, Dr. Yogesh Arwani, Dr. C.G. Sridhar, and Dr. Neha Berry.
So to start this session, I'd like to invite Dr. Adarsh Chaudhary, who needs no introduction, to discuss about a surgeon's perspective in Pancreato biliary endoscopic interventions, what a surgeon expects from an endocrinologist. Sir, please.
Can you please start my slides? Thank you so much. I am possibly the only surgeon in this conference, and I'm supposed to talk on what a surgeon expects from an endocrinologist. As a surgeon, I seek information, but what I usually get is mainly confirmation. Mostly what happens is the information that we get is all that we already know. So a surgeon desires much more than what we are given. See this endosonography report of a patient who's got a mass in the head of the pancreas. There is absolutely no information in this report. They say that there is a mass in the head of the pancreas. There is no mention of the vascular relationships of this mass. A biopsy has been taken from a subcarinal node, which all of us know that a pancreatic tumor rarely ever metastasizes to a subcarinal node. A biopsy of the node in the porta hepatis or elsewhere was not taken. So that's what usually happens. This is a real life scenario that majority of time, like I said, these things are there. The real information is missing. And like these reports are very common. You read this report, a large mass in the fundus of gallbladder, infiltration of liver, multiple periportal nodes, biopsy taken. This is a gallbladder cancer. The CT scan has already shown all these things. What is the relevance of this report? How has that made a surgeon wiser who's contemplating a resection? Multiple stones in a choledochal cyst suggest ERCP with stone removal. Case of chronic pancreatitis, a cyst seen. Gallbladder is distended. There is no mention about the rest of the pancreas, the status of the common bile duct, status of the splenic vein, is the spleen enlarged or not. So that's exactly what happens in majority of reports. So the information that a surgeon seeks is more than a CT scan. So if you're an if you're doing EUS and you want to increase your practice, you got to give more information than is available on a CT scan. Like they say, the man has two reasons for doing anything, a good reason and a real reason. The real reason may be that you have an EUS scope. The good reason may be, please help the surgeon give us some information that is not available on conventional imaging techniques. My main interest is pancreatic cancer, and majority of information that I seek is available on a CT scan. The degree of vascular involvement, lymph nodes, retroperitoneal extension, the morphology of the pancreas. But what I seek from an EUS person is that information which is equivocal. There are times when I'm not sure how much of the vessel is involved. Is there thrombosis? CT scan is not a good investigation to see the retroperitoneal extension. That's where EUS scores. The problem is that most physicians are not aware of the anatomy because you've never been taught anatomy. It has not been relevant for you. But when you do EUS, you need to understand the anatomy. And one of the most important anatomies in the region of the pancreas is to realize that the superior mesenteric artery lies posteromedial to the superior mesenteric and portal vein. So you must comment to the surgeon about the degree of involvement of the vein and the artery. This is important because you look at this picture. If you look at this picture, a small amount of the splenic vein of the superior mesenteric and portal vein is involved. If my EUS guy tells me that only 2 centimeters involved, then I know and I can do an end-to-end anastomosis. But if he gives me an information that more than 6 centimeters involved, I need to put a graft. So I'm prepared before surgery what to expect. It's very important. A good EUS guy tells me that the first jejunal vein is a constant vein. What is its relationship to the superior mesenteric artery? Youngsters who are in the audience, if you do these things, your surgeons will refer patients to you because the anatomy of this region is very important for us because that's where recurrences of the disease occur. And on an EUS, it's very easy to see this anatomy, but only if you look for it, you will find it. You see, most of you are not taught about lymph nodes. But my request to you is in your EUS room, don't remember, but at least put your chart there. So at least when you refer to a surgeon, you can tell them that I've taken a biopsy of the 8A, 12A, 12B, saying that I've just taken a biopsy of the periportal nodes. Has no relevance. It gives no information. I'll tell you something much more simpler. If you have to take a biopsy in a pancreatic cancer or a gallbladder cancer, take a biopsy of the interaortocaval nodes. Taking a biopsy in the hepatoduodenal ligament has no relevance because we will anyway remove those nodes during surgery. But if interaortocaval node biopsy is positive, then this patient is not a candidate for surgery. We'll give this patient chemotherapy. So concentrate on this region, try to get a biopsy which is relevant to us, which directs management and which affects results. Taking a biopsy in this region has no relevance. We already know there is cancer and it's not going to alter the treatment in this. Look at the information. This patient had post-ERCP pancreatitis. EUS was done, but no comment was made on the morphology of the pancreas. We opened up, so we had to close this patient. We went back after 4 weeks and then we did a Whipple's operation. So an EUS person, if he has eyes, he can see that what to offer. So when you do an EUS for a pancreatic cancer, always tell the surgeon, superior mesenteric vein, portal vein, hepatic artery is commonly forgotten, the gastroduodenal artery, the splenic vein, whether there is abutment, whether there's encasement. There are two different terms. What is the length of involvement? Is there a presence of thrombus? Presence of a thrombus in any visceral cancer is a bad prognostic sign. Don't get confused with lymph nodes. Just concentrate on para-aortic nodes. Please tell us about the retroperitoneal extension because CT fails there. Tell us about the morphology of the pancreas. Can you tell us about the texture of pancreas? Is it firm? Is it hard? Where is the duct placed? Is there associated pancreatitis? You give this information, you become a more sensible and helpful EUS guy. Second common problem in hepatobiliary disease is the presence of a gallbladder cancer. A gallbladder cancer is an aggressive cancer. Why is it aggressive? Because there are a few cancers in the body which spreads directly. lymphatics, lymph nodes, and bile duct. It is disseminated through lymph nodes. And when we do surgery in these patients, we excise the bile duct. This is the hepatic artery, that's the celiac artery. So if you are doing an EUS in a CA gallbladder, concentrate only on two group of lymph nodes. One is the celiac artery node, other is the para-aortic node. If the celiac artery node is positive, if the hepatic artery node is positive, then these patients should not be operated. They should be first given chemotherapy. So don't waste your time and energy in taking biopsies of nodes in the hepatoduodenal ligament because they do not alter outcome. So in a gallbladder cancer, tell us about the degree of liver involvement. Is there a dilatation of intrahepatic ducts or not? Because if intrahepatic ducts are dilated, it means the common bile ducts are being infiltrated. What is the status of portal vein and hepatic artery? Is the CBD dilated? And like I said, take a biopsy from the celiac artery or the para-aortic nodes. When we have a choledochal cyst, we want to excise the choledochal cyst. MRCP does not tell us what percentage of this choledochal cyst is inside the pancreas. If you leave choledochal cyst distal part in the pancreas, which is dilated, these patients continue to have symptoms. They can develop cancers. So if the dilatation of the bile duct extends into the pancreas, these patients need a Whipple's operation. So as an EUS person, you must tell, because MRCP cannot tell. In US, you can tell that the degree of dilatation goes into the head of the pancreas. So that's why it helps the surgeon to decide. So tell us, is the dilatation extending into the pancreatic head? How close is the pancreatic duct to the lower part of the cyst? Because we can damage the pancreatic duct. And how densely is it adherent to the portal vein? That's what makes you a classy EUS guy than from the usual pedestrian type of EUS reports we get. Why is the current reporting not optimal? Like I said, because most physicians do not know much about anatomy. You've never been taught because it was never relevant, and you had surgeons to do your bad work. But now since you do EUS, you better learn some anatomy because you should be talking the same language. Mahesh is smiling, but it's true. Because when we were in PG, I remember you were posted in surgery department. You used to come and watch the operations. You know what is happening. Now there is no posting in surgery department. Many of you have never seen a pancreas in your life. So how can you really report till you see it? It's also a fault by surgeons. We do not communicate with you. We don't tell you what we want. We just criticize you. We never tell you what is it that we want. So we also have failed. And sadly, what I feel very amused is that most people are more interested in doing therapeutic procedures than proper staging of the cancers of the hepatobiliary system. When you do a procedure, you think you are a real man, but if you do real staging, you think I have not reached there. So proper emphasis has to be then. So for EUS to be more meaningful for surgeons, it should contribute to clinical staging. And you have a great tool, which in many ways is superior to CT scan in many circumstances. Understand surgical planning. Get in touch with the surgeon. What is the intended procedure? What does he want to see? And I have a plea for the EUS people that you must have a standardized way of reporting. If you make proper standardized reporting, you will not miss anything. Like if you see a pancreas, portal vein, supramesenteric vein, artery, if everything is listed, you won't be missing. So what's my wish list as a surgeon? My wish list is, please solve the problem of the unexplained head of the mass, a mass in the head of pancreas. Is it chronic pancreatitis? Is it cancer? To my mind, the answer will come from EUS. Tell us about the texture of pancreas. Is it soft or is it firm? Because that prepares me for my surgery. If it's a soft pancreas, it has a greater chance to leak. EUS is a great tool to diagnose post-surgical collections. So as surgeons, we create complications, and a properly done EUS can do a very nice drainage. There is evidence that EUS shear elastography can predict possibly pancreatic exocrine dysfunction. There are reports on that. Please work on pain relief in patients who had chronic pancreatitis and help us to differentiate between benign and malignant strictures in the bile duct. And the greatest advances in science have come from persisting and the audacity, not with going with routine performances. Thank you very much.
Sir,
So do surgeons really depend on EUS staging? This is the first question. Do pancreaticobiliary surgeons really depend on EUS staging and then decide whom to operate or give a new HO?
We depend on anybody who gives us the right information. We have no biases. Give us information, we will love it. The problem is that no information comes. Majority of EUS guys, you may not be, accept it in public, but in private, 90% see the CT scan and report accordingly. That's the sad part. That's the sad part. Somebody, I mean, you are so scared to be wrong. You must stick your neck out and say, so what if it is wrong? How many times have a EUS guy reported replaced right hepatic artery? Rarely ever, because you don't look for it. Most EUS guys are just interested in doing some funny drainage procedures which don't work, and to do some biopsies from here and there which give no information. You have the ladders against wrong walls. I can show you so many reports from the best centers in the country. Don't think that only you do it, everybody does it, because it's so casual. I tell you, there is a guy, his name is Rakesh Mahajan. He's in Jammu. He does only a conventional ultrasound. I do a Whipple's operation just on his ultrasound. I just do a Whipple's on his ultrasound. There is so much information in that one ultrasound. So you need to have skills. You need to have pride in what you do. So we trust you, provided you do it well.
Dr. Manoj Sahu.
I'm so glad you said.
And yeah, I'm telling you.
And Nilesh, not glamorous.
Yeah, not. And the other thing is we get away by putting needles at various places, nothing happens. That's why we do crazy things, and I always oppose. But then somebody comes out with some report, see, he did it, so I did it. And diagnostic EUS is absolutely difficult.
I tell you,
you say it is easy.
It's not
saying, but it's not.
I don't know about it,
Yeah.
but I didn't want to show the photographs. You think you put a needle, nothing happens. There are big hematomas in pancreas. A lot of things happen. Just because you don't see it, it doesn't mean it doesn't happen. It happens.
Sir, it is a really wonderful talk coming from surgeon's mouth, because we are seeing the progress of EUS. Being a new learner, we want to do some procedures. So you are right. There should be protocol how we should learn EUS. First, basic anatomy, and it should be standardized. Basic anatomy. So much of patients, standardized teaching has to be there, because if that is not there, otherwise everybody see I've done this much of procedure. So standard protocol of teaching and standard protocol reporting should be there, just like it is done in CT or MRI.
I will tell you a secret. If you want to become a good EUS guy, start going to the operation theater.
Perfect.
You just have to go for 2 or 3 months. You correlate your EUS findings with intraoperative findings. It takes you to a different plane.
Perfect, sir. Thank you.
Thank you, sir,
Thank
for
you.
your enlightening, as always, great lecture.
Next speaker is Dr. Mahesh Goenka, sir. He is Director and Chief Gastroenterologist at Apollo Gleneagles, Kolkata, Apollo Multi-Speciality Hospitals. And he will be highlighting us on cholangioscopy, impact on the management of the biliary disease.
Thank you, chairpersons, and good afternoon. My thanks and congratulations to the organizing team, both local organizing team as well as imported organizing team from Bhubaneswar, for organizing this very focused meeting. I'm sure you've been listening to a lot of EUS, but to give you a break, we'll be talking of something beyond EUS for the next 12 minutes. So this is just an idea about how cholangioscopy has become very popular over the last few years. And you can see how the number of publications related to cholangioscopy has increased exponentially in the last 3 decades or so. So my job for the next 12 minutes is to talk to you about the tools and techniques, diagnostic role, therapeutic impact, and what are the present limitations of cholangioscopy. The cholangioscopy, when we talk today, we primarily talk about spyglass cholangioscopy, And in very few centers, at least in India, we have ultra slim endoscopes being used for cholangioscopy. Which the people who are here in the hall, some of us who are oldies, have been using this mother baby scope till about 20 years back. A very fragile system, poor irrigation, and would be shown mostly in the workshop just as a technique. However, 2007, Spyglass direct visualization system with a new platform changed our approach to cholangioscopy to a great degree. So at that time, this was the system in which you have to introduce a probe to provide the light, and it would take about 20 to 30 minutes to set up the system while you're doing an ERCP. In 2015, we had this direct visualization system or DS system, which came in with improved imaging, no separate probe for light, easy to set up, would take only about 5 minutes to change from pure ERCP to ERCP and cholangioscopy, easy to use, great controllability, and dedicated irrigation system. It is in 2018 that the present system was introduced, which is the third generation cholangioscope with a new CMO chip, which gives better image, automatic adjusting light, and is much smoother movement of accessories. While the system has developed, the accessories have also developed. SpyMax, which was introduced about a year back, takes much bigger bites than the initial spy biopsy was. We have now a spy basket, spy snare, and so on to go through the channel of endoscope, the spy scope. Now, this is just to show that how the images has improved from the legacy Spyglass, which you got in 2007, to Spyglass DS, the second generation, which was 2015, and the present systems, which is Spyglass DS2. The images are really as beautiful as they can be. So what's the diagnostic impact of cholangioscopy? We can use it for evaluation of indeterminate bile duct lesions, primarily strictures, and there it can not only give us the nature of the stricture, which Adarsh was talking about, but can also map the stricture and the extent of the stricture. You can identify and recognize the filling defects, cause for dilatation of the bile duct. You can evaluate malignant biliary stricture, and you can also sometimes use the technique for establishing the clearance of bile duct stones and investigating hemophilia. So these are some of the images from our database, which shows how a malignant stricture looks like. You can see in the first image, there is papilliform projection. In the second image, there is induration and there is circumferential narrowing. And in the third image, there is some abnormal vessels which are seen, which can suggest that it's a malignancy. In contrast, the benign strictures look smooth. There are no dilated system. There are no projections, as you can see in these two short videos. So how does spy scope help us in differentiating bile duct lesions, strictures, benign from malignant? Number of articles have been published, including from India. So this is an article published from Shyam's groups from US, which showed that just mere visualization can give us a sensitivity of 90% and specificity of 95%. And if you add a biopsy or a specificity, obviously will increase. We also participate in a multinational study, and the data on the large number of patients was somewhat similar, that the sensitivity and specificity, just as visualization is high, and if you add a biopsy, specificity will increase. So what are the various features which help us? If you look at these 4 features, which I've tried to show in this slide, the first one is circumferential thickness and circumferential stricture, which looks indurated, which has a specificity of only 31%. The second one shows projections, which has a specificity of 62%. When there are papilliform projections, as shown in the third picture, it has a specificity of 77%. If your dilated tortuous vessels are seen, then the specificity is almost 100%. So this is a large number of papers which has been published, and I must say that if you use spyglass cholangioscopy carefully, you can change the bismuth classification in almost about 40% of the patients. What about therapeutic impact? Now, therapeutic impact of spyglass has been in these various areas: lithotripsy of the stone, tackling small intraductal stones, endoscopic tumor ablation therapy, guide wire insertion, and migrated stent removal. Now, these are some of the difficult stones which we encounter quite frequently. And in these situations, lithotripsy can help. I predominantly use laser lithotripsy, which works by photomechanical effect. And this is our system, and you can see how nicely the stone has been broken into multiple pieces, which can easily be removed. Now, we published again a multicentral trial in endoscopy 2019, in which we showed that the large stone can be tackled by laser lithotripsy in one procedure in 80%. But if you have large stone more than 3 centimeters, you may require more than one procedures. Now, the other technique for lithotripsy, which can be used with the help of cholangioscope, is electrohydraulic lithotripsy. We don't use it routinely in our center, but this is something which is becoming gradually popular with a good success rate. So there's not much data which is compared EHL with laser, but this is an article which was published 4 years back, which showed that both are good results, but EHL is somewhat inferior in terms of duct clearance and complications compared to laser lithotripsy. Now, I'll just show you a few cases. This was a patient with Mirizi syndrome. You can see in the radiographical pictures that there's a stone at the cystic duct, which is compressing the bile duct. So I'm going with a spyglass cholangioscope and I find the stone at the cystic duct opening. So this was broken with a laser and complete clearance was achieved in one sitting itself. And these stones were removed and you can see two lumen. The larger lumen is actually cystic duct and smaller lumen is the bile duct. And then a stent was placed temporarily and this patient with cholangitis was managed effectively. Now, this is another patient, which is, as you can see, a small stone in the left hepatic duct here, in the peripheral part of the left hepatic duct. And if the video runs, we could reach, this was very difficult to tackle because the guide wire will not go across. And so we could reach that with a spy scope and then manipulate the guide wire and then the stone was removed. Now, this is an intraductal stone, which was tackled by spy basket. So spyglass is going in, as you can see. And we failed in the routine ERCP to sweep this stone, which was not very large. And it was a little very frustrating. So when we entered over the guide wire, we found that the guide wire was a different reticle and the stone was in a different reticle. So we manipulated the guide wire with the help of tip of the cholangioscope, introduced the guide wire into the system in which the stone was there. The stone was not very large, but could be caught with spy scope, spy basket, and then it could be removed, as you can see, with the spy basket, which was passed around. These are small stones, but can be very frustrating because sometimes it's not easy to remove them. Let me skip that video. Now, this is another case which we published last year in endoscopy. So this patient had a single stone in one of the sectoral duct on the right side, right posterior duct. And this was very difficult to tackle. So we removed again using the same technique of spy basket. This stone can be removed. And this patient now is on follow-up for 2 years, doing well and did not require any further intervention. Now, sometimes the guide wire placement can be very difficult at endoscopy, at ERCP, and you can see this looks like a complete cutoff when we are doing an ERCP. So we went ahead with the spy scope, went to that area and then manipulated with the tip of the cholangioscope, and the guide wire could be negotiated across that tight narrowing, and then a stent was placed. Now, the other uses of cholangioscope is that you can selectively decide which duct you need to enter, as you can do, as I'm trying to show in this particular video, that by movement of the tip of the cholangioscope, you can introduce your guide wire into the desired duct. And of course, in some cases, migrated stent, which may be difficult sometimes, very, very difficult, both in the pancreatic duct and the bile duct. Here again, cholangioscope can help us in localizing the stent fragments and then removing in the help of various accessories which are available. So what is my wish list for the next generation cholangioscope? It should be less expensive. The working channel, I would be happy if there are more than one. The diameter, if it is more than 1.2 millimeter. We still need better accessories. We need to have better imaging, maybe narrowband imaging or other enhanced imaging. And sometimes in dilated duct, to evaluate the duct may be difficult. And that's another limitation of this present scope. I do hope that some of these techniques, which I've tried to show in this video, would become available in future with the spy scope, nasobiliary drainage, biliary stenting, polypectomy, local ablative therapy through the spy scope, including argon plasma coagulation. A word about paroral cholangioscopy, not very commonly practiced, at least in our country. Some of the centers in Korea are doing it more routinely. The advantage of paroral cholangioscope is that it's a large working channel. It has enhanced imaging, but needs large sphincterotomy, at least 8 millimeter dilated duct, and it's technically much more demanding. So there are number of advantages, as I showed you, and this particular case shows how narrowband imaging can evaluate the small lesions in the bile duct, and you can take biopsies while you're using direct cholangioscopy. Now there are prototype new types of cholangioscope which has come, which can make the life easier. They have multiple bends so that it becomes more stable without complications. I'll spend 2 minutes on two issues. One is machine learning for classification of indeterminate biliary strictures during cholangioscopy. We have been a part of this multi-center, multinational study. So basic idea is that we gave the clinical presentation, the images, and the ultimate diagnosis, whether it was benign or malignant. And this was collected from 25 centers, including ours, 7 from Asia. The initial article was presented in American College of Gastroenterology. We had 227,000 training images and 56,000 validation images. And it could be seen that easily it could identify the site of stricture. Now, I just concluded Digestive Disease Week in Chicago last month. We had another paper which was the further study of this particular thing, and this had 667,000 images which were analyzed by artificial intelligence. And if you add the clinical parameters which were evaluated, then the area under curve could be 0.82 to diagnose malignant strictures. So I think it's a way forward, though these are early days of artificial intelligence for interventional biliary stricture. The last part which I wanted to mention, maybe I can have half a minute more, is can we do radiation-free, contrast-free stone extraction? So we have been a part of another multi-center randomized trial, which has just been completed, 250 patients, including 2 centers from India, including AIG, and it has been accepted initial data in DEN Open. So the result says that we could cannulate 89% of the patients into the bile duct without any radiation, without any contrast, and in 82% of the patients, this select group of patients, which are non-complex stones, could be managed without radiation and without contrast. So this is a way forward. So to conclude, friends, cholangioscopy has significant diagnostic and therapeutic impact. Indeterminate stricture diagnosis and stone management are primary indications. Spyglass 2 has much improved technology and is presently the standard of care. Direct parallel cholangioscopy is technically more demanding, not freely available, but has advantage for image enhancement and bigger working channel. Artificial intelligence and radiation-free stone extraction appear promising. So our journey is from better to best, but need to go beyond. Thank you very much.
Excellent talk, sir. When it comes to the pancreatic ductal stones and the laser and the cholangioscope, could you share a few points?
When I was asked this talk, I said, let's limit ourselves to biliary thing, because in 12 minutes, it's very difficult to cover biliary and pancreatic. I would say that it looks nice to talk about cholangioscope or pancreascope going to the pancreatic duct and doing the same as we do in the bile duct, but technically it is much more demanding. So there, the algorithm will be entirely different. You do a ESWL, and only in select group of patients, possibly you can try this particular maneuver.
Taking biopsy in indeterminate stricture. When we take the biopsy forceps out, sometimes it is very difficult. After taking one bite, you can't introduce biopsy forceps again. You have to come back. What are the technical tips?
So I think it's basically the changing the loop of the scope in the duodenum which matters. You have to make it more smooth, it should not be angulated. But we have seen a dramatic change between DS1 and DS2. Now in the DS2, we don't find such a problem. I think they have done some minor modifications in the system. This used to be a problem even for introducing a laser fiber, that you introduce the scope over the guide wire, and when you come out with a guide wire, the laser fiber doesn't go. But these were the historical problems which we have overcome, maybe with some expertise on our side and with the improvement of the technology on the other side. Perfect.
Indeterminate primary strictures, indeterminate stricture with plastic stent in situ. When we do cholangioscopy, the appearance probably changes. I don't know. It's very difficult to make.
I agree with you, Monica, that there are problems when there's a previously treated ERCP, some procedure has been done, particularly the stent has been placed. But my own experience is that dilated, tortuous blood vessels are still not seen even after you put the stent. You may find a little bit of irregularity, little bit of protrusion, and some bleeding or erosions at that side. But we don't see those classical dilated tortuous vessels which I showed. Those are still classical of malignancy.
The tissue diagnosis remains the mainstay for the patients to be taken up for any further.
I agree with you that multiple biopsies, you have the Rose technique or something to do inside the room, it is always good. But usually we would take 3 to 4 biopsies in such situation, and we are reasonably good results with that. You have to always combine the various technologies, and maybe some patients, EUS and the FNAC in these patients may be additive to reach a conclusion.
I would like to thank the speakers and chairpersons. For the next 2 sessions, I would like to invite as chairperson Dr. A.S. Purita, Dr. Ajay Jain, Dr. Ankit Dalal, Dr. Shivam Khare, and Dr. Manish Tomar.
it is our pleasure
please
to.
invite Dr. Binadir sir for his talk on US-guided biliary interventions.
Good afternoon. At the outset, I'm very thankful to Rajesh and Jubin and all the colleagues, Manoj, for giving me this opportunity to be with you this afternoon. The talk is on US guided biliary interventions. It's a very large topic, so we will try to skip some of the areas I will not cover. Maybe you can ask questions. So we have three non-surgical biliary access and drainage options: PTBD, ERCP, and EUSBD. And this is a comparative, philosophical comparative table, not results. And you can see that EUSBD, the access is better because you can go from the stomach through the liver, or you can go from the duodenum. ERCP is stuck to the ampulla. That's the nature of the procedure. PTBD, again, can be done from right or left side. Now, stent placement, again, you can have antegrade and retrograde with EUSBD. So you can go transpapillary or you can go antegrade from above, like PTBD. And post-surgical anatomy, duodenal stenosis, the access in EUSBD procedures is very, very easy, while for ERCP it is possible, but it is difficult. Again, gallbladder, the access is pretty easy for EUSBD. So if you look at these features, you realize that EUSBD provides a flexibility of approach depending on site of obstruction. If it's a hilar block, you do follow a different approach. Distal block, you follow a different approach. Over the past 2 decades, EUS biliary interventions have proliferated into multiple procedures, biliary access procedures like rendezvous, stone extraction, few studies, but promising, and mainly it is EUS guided biliary drainage. Out of that, you have the antegrade procedures and you have transluminal procedures, that is choledochorioidectomy, hepaticogastrostomy, and gallbladder drainage. So we will talk about EUSBD and leave the stone and other things aside. So what is the status of EUSBD for resectable lesions? You have a patient who has a resectable head pancreas, your surgeon refers him to you for reducing the bilirubin. ERCP is the gold standard. Has EUSBD been tried? Limited data. There are no prospective studies. So this is the first study which was published. Small number of patients, 21 patients, decent adverse event rates, and all patients could undergo Whipple's, no mortality. So preoperative EUSBD is technically feasible was the conclusion from this French study. This is a much bigger study published recently in Journal of Clinical Gastroenterology. This used both EUSBD and ERCP. It's a retrospective study, of course. You have 58 patients who underwent EUSBD and 87 underwent ERCP. In EUSBD, a variety of procedures were done. Clinical success was same for both procedures. Adverse events were non-significant, no significant difference. EUSBD group had higher clinical success and lower hospital stay post-surgery. Now that is the conclusion of this study. We need prospective data to see whether this is true or not. So what are the recommendations? The recommendations are, we do not have quality evidence right now, so please stick to ERCP for pre-operative biliary drainage and use EUSBD. If you want to use, my recommendation is just do a rendezvous. Don't do anything else. Unresectable distal malignant lesions is one area where there is a large amount of data which has become available in the past decade, and this is our study. which actually started it all. 2015, we compared ERCP and EUSBD, highly controversial paper. We got a lot of hate mail after that. But the results are what you are seeing in the next 7 years with randomized studies. There is no difference in the success rates and adverse event rates between ERCP and EUSBD for distal malignant blocks. Pancreatitis rates in difficult access group were significantly higher, and clinical success in duodenal stenosis was significantly lower in ERCP group. So there, if you see what we wrote is, thus EUSBD can be used in patients with or without duodenal stenosis and could be a potential first-line procedure for relief of jaundice in patients with malignant distal bile duct obstruction. Success of ERCP in the difficult access group came at the cost of increased pancreatitis and an increased number of sessions. So these were the conclusions, and following this, we have had a flurry of randomized studies published in the last 3 years. I will probably not talk much about the PARC study and Sham Vadrajulu studies, small number of patients. So I think we should not talk much about them. But then you have the Korean randomized study by Pike et al., which has a good number of patients, 64 and 61. Again, no difference. In fact, the adverse event rates in the ERCP group in this study was significantly higher compared to EUSBD. Most of us do not believe it, although it's a randomized trial. Recently, 2 months back, Anthony Teo has published a multi-center randomized study in gastroenterology. This is probably the best data to date comparing the two modalities. It uses a EUS-specific stent, Axios stent, 155 patients, and they did hot Axios and double plastic stent. ERCP, they used Wallflex. Again, technical success was significantly higher in EUSBD, and that was primarily because in ERCP group, 7 patients had duodenal stenosis. Clinical success was same, procedure time was significantly shorter in the EUSBD group compared to ERCP. Rest of the things were overall same. So this study probably conclusively proves that the two procedures are equivalent if you exclude duodenal stenosis patients. If you do the analysis by intention to treat, then EUSBD scores over ERCP. What are the society guidelines? So these are the ESGE guidelines. Recommended ERCP for primary drainage, but EUSBD could also be used. So little guarded recommendation. SGEI, we met and we made these guidelines. We are pretty unequivocal here. Both EUSBD and ERCP can be used as first-line options. So these are the society recommendations for distal malignant obstruction. I will not talk of hilar obstruction. The data is not very mature as yet. It is feasible, it is acceptable, but we need more data before we talk about EUSBD in hilar lesions. What are the unresolved issues? Which stent to use and which procedure to use? So CDS or HGS, the debate continues. We actually use it depending on the site of the block. For hilar blocks, obviously you will do HGS, not CDS. But this is the latest meta-analysis, which had 288 CDS and 309 HGS patients. And in this meta-analysis, early adverse events were higher in HGS and mean procedure time was longer for HGS. The jury is out. We still do not know about this. Should we use a LAMS or should we use a SEMS, because there are cost issues involved? So this is, again, a meta-analysis of 820 patients and not much difference between the two stents. So adverse event were tending towards higher for SEMS, but non-significant. Reintervention rates were also mildly higher in SEMS patients. So these are the two areas we have to look when we see larger studies comparing these stents. But for the present, you can use both the stents. LAMS or SEMS. I prefer SEMS. There is this very interesting study which is published recently in digestive endoscopy. 93 patients, they placed Axios. Stent dysfunction occurred in almost a third of patients after 5 months. Duodenal invasion. So before the procedure, if there was a duodenal invasion, the LAMS dysfunctioned much more frequently. So is it a contraindication for LAMS? And we do not know, but this is intriguing data. Presence of duodenal invasion probably increases dysfunction of LAMS in these patients. In the end, I'll quickly show you you have seen the live procedures, so I should not spend much time here. So you have, this is a patient of duodenal obstruction. This is a practical feasibility. Immediately change the scope. You see hugely dilated CBD. Oh, kya ho gaya bhai? This is the scope position, looking up towards the hilum, puncture, aspirate, inject contrast. Here you are, pass the wire, pass a cystotome, and place a fully covered stent or a LAMS. So the whole procedure should not take more than 10 to 15 minutes, pretty safe, pretty effective, and I would say pretty easy, easier than ERCP if you ask me. So this is CDS, and this is another procedure which I feel is very, very easy. Gallbladder drainage can be done for EUSBD if cystic duct is patent. Here you use a hot axios, it's even easier. We pass a wire because we wanted to pass a stent through this plastic stent. So do a gallbladder drainage. Very, very gratifying results, especially in patients who are acute cholecystitis. Patients recover dramatically, and you can place a plastic stent through it. So a lot of interesting advances in the past decade. The literature is maturing, and we feel it is coming there, but not yet there. Many technical issues need to remain solved. EUSBD, of course, could be preferred in patients with post-surgical anatomy and duodenal stenosis, needs further refinements in technology and better studies for us to know the real place of EUSBD in biliary obstruction. Thank you.
Thank you, Dr. Thank you, Dr. Theer, for that illuminating talk. Because in the last 20 years, we have seen a paradigm shift. At one stage, the only treatment for biliary obstruction used to be a PTBD, which came with its own set of complications. And since then, as I mentioned, there has been a paradigm shift. We hardly need to send the patient for PTBDs.
Right.
But just to set the ball rolling after your talk, I just wanted to ask you, in those patients for distal malignant inoperable biliary obstruction, what proportion of the patients are you doing EUS guided drainage versus ERCP?
95% ERCP, 5% EUSBD.
So do you think that ratio will change, and when do you think it will change?
Yes. So, in my opinion, the two procedures are equivalent, and that gives ERCP the edge. If we had shown that EUSBD is superior, then there was no question. If the two procedures are equivalent, the tendency is to continue to be with the procedure which is time tested. ERCP is around for 5 decades. So unless something technologically changes, I have issues with the LAMS design, some other things. Something happens where the procedure becomes so easy that, like the gallbladder drainage, I like gallbladder drainage more than EUS-CDS because it's much easier. So if something like that happens, then automatically the whole thing will shift, or we show that it is superior. So far, there is no study which shows that EUSBD is superior to ERCP.
Dr. Goenka, please. Use the mic, please.
Type 3, I would start with ERCP and try to place at least 2 stents. If there is a cholangitis and left lobe is not properly drained, then only I'll go for EUSBD of the left lobe.
So what about draining the right lobe through the PTBD, through the EUS?
It's a emerging technique. Again, I think we are technologically hindered. We do not have, we can do it. It's not a problem. We can place a stent in the right system. But technologically, it's a little challenging. We need better technology before we become comfortable with the procedure. Yeah.
So in like lower CBD block, if cystic duct is away, then you prefer to do CDS or through gallbladder drainage?
So far, the data suggests CDS, but there is emerging data of gallbladder drainage in patients exactly what you described. I believe once we have enough data, the surgeons used to do cholecystoduodenostomy. The only problem is when the cystic duct gets blocked, there is an issue. So, but we need more data before it's a great technique, gallbladder drainage, but we need more data.
In EUS CDS, how do you choose between flange metallic stent versus lamps? The cost is the difference.
Yes.
So how do you decide?
So for me, as I said, vast majority of my stent patients go for fully covered, self-expanding metal stents. Axios is reserved for those insurance patients who can afford and who have a nicely dilated CBD, more than 15 millimeters. If they are 12 millimeters, I will be hesitant.
That will be the last question because we're running 5 minutes behind time. So that will be the last question.
If you put lamps, why to put a plastic stent into it?
Yes. So a plastic stent is put exactly like why we put plastic stent in the wall. So the wall, especially in patients with acute cholecystitis, the wall is angry, gallbladder wall, and it is thin. And this is a tough stent. So you keep a plastic stent to keep the opposite wall away from the edges of the lungs. So it allows the flow to continue.
Thank you, Dr. Vinay.
Thank you.
Now I'd like to introduce our next speaker. That's Dr. Sandeep Laktakia from Asian Institute of Gastroenterology. He'll be talking about US guided pancreatic duct interventions. Over to you, Dr. Sandeep.
Thank you, Ankit. Good afternoon, everybody. At the outset, I would like to thank Rajesh Puri, Manoj Sahu, and the entire Medanta team for inviting me to this wonderful meeting, International Pancreatic Biliary Congress. I'll be speaking on US guided pancreatic duct interventions, standardizing the technique. So EUS guided interventions for pancreatic duct, we consider for some of the reasons which I'll allude to later. In this talk, I'll also cover the prerequisites, the types of EUS pancreatic duct drainage, how to do an adverse events and prevention of some of them. So EUS guided PD intervention is generally considered as a Waterloo. It's the most difficult of all the interventions by EUS and should only be attempted only when no other options are available or feasible. Coming first to the indications, when the patient has a dilated pancreatic duct with possible ductal hypertension, which is the cause for his pain, and hence it needs drainage. Not always duct which are dilated need to be drained if the patient does not have pain. So we presume that dilated duct is equal to the pain in that patient, although there can be other reasons for pain, and that can be discussed later on. And some of these indications for dilated duct and pain is chronic pancreatitis, patient having anastomotic pancreatic duct stricture, especially in the Whipple's scenario, disconnected pancreatic duct, patients who have external pancreatic fistula drain put for percutaneous drainage for catheter for the acute necrotizing pancreatitis, which then ends up in a fistula and continuous drainage of fluid. Or if ERCP has been attempted and failed or is not feasible, psych and surgical altered anatomy. So this is a toolkit which I would like all of you to take a picture of, those who are doing this procedure, that first and foremost, you need a very high quality fluoro machine. An average fluoro machine, or which is not showing you wire and needles, And contrast, I think better not to do, because then it will end up in mishap. Even with the best of technology, sometimes we fail. And this is most paramount, I would say. Accessory that we normally need is a 19 gauge or a 22 gauge. Wires can be all sizes. 025 is the most preferred, but other directions also can be used. 6 French over the wire cystotome is a must device. It's not available in the West. That's their problem. But it's available in India and one must use it. And guide wire should be both angled and a straight. Angled is preferred. Both short and long wire can be used interchangeably. But my first wire is a long wire and an angled tip wire 025. A bougie, if you have, is an added boon. Some of the bougies from the Japanese colleagues are very good. And if you have friends from there, try to borrow it from them. Always use a stiff stent, either a straight or a single pigtail, not the stents which have multiple side holes in the center of the stent. One should synchronize with the team in the room. Not too many people in the room, only few important people whom you can just wink and tell or say, give a sign with your technician, your fluoroscopist, your assistant, and 1 or 2 persons more in the room. One should have very good knowledge of ERCP. One should have good idea of wire manipulation and stent placement. And the patient position either should be prone or supine, not left lateral. You cannot change the position in between. So start and finish in the same position from beginning to end when you're attempting this procedure. Let me show some video cartoons here. This is borrowed from my friend Masayuki Kitano from Japan of EUS guided PD intervention rendezvous procedure. When you're failing by ERCP, but some reason the wire is not going, so you can come from top down just like for biliary procedures and pass the guide wire across the papilla. Then you can exchange the scope with an ERCP scope, catch the wire and do it similarly like you do for a biliary intervention. The other one is a pancreatic gastrostomy, where the wire does not go across the narrowing and bounces back from the stricture, and then you are obliged to now drain the duct upstream to the stricture from the stomach, and that's called as pancreatic gastrostomy. Simple. Okay, moving forward. So how do we decide the algorithm, which procedure to use when? So it depends on the anatomy, a normal anatomy or an altered surgical anatomy. What is the position of papilla? It's accessible, not accessible, or absent. Quite similar to a USBD. It's actually modified from the same algorithm. Indication now, because there we have malignancy as an indication. Here we have a benign disease as an indication. It's chronic pancreatitis or disconnected pancreatic duct are the most common indications, and the site of the block. So if it's accessible, obviously we'll try with ERCP first. If it fails, then we can try US rendezvous procedure. But if not accessible, then we do EUS guided PD drainage. And in this, we have 3 options. Permutation combinations is retrograde transpapillary. I'll show an example of all 3 of them. Retrograde transpapillary, that is rendezvous procedure. Antegrade transpapillary, where a wire goes across the papilla. You have an option of either exchanging the stent, a scope for a duodenoscope, or if there's altered anatomy or you don't want to change the scope, you may sometimes lose wire in between. So might as well drain the stent from top down. And the stent tip can be across the papilla, can be just at the stricture. And third is a transmural, where it can just be a pancreatic gastrostomy, as I showed in the cartoon. The stent tip can be towards the stricture or towards the trail. That's the difference between anterograde and retrograde. And pancreatic bulbostomy, where the bile pancreatic duct is almost coming to the papilla, but somehow you're not able to enter transpapillary. But it's a nice dilated duct, and you can come from the duodenum and create an excess opening there. So let me show the example of all 3 of them. This was a patient with chronic pancreatitis. ERCP is failing. The contrast is just not going into the upstream duct. The MRCP suggested a dilated duct, and then we came from top-down approach. Fortunately, the contrast fills the stricture and comes to the papilla. This is a very good situation to have, and wait for this to happen. If you see this, that's a favorable anatomy. Negotiate your wire across the stricture into the duodenum. This is a stricture. Negotiate your wire. It will go across. And once it goes across, then you can change. In this patient, we did that. We also did a place a stent then through a duodenoscope. Pancreatogastrostomy, let me show you a small video of this. One should look at the duct. If it is reasonably dilated, then only attempt. And this is quite a nice juicy duct, 8-9 millimeters or so, punctured towards the proximal body, towards the genu side, so that the guide wire looks at the papilla. Papilla is somewhere here. So a contrast will fill it up, get the roadmap right. And then pass the guide wire. So always keep looking at the needle and the guide wire. Once you have the guide wire, never lose this EUS image of the guide wire. That's a lesson, very important lessons for all the beginners who are doing it. In any EUS interventions, never lose the guide wire on the EUS image. And once it is done, then you pass a cystotome, dilate the path exactly like the same way. And here you are now able to pass the wire across. And either you can convert to a roundover procedure, but here we continued and placed the stent antegradely. And once it was done, then we also came through the papillary side and then placed another stent from the transpapillary. So we had a double way of placing, but that's okay to do that because in future we have to do transpapillary only. So the tips and tricks is you can also take a picture of this. The puncture needle that we use first has to be without a stylet, preload with a dilute contrast, 1:1 or even maybe 1:2. Don't aspirate too much, unlike biliary system. Just a small aspiration or no aspiration is actually good enough because you see your tip of the needle in the PD. Inject some contrast, not too much, small amount of contrast, just get that you have seen it's in the duct and nowhere else. The first guide wire is the most important wire. You should not keep changing wires. It should be angled, long, hydrotropic wire, and 025 is my preferred asset. Avoid undue withdrawal. Don't try to manipulate. If you try pulling out a wire with a needle inside, it's going to shear. And once the wire gets sheared, you have to start all over again. By this time, your duct is decompressed. It's become smaller in caliber. There's a juice leak across, and you're likely to fail more now than you started off with. And quick exchange of accessories to avoid ductal leak. At this time, the talking should be as less as possible. I'm sorry, I also did today in my procedure, but the intent was to fully concentrate on the case in front. It may disturb some people in the audience or if you're transmitting live, but I think the patient in front is the most important person in the room, and we should able to do what we are trying to do in the beginning. The second person in the room can then take over the communications. If you have anatomy like this, it's a very juicy duct. You can, ERCP is failing. You pass the wire, which now goes retrogradely. Don't worry, you can also place a wire. This was one of the earlier ERCP where I used a double pigtail stent, but I would have now preferred a single pigtail stent or a straight stent. Another video example which I would show is a patient who had outlet obstruction from chronic pancreatitis. Some of you may have seen this video before. This is having pain and outlet obstruction. He was severely malnourished, and EUS showed small pseudocysts, which also could have been drained, and there were ducts which are dilated, which I preferred to drain because there were more than one pseudocyst. And then finally, we could place a stent. I'll rush to some of the slides next. In altered surgical anatomy, this is one of the starting points where you can use it, especially in a post-Whipple scenario. I'll skip this video for the simple reason that the pancreas is soft and you're likely to succeed more often in a post-Whipple scenario than in a chronic pancreatitis. Disconnected pancreatic is another indication where the disconnection can be short or long between the two segments. And the short segments look very attractive, but often it's so scarred at the absent pancreas that nothing goes beyond. And this is how it evolves. We heard a very nice talk from Dr. Rana in the morning that pancreatitis causes necrosis of the duct, which leads to fluid collection. And once you drain it off, the parenchyma actually atrophies over here, and there is no communication between the two segments. This can also be a situation in an external pancreatic fistula, which may look on imaging like this. In spite of a plastic stent being there, the duct is still dilated upstream and having pain, causing pain. So we need to do something for these patients. So disconnected duct should be attempted to be managed by interventions is if they have recurrent pancreatitis or pain, recurrent pancreatic fluid collection, or persistent external pancreatic fistula. Some of the examples I will just show here. This is a patient with disconnected duct. Every attempt at ERCP fails. You have SNization, but upstream duct is not filling except the small collection. Maybe next minute or so I'll finish off. And then we did same time EUS guided conversion. We could fill the entire duct from the head, from the proximal body to the tail, including small collection, and place an antegrade stent, which is what I said in the beginning, antegrade stent. It can also be a retrograde stent when the wire goes towards the tail and you're punctured quite towards the head side, and then you place a stent. The third situation is pancreatobulbostomy, where this patient had a chronic pancreatitis with stricture. Nothing is filling upstream, but on EUS, we find a very juicy duct from the duodenum, which is about 8 millimeters or so. We punctured that and then passed the guide wire across. In this position, the scope is very stable. So that's why if you have an option of pancreatobulbostomy versus gastrostomy, choose bulbostomy as the option, because scope is always stable. And this is the final stent position, which automatically becomes stable. And then you can sometimes find surprises where a disconnected duct actually is not disconnected, but is connected with a small rim of pancreatic duct, and which can be then rejoined by a stent, as in this case, which this is a patient who had a disconnected duct on MRCP, but here the upstream duct got filled up and we could place a stent transpapillarily. Another case like that, I'll just skip this. And in the end, adverse events are known to happen with EUS pancreatic drainage, including pain abdomen, bleeding, duct leak, and failure of completion procedure. Pain abdomen is usually transient. Within a day or so, it subsides. Bleeding is rare unless you really puncture a big vessel. So prevention is to align the pancreatic duct with your needle. Don't puncture perpendicular, but at an angle so that you get the longest duct there. Avoid needle knife for fistula perforation can cause. Straight stents are preferred, and avoid stents with central holes to prevent any leak. So take home message: EUS guided PD intervention consider only in special situations, in chronic pancreatitis, anastomotic PD strictures, disconnected duct, and external pancreatic fistula. Rehearse before you start the procedure. Use all the tools available. Good MRCP is important, and 6 French stent, cystotome, and bougies are important. Thank you very much for your very kind attention.
No question, please. Can we move to the third talk now? Thank you very much.
Thank you, Dr. Sandeep.
Great and valuable talk by the speakers. I would like to thank the chairpersons for expressing their expert opinion on the subjects. For the next 2 sessions, I would like to invite as chairperson Dr. Monish Chabra, Dr. Samir Mohindra, Dr. Rajkumar Wadhwa, Dr. Daksh Khurana, and Dr. Manoj Kumar.
Good afternoon, ladies and gentlemen. I would like to invite Dr. Mustafa for the next lecture.
Okay, good afternoon, everyone. So really, it's my honor and pleasure to be here for the first time. And special thanks to Professor Puri for inviting me. So I'm going to speak about RFA and pancreatic lesions. So a little bit of what is available, literature, and then really, do you have any missing thing or not? So radiofrequency ablation is not a new thing. We have been using this at HSCC for years. We have been using this. Surgeons have been using this intraoperative. In the biliary also, we have been using this a lot. But now the idea is to use this via the EUS is a little bit something new. So the available devices for RFA in the market, we have two different categories, either doing RFA without an internal cooling system, like the Habib Pro, for example, from Boston Scientific, or having the internal cooler system like either the Hybrid Therm or the StarMed. So this is one of them. This is the Radiolix, which is does not have any cooling system. Habib probe is a very thin probe that accommodates inside the EOS needle, and a little bit under research now for EOS RFA. The most common used device is the StarMed, which is accommodate an internal cooling system with also an insulator tip. So you have here, yes, you have the part where you have the radio frequency and you have the cooling part. So this is a very short, just to show you, as I said, this is the RFA part and this is the insulated part. And it is a preloaded inside a EOS needle with a very special generator. I'll show it you in a second. So this is the set. So you have the generator, you have the cooling system, and you have an input and output always of the cooler system, of this cooling system. So the idea is simply when you detect the lesion, you start having always the radio frequency ablation from distal to proximal. It's very important to understand that the tip of your needle is just doing radio frequency 360. So which means if you are outside of the lesion, you are burning a normal pancreatic tissue. So you can see here, this is the idea, and then you start pulling back. And again, very important when you pull back for the last time, I will show a little bit of cases now. You should be sure all inside the lesion. So question for all of you, if you have 2 centimeter net tumor in the head of the body of the pancreas of a 45 years old, what you are going to do? This is a non-functioning net. Who will do a follow-up? Okay, who will send this patient to RFA? Yes, we have the big boss. Who will do surgery for this patient? Okay, could I ask just 1 second? Please, why surgery? He's 45 years old, 1.9 centimeter lesion.
2 centimeters is, I think, would be the cutoff line. Anything more than 2 centimeters, you would, the high chances of having nodal metastasis.
So this is very important. This is very important message is lymph nodes. So this is now, till now, all the literature supporting is this 2 centimeter number, because it's not about that we cannot ablate. We can ablate a 5 centimeter lesion, but the idea that 5 centimeter lesion 100% had a lymph node metastasis. So we have a lot of studies. Most of them are small series, but all of them, they showed efficacy of the technique. So this is one of the oldest one, about 12 patients with net tumor. And you can see you can see that the response is, we have 86% of tumor resolution. One of the technical tips that you should put in mind when you coagulate, when you do RFA for a net tumor in the pancreas, it will not disappear on the spot. We are doing necrosis in this area. So the lesion will be there. However, in this study, this is very interesting. When they follow up this patient after 3 years, we have 85% of complete disappearance of this necrotic tissue, this necrotic area post RFA. However, still there is recurrence, and this is my second message of the day. When you do RFA of a lesion of 1.8 centimeter, don't just let this patient go home forever. We should follow up this patient. Again, this is another case series of 10 patients with 12 net tumor. And you can see this is the follow-up at 6 months and at 12 months. You can see this is another study, a retrospective study on 27 patients, and we have a complete response in 93%. So till now, the idea that yes, we can ablate a 2 centimeter lesion with a on-spot diagnosis that we have completed the ablation. Again, this is a bigger study. This is a bigger study on 61 patients where they have functioning and non-functioning net and effectiveness of 95%. Another question to all the professors here. If you choose to do RFA between functioning net of 1.5 centimeter and non-functioning net, who is with functioning net? Who will ablate a functioning net? Who will ablate more a non-functioning net? Yes, I ablate both. However, I ablate if by contrast EOS, and I'll show you a video now, if I can find this 1.4 functioning net, I will ablate it. Because sometimes this is technically very, very difficult for a surgeon to find if it's a very small, especially if it's functioning, hormonal functioning. So in conclusion, yes, we can ablate. As you said exactly, Professor, that it's 18 millimeter. This is our border that this is associated with the best results. If you have bigger than that, yes, we have more risk of lymph nodes. This is a very recent systematic review and meta-analysis on 19 studies, and you can show in both in functioning net and non-functioning net, it's very effective, and you can see the significance in both groups. So this is one of the cases from the last workshop from Professor Giovannini. You can see here. Sorry. So this is, I'll just start this from the start. Yes. This is the net tuber. So as I said, it's like any normal EOS needle. You put your needle. It's very important to put your needle till the end here, and then after that you start ablating. So I need to have sorry. You start ablating distally, and then the good thing in the system that it will stop. Because this internal cooling system, it will not over ablate, I would say. And then you pull back and you continue your ablation. I always do this, and this is, I will show you here, even in this video. So this is now almost completely ablated. I will show you this just at the end here, contrast. So I always do this. If I do net, I do contrast enhanced EOS before and after. So we all know that net tumor are a hyper enhancing tumor, and a necrotic area is a hypo enhancing tumor. So you can see here, this is after the ablation. It's a hypo enhancing tumor. This means that you have ablated most of the tumor. Another case from Professor Devier workshop. Same scenario, it's a tail lesion. So this is we did contrast enhanced before the lesion. You will see the image now. So on the left side, this is the B mode, and on the right side, this is the contrast enhanced image. And you can see it's a hyper enhancing lesion where it's just grasp the sonoview. And then this will be followed by the ablation technique. It's the same technique of the last case, where you have your needle, you go with the needle till the distal part, you start ablating step by step, take your time till you have this continuous ablation. It's very important technical message here. Number one, you should not push the needle beyond the lesion because you are going to start ablating a normal pancreatic tissue. Number two, it's very important to know when you start ablating, you have this white bubble, so you cannot anymore delineate anything. So it's very important, the starting point where you put your tip of the needle, it's very important, and then you withdraw, and you finish, you always think that you have this 1.5 centimeter of the insulator part, which will be your last part in the proximal area. And I can show you at the end of this procedure here, where we did again contrast enhanced EOS, and you see it's an hypo enhancing lesion. So this is the good thing of RFA. If you combine this with contrast, you can on real time say, okay, we have ablated this, and then we will just follow up this patient. And just again, remember, we should not let this patient go home for years. We should do follow-up for these patients. So yes, we have adverse events. So we have acute pancreatitis, infections, sometimes perforation However, there's a little bit of case reports giving the idea just to treat this patient as prophylactic as ERCP. Again, no guidelines. However, the most important thing is to correct the correct setting of the device, which means you should not over ablate any lesion just to avoid necrosis of pancreatitis. So as you said, the 2 centimeter figure is the whole work. More than 2 centimeter, even if we can ablate, we should not, because there is a high risk of lymph nodes. Less than between 1 and 2 centimeter, less than 1 centimeter, a little bit risky, because now you are sure that you will ablate a normal pancreatic tissue, because of the tip of the needle is will ablate a diameter of 1.2, 1.3 milliliters. So if you have a lesion of 6 millimeter, you should follow up this patient. You should not ablate. Yes, we are missing a lot in this area. So it's something very new. We are missing studies for patients that they are surgically candidate. Now we are only evaluating patients not surgically candidate. We need more of head-to-head studies, and we need more of studies regarding functional net. So my take-home message: yes, EOS an emerging modality with very high technical success and accepted side effects. It could be alternative for surgical resection for a very specific group of patients. However, prospective study should be done. Thank you very much.
Excellent talk, Dr. Mustafa.
Thank you.
I have 3 questions for you.
Sure.
Number 1 is, other than the size and mitotic index, do you look at other features of morphology? For example, closeness to pancreatic duct. For example, if there's a tail net and which is close to splenic hilum with extensive collaterals.
Sure.
Number 2. Number 2 is, how do you define effectiveness of a therapy? For example, doing EUS contrast or doing a simply contrast enhanced CT scan, that will be
okay. Thank you very much. Question number 1, if it's near to the pancreatic duct, I will try to avoid to do this, to ablate inside the pancreatic duct. Number 2, yes, if it's very distal to very near to the hilum of the spleen, again, this is very risky. Regarding the follow-up, I'll do both of them. I will do immediate contrast enhanced EOS post-procedure, and then I follow this patient mainly by MRI after 1 and 3 months.
Yes, sir. 1 session is enough, or you require multiple sessions to ablate the tumor?
Yes, sometimes you need, but if I do the first session and I have contrast and I see that still there is a hyper-enhancing lesion, I will do a second session for this patient in 2 weeks, 3 weeks. I will not do it immediately just to avoid a bigger area of necrosis.
So any heat sink effect in this procedure with the RFA? Heat sink effect?
Sorry?
Heat sink effect if there's any vessel nearby?
No. I think this, because you have this, if you are using one of this cooling system, so yeah, no, you don't have a problem with this.
Thank you so much,
Thank you.
Dr. Mustafa, for an excellent talk.
We are in for a very interesting debate, and the topic is EUS guided biliary drainage versus ERCP for primary treatment in malignant biliary obstruction. And for the motion, I would like to invite Dr. Praveer Rai, who is a professor in Department of Gastroenterology, SGPGI. He'll be speaking for US.
So a very good afternoon. I think for this debate, it's very difficult to do this debate, especially once you have not been able to complete the procedure. I think Dr. Amol must be very happy at that. But anyways, so we'll try to convince you that EUS guided biliary drainage is the primary modality that should be used for distal malignant biliary obstruction. And why do I say that? Let's see. So if you see the current scenario, ERCP with biliary stenting was first established in 1980. And after that, as you all know, that ERCP and transpapillary SEMS is the mainstay of treatment for malignant distal biliary obstruction according to the international consensus. However, there are issues. What are these? Difficult cannulation, adverse events, and stent dysfunction. So biliary cannulation can fail around 0.5 to 16%, even in expert hands, and maybe higher in novice. Cannulation failure can be because of edema, friability of the duodenum, distorted ampulla, or duodenal narrowing. So in these cases, you need to do a pre-cut or a fistulotomy, which leads to significant rate of adverse events to the tune of around 2 to 34%. And there are meta-analysis to show you that 25 to 45% of the patients undergoing ERCP for malignant distal biliary obstruction have duodenal involvement by the tumor. And there is a direct correlation between the procedural complexity and the adverse events. Post-ERCP pancreatitis less than 3% if the cannulation time is less than 5 minutes. However, if the cannulation time is more than 10 minutes, then the risk of pancreatitis is more than 10%. And despite successful intervention, that is, even if you have been able to place the stent, you can have stent dysfunction due to occlusion or the migration. Covered stents are designed for this, and even these tend to migrate or cause polycystitis. A look at US guided biliary drainage was first established in 2001, that is 21 years after ERCP, and it's traditionally performed after failed ERCP. And according to the site where you puncture, it's known as choledochoduodenostomy, hepaticogastrostomy, antegrade biliary stenting, or a rendezvous procedure. And the international consensus for management of malignant distal biliary stricture recommends that if expertise is available, US BD may be an effective option for failed ERCP, difficult cannulation, or a post-surgical anatomy. In a failed ERCP setting, if you see the success rate of USBD, it is to the tune of around 94.7%. Again, not 100%. We saw that today. Clinical success, 91%. Adverse events, there. But this study is again 2016. In more recent study, the complication rate is further less. So primary US-guided biliary drainage versus ERCP, there are randomized controlled trial which show that a high rate of technical success and acceptable safety profile. I'll come to these randomized controlled trials. And there are observational studies which tells you that USBD can be effectively achieved successfully in greater than 90% of patients who have failed ERCP. Hence, the logical question arises that can US replace ERCP as the primary technique of establishing biliary drainage in malignant distal biliary obstruction? So which is better? So to answer this, we need to know about the optimal clinical outcome, that is technical clinical success, adverse events, reintervention rates, stent patency, and quality of life. We're looking at the cost, procedure time, and training. So first, focusing on clinical outcomes. So this was the first randomized controlled trial between US-guided biliary drainage and ERCP for primary palliation, means that you're not attempting an ERCP, you're directly going ahead and doing an US-guided biliary drainage. 125 patients here, 64 and 61 in the ERCP group. High technical success, clinical success was also high in both of the groups. So technical success, clinical success was similar. However, this study showed that for USBD, the stent patency was better. Adverse events were less, 6.3% compared to around 20% with ERCP. Reintervention rate was less, and the quality of life at 12 weeks was better. Then came this another second randomized controlled trial, again 34 in ERCP group and 33 in US-guided biliary drainage group. Adverse events, technical success, stent dysfunction, treatment success at 4 weeks was similar in both of these two groups. So this study showed that neither USBD was superior nor it was inferior, so both are equivalent. Then came this third randomized controlled trial, again 2018, which again showed, however, if you see the sample size here is just 14 and 14 in each group, no difference in the different parameters. What this study particularly showed that in USBD had lesser cases of tumor ingrowth, but more cases of food impaction or stent migration. So that's one of the problems, the stent migration and food impaction. Now, this is just a month back, this became online, not even a month. This Dr. Anthony must be sitting here. So he has done this excellent study, randomized controlled trial between US-guided choledochoduodenostomy versus ERCP guided drainage. So 79 and 76 patients in both groups. If you see, the technical success was better in US guided drainage, and clinical procedural time was less.
That was 10 minutes in US guided versus 25 minutes. So as you saw today, the case, the ERCP was done. It took around 25 to 30 minutes for the procedure to be completed. Other parameters were similar. So once you have these randomized controlled trial, which are contradictory, you need a systematic review and meta-analysis. And this is what was done. 3 randomized controlled trial, 1 prospective and retrospective studies, which again showed that clinical success was no different. Adverse events were similar. However, the pancreatitis was significantly higher for ERCP, and there is no significant difference in the rates of intervention. Again, slightly different from what was showed earlier. Following this, we have, again, 5 more systematic review and meta-analysis. And what you need to focus on is that in these 2 meta-analysis, it was said that ERCP, the risk of pancreatitis is more, the risk of reintervention is more. So these are the 2 important takeaways from these meta-analysis. So if I summarize this, so EUSBD has a higher technical success to ERCP in the majority of patients and a comparable clinical success and safety profile. The most common adverse events for ERCP is a post-procedure pancreatitis, which is minimal or does not happen with EUSBD. Reintervention may be less with EUSBD compared to ERCP. There are certain issues with EUSBD. You have different routes through which you can do the procedure, colorectoduodenostomy, hepatogastrostomy. Therefore, the technique has not been well standardized. However, if you see a systematic review and meta-analysis, it tells you that whether you do a colorectoduodenostomy or hepatogastrostomy, the result is the same. There is no difference. Moreover, this problem of food bolus impaction or stent migration has been resorted. Moreover, the increased amount of bile leak has been sorted by development of new single stem device, that is cautery enhanced lamps. And these dumbbell shaped lamps, along with long double pigtail stent placed through this, avoids the risk of migration. Coming to the cost, USBD is less costly compared to ERCP when used for primary palliation. Why do I say that? Based on this retrospective study, because the number of hospitalization due to reintervention increased. Therefore, the overall procedure cost was significantly higher in ERCP compared to EUSBD. If you talk about the procedure time, again, this study clearly shows the procedure time was around 5 minutes compared to 11 minutes for an ERCP, which again was statistically significant. And this decreased procedure time is primarily because the one-step stent deployment systems that are being used now, especially for colorectoduodenostomy. Just a word about training. So if this was a very good study conducted in 2017 by Wani et al. So what they showed that the more trainees achieve technical competence in basics of EUS than in ERCP, a difference of around 60% in ERCP while 82% in US. So ERCP, again, as you know, requires excellent hand-eye coordination and full command of multiple maneuvers to find optimal angles for cannulation. So this is our society. If you see the recommendation based on this society, it clearly recommends that both USBD and ERCP are the first line options for biliary drainage in distal malignant biliary obstruction. For hilar block, you obviously need a multidisciplinary team approach. Just to conclude what I have said, in case of surgical altered anatomy and duodenal obstruction, you can do an US guided drainage. Reintervention rates are less, stent patency is more, papillary manipulation does not happen, does not lead to pancreatitis. It bypasses the malignant stricture, which leads to lesser risk of tumor ingrowth. One-step stent deployment technique is faster for USBD. Overall cost is less. Only issue is with procedural, which may be a bit more challenging with EUS compared to ERCP. So to summarize, so EUSBD has higher technical success and a comparable clinical success and safety profile to ERCP in malignant distal biliary obstruction. It should be the primary treatment for patients with malignant distal biliary obstruction. ERCP being more widely available, the transition from ERCP to EUSBD will take time, but should happen. Thank you.
Thank you, Dr. Praveer. You have defended USBD. Now I'd like to call Dr. Amol Bapai, who is going to speak for ERCP, and let's see how he's going to compete with you, Praveer.
Good afternoon, and thank you, Rajesh, for the kind invitation. And thanks to Praveer for setting up the stage for this exciting debate. So, primary EUS biliary drainage versus ERCP for malignant biliary obstruction. Let me start with a few disclosures that we presented the first EUS CDS as well as first AGS way back in 2005, 2006, and it was in the Delhi Endocon that we presented our video. We don't have any recent publications on ERCP, but we do have more than 10 conference abstracts and papers on EUSBD. Selective cannulation rates at our centers in ERCP are 99% plus, and rates of pancreatitis are around 2.3%, with CVR being 0.3. So Praveer mentioned that EUSBD is superior than ERCP because of risk of pancreatitis and other complications. Also because ERCP can produce failed cannulation and it cannot be performed for an inaccessible papilla, which I do admit and we agree to that. But does that mean that it becomes the primary modality? Well, we have a lot to discuss about that before that. So let us revisit these factors in a little bit more detail. Let us look at the incidence rates of post-ERCP complications. This is a meta-analysis, a relatively old study, but let us look at the numbers. That severe post-ERCP adverse events in form of severe pancreatitis 0.4 and that's 0.1, bleeds 0.3 and that's because of bleed 0.05, perforations very minimal, infections again very minimal. Another more recent study, post-ERCP pancreatitis and the severe pancreatitis in most centers, probably less than 1% or around 1%. And it is globally, across the globe, the incidence is quite similar. So therefore, the overall risk of post-ERCP pancreatitis, although has been reported to 9%, the severe pancreatitis is quite less, which is actually the matter of concern. And we know that the risk factors for post-ERCP pancreatitis, according to Martin Freeman's this celebrated study, is female gender, younger age, normal serum bilirubin, absence of chronic pancreatitis, and actually factors like chronic pancreatitis, older age, and malignant obstruction are supposed to be protective against post-ERCP pancreatitis. And therefore, ERCP-related adverse events in malignant biliary obstruction patients are inherently lower. They have an inherently lower risk of post-ERCP pancreatitis. And although bleeding can be may increase after an endoscopic sphincterotomy, it has been demonstrated that you do not need a sphincterotomy before placing a SIMS. And therefore, the overall severe adverse event risk is very low, even lower than in malignant biliary obstruction. Looking at the success rates and adverse events of EUSBD in comparison, the average reported success rates are around 90%, and the adverse event rates range from 3.4 to 38.6, and they average somewhere between 17 to 19%. And they have mentioned that CDS is superior to hepatogastrostomy for adverse events. And the nature of adverse events during EUSBD are predominantly bile leak and peritonitis, as well as bleeding, cholangitis, capnoperitoneum, and occasionally stent migration. But majority of these are quite severe, and they may require, particularly bile peritonitis, may require surgical intervention in patients who are otherwise unfit for any surgical intervention and they're only for palliation. So that's a question that we need to ask. We also have measures to reduce post-ERCP pancreatitis, but do we have any documented methods to reduce adverse events during EUSBD apart from improving our technical skills? Coming to the cannulation rates, this is the paper from the Orlando group, which Sham showed the randomized Praveer showed the randomized study subsequently from the same group. But this study a few years earlier has mentioned that when they looked at their EUS biliary drainage procedures, the success of selective cannulation at ERCP was 99.4%, and only 0.6% patients actually required the EUSBD procedure. And the rates of selective cannulation at ERCP has uniformly been quite high, above 90-95% whenever the papilla is accessible. Coming to the subsequent discussion about availability and training for ERCP versus interventional EUS in general. The US NIH data mentions that about 5 lakh ERCP procedures are performed annually. In the Indian scenario, there are definitely more than 1,000 centers. I think this is just an approximation which I made because I could not find any data. But there are about 400 installations, which I got this information I got from the industry. However, only 20% of these centers perform any kind of EUS guided interventions. Therefore, only about 80 centers are actually offering EUS guided interventions in general. How many of them are performing EUS guided biliary drainage? Probably fewer than this. And competency in ERCP, competency training in ERCP, I'm sure at least 100, if not more, centers in India is providing. But I do not know of any center, including ours, which can certify competency to any training candidate for an EUS biliary drainage procedure. So this is something that we need to understand. The devices for EUS biliary drainage are all borrowed from ERCP, and there are very few dedicated accessories for these procedures, and therefore we are still far away from our prime time. Coming to the cost analysis, and I think there is a difference of opinion about this. Establishing EUS services itself by adding an EUS service is much more expensive, and the cost of EUS biliary drainage is definitely higher today in India at least. We have the EUS needle, we have the accessories, and the EUS specific stents like the Axios or the Geobor are definitely much more expensive than the standard SEMs that we can use through the ERCP route. Another important factor that we need to consider is the risk diversification. And in any interventional endoscopy procedure, I think it is important to stratify procedural risk. EUS biliary drainage is a high-stake procedure. You get one chance to do it right. And if you don't get it right the first time, it can lead to disastrous complications. ERCP, I think we all know that a second look ERCP gives you a far superior rate of success of cannulation than what you would probably imagine with an EUS guided route. Therefore, primary EUS biliary drainage versus ERCP, does this argument still stand? Moin Kashyap, in his editorial, mentioned that the EUS procedure has to become easier, faster, and safer to scale and to challenge ERCP as a primary approach. Some hard facts, my friends. Suboptimal ERCP competency cannot be a substitute or an alternative to implement a primary EUS guided biliary drainage procedure. And selective cannulation should definitely be the prime aim of any training endoscopist. All data comparing EUS guided biliary drainage and ERCP, which Pravir has shown, however, unfortunately, is presently from high volume tertiary centers. The operators there are highly skilled and experienced in both these procedures. They have the adequate infrastructure and resources to handle difficult kind of cases, and they have access to high quality PTBD services as well. Can these outcomes be generalized? I don't think so. What about you? Therefore, the primary, when we look at primary EUS BD versus ERCP, if we take 100 patients with biliary obstruction, in 85 to 90% patients, the papilla is going to be accessible, and we are going to be successful in cannulation in 95% of them, if our selective cannulation techniques are good. Therefore, that leaves a very small subset of patients who actually deserve a primary EUS guided biliary procedure. That is what is the bottom line. And the international consensus for the management of biliary malignant distal biliary stricture recommends that ERCP and transpapillary SEMs is the mainstay of treatment. Therefore, the debate is over, in my opinion. To conclude, in malignant biliary obstructions, ERCP should be the first line of choice. EUS guided biliary drainage definitely is indicated in selective situations where ERCP fails or it is not possible. And EUS guided biliary drainage may be an alternative to a PTBD approach when the ERCP fails. Thank you so much, and a warm invitation to come to Pune in July. Thank you so much.
Thank you, Dr. Amol, for a wonderful presentation. I think the debate is now open for discussion, and we can have comments from Dr. Anthony.
Well, thank you all, both doctors, in giving this very exciting debate. I quite enjoying sitting here and listening whilst I'm trying to provide the evidence. So for our study, when we are designing it, it was based on the idea that maybe USBD can improve patency. So with this in mind, that's why we have this study of comparing USB CDS versus ERCP. But at the end, we couldn't prove this because we found that the CDS with the lamps was associated with other problems like food residue going inside the tumor, the bile duct, and there were other causes of intervention. So for me, I think the bottom line is, I think most of us here are still doing this. We would try ERCP first. But I think with US CDS, with a dedicated device, I think in patients where you anticipate it's very hard, like a big tumor to renal obstruction, I will have no reservations in moving on to a primary USBD procedure. But I completely agree with a lot of the points that Amoy was telling us about. But I also want to point out that many of the studies on ERCP success rates are based on the overall success. So we are looking at a very small group of patients which are tumor malignant distributed obstruction. So actually for this group of patients, I very doubt that the primary success rate will be like more than 99%. So that's my comment. Thank you.
Sandeep, you would like to, Dr. Goenka, please.
I think both of them have put their points very well, but can I ask specifically what is their practice? What will Praveer do in his practice when he's dealing with a malignant obstruction? What Amol will do? And a question to Professor Teo. I'm a little surprised at your ERCP technical success rate in that study being 75%. How do we explain that? Is it that who did these procedures?
So I'm sorry to disappoint you, but it's not me who did all the procedures. So it's actually this multi-center trial. So everyone was, very well-known endoscopists, and they are all well-trained in ERCP. So the lower rate was because due to the tumor obstruction. So there were some patients due to duodenal obstructions, some were failed cannulation. So it is what it is.
Yeah, so I think as far as practice in our center is concerned, I think it's all distal malignant biliary obstruction. We directly go ahead and do a primary US guided biliary drainage. And the reason why we do it is, if we review the literature nicely, so what we see is that to achieve competence of US guided biliary drainage, that is to have very less complications and a high success rate, you need around 100 cases to do. First, this is to achieve that competence. Moreover, to sustain that competence, again, that number is still not clear, but to achieve competence, you need 100 cases. So if you are doing primary ERCP with a success rate of 99.5% or 99%, the number of patients ultimately in which you will be doing an US guided biliary drainage would be very less. And to achieve competence of 100 will take maybe 5 years or 6 years. So the point that I'm trying to make, once we know that, since it is being done by experts, we know that this procedure is safe otherwise, if you have a good competence, and moreover, with the advances in equipments that is being made, I think it will possibly, at least for this particular indication of distal malignant biliary obstruction, it should be the procedure of choice.
Yes.
Can I make a comment? Amol,
Yeah.
here I am on this side. Yeah, I think as a primary modality, when we are discussing all these things, using any cautery enhanced device puncturing the bile duct from outside
and not succeeding is always more dangerous than trying a cannulation 5 times. You have complications, you have bile leak, and you have to resort to either PTBD or some other modalities. So it is always safer. And you can generalize ERCP to the large majority of the patient doctors who are practicing. And USBD, I don't think it is wise to puncture anything with a cautery from outside. And I think it's very, very risky, and it has to be resorted only in selected cases, not everyone.
I would just like to answer Dr. Goenka's question. So at our center, we would still go by the primary ERCP route in most patients. And unless there is duodenal obstruction, of course, where we would resort to an EOS guided biliary drainage approach. At the same time, I would like to say that yes, our threshold for moving on to an EOS guided biliary drainage is much lesser now, and it is much things that we would probably try 5 to 10 minutes, and otherwise, if we cannot, then we would probably move over to a EOS guided approach rather than just keeping on attempting selective cannulation. So that is what is happening. No, pre-cut we would definitely do if the papilla is feasible for a pre-cut. Sometimes in that head pancreas infiltrated papilla where we pre-cut, I would rather not do a pre-cut, which probably before I started doing EOS guided biliary drainage, I would have still attempted. Here I would straight away go for an EOS guided CDS.
Praveer, would you be able to defend yourself in court? Suppose a patient primary USBD lands up with a complication. That why you could not take the established route first? Why you did not do any RCP?
I think a very, very important question. And I think where this the established thing comes from studies, and studies are primarily randomized controlled trials. Fortunately, we have now randomized controlled trial to protect us. So this is what I would say, because obviously you need evidence, and the evidence is randomized controlled trial. We have that evidence now.
Go ahead.
It was a great debate. I think we are deviating from the main topic. The main topic is primary USBD versus ERCP for distal malignant biliary obstruction. When you people are quoting data about ERCP or 99.4% success rate, it's about the whole cohort of ERCP, or majority of which is because of benign diseases. So whenever you collate the data, you're talking about the success rate of overall ERCP, where the majority is because of the benign diseases. If you look at the data, like Dr. Anthony's data of RCT suggests 75% ERCP success rate. If you see Dr. Dheer's paper where he had compared between, that was a retrospective data, 2011 GIE, between pre-cut papillotomy versus USBD, again, the majority were malignant, and the papillotomy rate, success rate was just 75%. So we are actually talking about distal malignant biliary obstruction. ERCP success rate is 75% versus more than 90% of USBD. So there we need to talk about how much is the success rate, how much further we are trying to go ahead, because distal malignant biliary obstruction, we understand the anatomy is distorted at the papilla. You give a lot amount of try, you try to do a papillotomy, you fail, and then you eventually land up doing that. Rather than going that and increasing the risk of post-acute pancreatitis, why not upfront do an USBD in a select cohort? We are not discussing about USBD versus ERC for all malignant or for all biliary obstruction. We're only talking about distal malignant biliary obstruction, and that's what I think I would agree with Dr. Praveer Rai, sir, that probably we are not saying that the stage is set right now for a primary USBD over ERCP, but probably we need to move towards that with the help of all the training and whatever that we have.
Yeah, I think just to add to it, I think I mentioned that in my slide as well. Around 25 to 40% of the patient with distal malignant biliary obstruction may have outlet obstruction or duodenal obstruction.
Well, at least in our practice and in the data that I have looked at, I think typically duodenal obstruction is there in about 15 to 20%, not 25 to 40, but probably I may have missed some of the studies. One of the things which consistently appears in all comparative data where we are looking at USBD versus ERCP, and majority of this is coming from expert centers all over the world. And in majority of the studies, suddenly when there is a comparative study, the ERCP success rates have dropped. And that is something which probably cannot be explained. So I think probably the threshold for moving from an ERCP to an EOS guided approach is what is making that change. We're not looking at anything else. But I think that threshold
think,
is what is moving this.
We'll close the session and the discussion goes on after this. Thank you.
Now we'll be moving forward to the live demonstration with the working tea break. For the first demonstration session, I would like to invite as chairpersons, Dr. Deepak Gunjan, Dr. Nikhil Santalia, Dr. Prakash Dekaris, and Dr. Gursevak Singh. Now we'll be going live to Medanta.
Dr. Puri, you are on. Your sound is not coming. Sound is not coming from your.
Is there?
Yes, yes, you are audible.
So welcome you all for the next second session of live endoscopy.
Sir,
And in this session, we are going to show the various pancreatic interventions. So we are going to start with the room number 1, where Dr. Vikas Singla is going to show. So I request Dr. Jubin to start because I'm hosting the next EndoCon 2024. So I invite you all for next EndoCon 2024, and we ensure and promise that that conference will be much better than this conference. So I request Jubin to show the video, and then we can start the live, the first case.
A 43-year-old gentleman with no comorbidity presented with pain, abdomen, and steatorrhea for 15 days. On evaluation on CT scan, he is found to have diffuse pancreatic parenchymal atrophy with dilated PD and PD stones. So MRCP shows the same findings. So, and the HbA1c is 6.3. The patient underwent 2 sessions of ESWL. Now the patient is planned for ERCP with PD clearance and PD stenting.
Over to Dr. Vikas Singla, please.
Yeah, Deepak, can you see us?
Yes, you are on.
Yeah.
Visible and audible
Are you getting the endoscopic image?
Now we are getting, but your video is not coming.
So, good evening to all of you. At the outset, I'm thankful to Dr. Rajesh for this kind of opportunity. So, this is a patient with chronic pancreatitis having repeated pain abdomen episodes and having the dilated MPD with the multiple stones in the MPD. Underwent ESWL, now planned for ERCP, and on fluoroscopy we can see there are multiple stones, small stones in the MPD. Now the plan is to clear the MPD and to look for any residual stricture. So we are into the second part of duodenum, and we can see the long prominent papilla.
Sir, was a ERCP done before ESWL?
We can use either a triple lumen sphincterotome, or we can use the double lumen cannula, or we can use the ultra taper cannula, but this opening seems to be wide enough, so we can use the regular triple lumen sphincterotome or the cannula. In this case, we are using the double lumen cannula with the J-shaped Terimo guide wire.
Dr. Vikas, just highlight the direction in which you
Yeah.
would like to cannulate the pancreatic duct.
So the direction, first the papilla should be at 11 o'clock. So if you want to go into the CBD, CBD goes along the roof like this. So this is direction of CBD. And if you want to go to the PD, direction is like in this direction at between 11 to 12 o'clock. And it goes more vertical into the duodenal wall. So PD opens more perpendicular into the ampulla as compared to the bile duct, which travel parallel to the roof. So first of all, I will try to engage the tip into the opening.
So how
Go
scope
inside,
position is
then I
different?
will use the left
Dr.
top.
Vikas. Dr. Vikas, is it audible from us?
Slightly pull back. Yeah, yeah. I think we have gone inside. So yeah, now we are injecting the contrast. So yeah, you can see that our cannula is inside the MPD and it's grossly dilated.
Can you enlarge the fluoroscopic image?
Yeah. So Deepak, are you getting the pancreatogram image?
Yes. Yeah, now good.
Yeah. So with me is Bhagwan, who is the excellent technician, and Darshanji is on the fluoroscopy. I think they are one of the best person to assist you in the ERP. Dr. Monica, you have any doubt regarding that?
No, nothing.
Yeah. So you can see that Bhagwan easily pass the, can you please pass the guide wire? Yeah. Yeah. So now we are deep inside the pancreatic duct. So while we are attempting the cannulation of the pancreatic duct, it should be more towards 12 o'clock, and we should be using the more left knob and slightly pull movement on the endoscope. Yeah, now we'll exchange the, yeah. So can you please exchange the guide wire? So we are using the VisiGlide guide wire 025.
Do we need a sphincterotomy in this case?
Yeah. So Deepak, can you appreciate there are multiple small tiny stones?
Yes. Yeah, particularly
In the body and tail area. Yeah. Can we inject contrast in the head region? Yeah. So we want to see any stricture in the head region. So it's widely dilated. There is no stricture actually.
Dr. Vikas, there is a data which says if a patient has a adequate ESWL,
Yes.
he may leave these patients without doing anything.
Yeah. So I think in this patient on fluoroscopy, there are multiple stones, more than
You would
3.
like
Yeah.
to
Yeah.
clear this.
Yes. Yes.
Now-
Dilate. So we'll do the EPD followed by the balloon dilatation of the papilla and try to remove the stones in the MPD.
Sir, would you prefer placing a stent before ESWL?
Stenting. No,
Yeah.
I think once you're done the ESWL, if there are still residual stones, we can directly go with the ERCP and the clearance of MPD. Stent is required when you have the stricture in the MPD. This patient, I don't think there is any stricture into the MPD. Prior to ESWL, you don't require any stent in the MPD. You can directly go with the ESWL.
How much sphincterotomy you would like to do, Dr. Vikas, in this case?
So it's a long papilla. I think we can go up to 75%. So I think stones are slightly larger. So we may do the balloon dilatation also.
Balloon dilatation.
So we'll keep some part of papilla preserved. So maybe 50 to 75% will cut.
How much dilatation are you planning?
Planning either 6 to 8 mm dilatation. So this is, we are using the clever cut. And you can see that there is insulation sheath. Deepak, can you appreciate that? There is a sheath at the proximal part of the wire.
Enlarge the image of endoscopy.
Yeah. So the
it is
proximal
visible.
wire, on the proximal part of the wire, there is insulation sheath. So even if the wire comes in contact with the elevator, there is no earthing.
Dr. Vikas, how this EPT is different from biliary one?
So if you want to do biliary EPT, the direction should be at 1 o'clock. It should be like this at 1 o'clock. And if you want to do the pancreatic, it should be towards between the 11 to 12 o'clock.
What should be the endpoint of PPT in pancreatic sphincterotomy?
It's a similar up to the duodenal fold. You can go till the end of the papilla.
Is there any risk of doing sphincterotomy in cases of these chronic pancreatitis of fear of pancreatitis induced by sphincterotomy?
Pardon?
Pancreatitis following sphincterotomy.
So if you're placing a stent and this patient already has the chronic pancreatitis, there is hardly any risk of
Because any difference in the current setting of the cautery between biliary and pancreatic sphincterotomy?
I think now we can do the balloon dilatation. Yeah. So we'll go with the 8 mm balloon. This is the fairly dilated duct and there is no distal narrowing. I don't think there is any risk of, so we can go with the 8 mm balloon in this case.
Which balloon you will
So we
prefer?
can use either a hurricane balloon or we can use the Titan balloon.
Because any difference between the current setting of the cautery between biliary and pancreatic sphincterotomy?
Yeah, they are same. The same setting are used.
So if there is no stricture, why do you want to do balloon dilatation?
So the stones are actually, I think they are larger stone, 8 to 10 mm. So I think it's easier to remove the stone once you do the balloon dilatation. So we are targeting the dilatation at the papilla only, not at the pancreatic duct. Duct is dilated till the papilla. So we are dilating the sphincter muscles, not the pancreatic duct.
So how do you decide which balloon size should be used in pancreatic duct dilatation?
So I will go with the size of the pancreatic duct. The duct is around, I think, 10 mm. So up to 10 mm we can dilate in this case. So the balloon should be half inside, half outside. I will keep it slightly. Yeah, dilate. Now you can push the balloon down. So Deepak, can you appreciate the waist there? Yeah, now the waist has gone. So we'll dilate for around 60 seconds. Dr. Monica, do you dilate the papilla before?
Papilla, normally when the stones are more big in size, then we dilate this. If that is not there, the ESW is very effective, then even simple sphincterotomy is enough.
And regarding the preference of balloon or the basket for removing the stone, what do you?
We prefer balloon.
Yeah.
Because if some impaction occurs by chance, then that is a problem.
Yeah.
In these
But with the
cases.
balloon, the issue that stone can migrate into the side branches.
That can be
Yeah.
there, but if the ESWL is effective, I think
Yeah.
this problem will not occur.
Yeah, I think the stones are. Yeah.
Balloon can burst.
Yeah,
that
yeah.
is there, but
Yeah.
Because sir, in any situation you use pancreatic lithotripsy by spy scope?
Yeah, the spike, it's difficult to pass the cholangioscope in a patient with the chronic pancreatitis. So in this case, like this patient has diffusely dilated duct, and if there is an impacted stone somewhere, then we can pass a cholangioscope or the pancreatoscope deflate. Yeah, sometimes if you have a dilated duct and an impacted stone, but most of the time there is a stricture in the head region, you are not able to pass the pancreatoscope across the stricture. But yes, in such a scenario, dilated duct with a large impacted stone, it can be a good option.
Can we try dilating the pancreatic stricture also in such cases?
Yeah, we can dilate the stricture also. So there are dedicated Sohendra dilators, or we can use the Hurricane or the Titan balloon for the stricture dilatation.
Dr. Vikas?
Yes, sir. So, yeah, Dr. Rajesh.
Yeah, I think the dilatation done. So meanwhile, can we shift to the room 2?
Yeah, sure.
So we switch to the room 2, and I request Dr. Bimal to present the history. Over to Dr. Pramod Garg after the history.
So next case is a 38-year-old gentleman who is a known case of acute necrotizing pancreatitis with walled up pancreatic necrosis, onset 27th March, alcohol etiology. He was put on PCD on 23rd April, and the PCD upsizing was done up to 32 frames. Still, the patient is having high grade fever for 20 days despite IV antibiotics, and the culture grows Klebsiella pneumoniae. And this is the recent CT scan, which is showing there is a minimal decrease in the size of the collection as compared to the previous CT, and there are necrotic debris also. And the count is a bit high, it is 15,000. So our plan is to do percutaneous endoscopic necrosectomy.
So you are visible, sir.
Over to Dr. Pramod Garg.
Okay, so good afternoon, everybody. So this is a case with infected pancreatic necrosis who had a large collection away from the lesser sac. And this is a case where you can't really do per-oral endoscopic drainage and necrosectomy. And that's why he had undergone percutaneous drainage. And the tube has now been upgraded to 32 French. But he still continues to have fever, counts are high. And the idea here is to do percutaneous endoscopic lavage and drainage. And if we find there is loose necrotic debris, we can do necrosectomy. So this is a procedure which is ideally suited for patients who have collections away from the lesser sac and are not responding to percutaneous drainage alone. He has a 32 French tube, so that means about 10.7 millimeter in size. And this size track will allow passage of a standard upper GI endoscope, which has been thoroughly cleaned. And I have also put in extra spirit through the channel. With me is Dr. Soumya Jagannath, who has been doing a lot of these procedures. So I have just given him a little bit of sedation and given some local anesthesia around the site where the tube has gone in. So we will now remove the tube and introduce our scope. When you introduce the scope, CO2. So we will inflate little bit with CO2, but sometimes we don't inflate with CO2. We go under vision by instilling some saline or water. So can you see this? The tube is out now. Saline. I am very gently trying to go through the track. It seems a longer track. So gently we are entering the cavity here. And you can see some necrotic debris there, right? So once you enter the cavity, I need saline. Once you enter the cavity, it is something like you do per-oral endoscopic necrosectomy. The difference here is that the difference here is that we should be careful not to increase the pressure inside the cavity. So when you do per-oral drainage, I need saline. Most of the air keeps coming back into the stomach, and chances of increasing the pressure within the tract are much less. Saline. But in this case, your passage has been largely blocked by the scope, and that is why there is a possibility that you may increase the pressure within the cavity. And if that happens, then there could be increase in sepsis. So we have to be careful not to increase the pressure. And sometimes liquid pus can also, go out of this cavity into the peritoneal cavity, and then there could be peritonitis. So my first goal here is to suck out the liquid pus and make sure the cavity is by and large clean of the liquid pus, which is easily aspirated. So see here, I'm not inflating any air inside. My idea is to put saline and just suck very gently. Also be careful that there are no vessels running nearby. Don't suck too hard. You have to be very gentle with suction also. Unlike surgeons, this is an uncharted territory for us. So we have to be extra careful when we do this procedure.
Sir, how many days you have to wait after upgrading the catheter to perform
So
this?
it depends what size of catheter is. So if you have reached 30 or above, within next 2-3 days, you can go in. Okay, that's okay. Now,
Dr. Garg. Hello.
Yes, please.
Yeah, Dr. Pankaj Desai here. Sir, do you
Yeah.
put, what is your take on using hydrogen peroxide?
So we used to do that earlier, but in couple of cases, what we found was that there was increased pressure because of H2O2, and 2 of our patients developed peritonitis. So we have since then stopped putting a lot of H2O2 into this cavity.
And how would you differentiate this solid material here that this is debris and not a residual pancreatic tissue?
So one that I've seen the CT, and it is away from the pancreas, so it is unlikely to be pancreatic tissue. Second, the appearance of this is quite classical of a necrotic tissue. It is slightly yellowish also, so mainly peripancreatic fat necrosis is there. It is certainly possible that part of the pancreas is also necrosed here, so we can't be too sure. So the idea here is that if this debris is loose, if you find it is easily removable, we will try and remove it. Yes.
We can go to Vikas Singla room.
Yeah, go ahead.
Sit to Dr. Vikas Singla room, room number 1.
Yeah. Deepak, can you see us?
Yeah, visible.
Yeah. So right now our balloon is in the body region. Can you inflate the balloon? Yeah. Yeah. So now we'll do the balloon sweep. And you can see that now the stone is getting stuck here. So now the trick is not to pull the balloon, just to rotate the shaft of the scope. Rotate the shaft and don't push the scope inside. Otherwise it can cause perforation. Just give a track. Bust. Yeah.
Because what is the difference between removing the pancreatic stone versus CBD stone
So
in such a case?
So when you are removing the CBD stone, the scope should be more inside. It will align the balloon along the CBD direction. Can you inflate the balloon again? Yeah. So Deepak, whenever you get stuck with the balloon, just rotate the scope. Now don't pull the balloon, just rotate the scope clockwise and don't push the scope inside. And you can see that a lot of stones are coming there.
So why it is different from biliary duct? Because in bile duct, we try to pull the balloon also. But why we are not doing in pancreatic ductal clearance?
So if you pull the balloon, the whole assembly may come out. Sometimes even the wire can come out. Inflate.
Also, the complication rates are higher in pancreatic ductal clearance as compared to biliary ductal clearance.
Sir, Nikhil here. Sometimes the stones are sharp and balloon gets damaged. So you
Yes.
prefer basket?
Yes. So with the balloon, as Dr. Monica mentioned, the risk of impaction of the basket. Then you may have to use the Sohendra lithocrush. But here we can see that CBD is dilated and the stones are smaller as so PD is dilated and the stones are small as compared to the duct diameter. So that's why we went ahead with the balloon. Can you inject the contrast there?
Fluoro, please.
Yeah, can you see the fluoro image?
Fluoro image, room number 1, fluoro.
I think most of the PD has been cleared. Just inflate the balloon.
So what's the fluoro image, please?
Stand after this, Dr. Vikas.
I think we have the wide papillotomy. You can see the pancreatic sphincter inside. It's a wide open, and the stone size is smaller. So I think we can avoid putting a stent here. I think this patient is from the Myanmar. So I will ask Dr. Puri also whether we should place a stent.
So Dr. Vikas, as we discussed,
Yeah.
the patient is from the outstation and let's put a 10 French stent.
Okay.
And because we can see the stones in the tail of the pancreas still.
Yes.
And there was a resistance.
Yeah.
So you can proceed with the putting the stent and I switch over to Dr. Pramod Garg room.
Yeah.
Dr. Pramod
Thank you,
Garg,
Rajesh.
room number 2.
The stent there.
So the diameter has become very much less as compared to the previous after stone clearance.
Yeah.
Dr. Pramod is online.
Yeah, okay.
Online.
Okay. So we have started removing the necrotic debris, and you can see these are the debris which is coming out of the cavity here.
Please focus the camera on the endoscope.
Dr. Pramod is online.
Yeah. So we have started the necrosectomy part because we sucked the liquid pus, lavaged the cavity, but we realize there's a lot of debris here which needs to be removed. And only you remove this the debris, more pus will come out. Open.
Sir, what is the technique of putting the this snare during necrosectomy?
So,
I can look at black belt.
so the idea is that I do not know what lies inside. So I have to be careful in putting my the snare here, but close. And take out small part of necrotic tissue at a time. Because otherwise it will cut through. Right now, for example, it has cut through the debris. If the debris is very soft, it will cut through.
Dr. Pramod, have you any experience with the endorotor?
No, I haven't.
It's not audible. Not audible.
So one of the things here is that
one question here, Mahesh here.
Yes, sir.
You have to enter at least about 10 to 12 times when we move through the sinus tract.
Yeah.
So do you think putting a metal stent in the tract can make it more safer? And do you use fluoro during the procedure? What I find is sometimes fluoro is useful to know as to what depth you should go.
Right. So generally we don't use fluoro. If your tube size is 30 or 32, for example, here it is slightly longer track, about 10, 12 centimeters. So the fluoro generally is not required. But as far as metal stent is concerned, we do sometimes place metal stent. If we find that we have to do necrosectomy early on, so rather than upsizing the tract by, putting in plastic tubes multiple times, first time if you put a metal stent, that provides very good, track for doing necrosectomy.
But it requires more pain control because after putting the
it's pretty painful. By the way, we should not try and take out a lot of debris at a time. Most of the time you will find it will break and small chunks will come out. So you have to be very patient with this procedure, very gentle. The tissue around the debris is very fragile, and even the tip of your snare can damage it.
How about using Rothnet for this?
Yeah, we tried Rothnet sometime. It doesn't work as good as you want it to, but yes, surely one can try.
And what is your experience, sir, with causing fistulas from the bowel in these sort of situations? Because when they do a laparoscopic necrosectomy like this, they always sometimes prefer to do a colostomy and then do.
So because of the procedure, we haven't actually encountered any case with fistula because of the procedure. But the possibility that a fistula already exists is always there.
Yes,
For example, in this
that's
particular case, we found on CT, I don't know whether you had a chance to see CT, open. There's a lot of air inside the cavity, and a microfistulization, open, through the, from the colon is quite possible.
Sir, can we do this if the catheter is transperitoneal?
Ideally, no. Close. Very good. But in some patients, we have done it, particularly if the track is.
Dr. Pramod?
Yeah,
Dr. Bajal is also here.
sir. Sir, good
So
afternoon.
any comment you can give?
Open.
Dr. Bajal is in the endoscopy room who has put the percutaneous drain. So you can have some question to Dr. Bajal also. He will be happy to reply.
Radiologist,
Hello,
interventional
everyone.
radiologist is here.
Just other than getting impressed by what you all do, there's nothing else for me to say.
No, sir. You do a great job. We always depend on you. आप saline डालूंगा थोड़ा सा. So the advantage of this procedure is that I don't want to finish off the entire, necrosectomy in one go. You can tailor this procedure. You can tailor this procedure according to patient's tolerability. So we have many times done it at the bedside in ICU when patients are quite septic. In fact, patients on ventilator, we have also done. So you just go lavage, take out pus, take out whatever debris you can. When you feel that it is enough, stop the procedure, put it in again, and do it next time after 2 days or 3 days, depending on the response.
So what should be the initial size of catheter when you are putting first time? Because both Dr. Baisal and Dr. Garg is here. So,
Sir, would you like to take that question? That find out. Tell answer.
If there's a planned necrosectomy very quickly to 32 Feb, which is just about our maximum size that we do.
so it's not audible.
So we quickly upsize our drains to 32 French, which is just about the largest that we do percutaneously. And that allows very comfortably a 10 millimeter or a 12 millimeter system to go in.
What should be the initial catheter size? Because larger size.
I'm okay. Whenever you want.
Our first catheters, when we know that there's an obvious necrosis, would be anywhere between 20 to 24 French. That's our target. Of course, at the end of it, during the procedure, if we find that the dilatation is becoming exceptionally difficult and tight, we don't go overboard. But our first target is at least to reach 20 and bigger. And the second stage, maybe in 24 to 48 hours, move it up to 32.
Sir, Dr. Zubin here. So would you upsize the catheter based on symptoms or based on the radiological debris?
So totally based on the imaging, which would tell us if there is a significant necrotic component and debris inside, we would definitely like to go larger rather than wait for sepsis to worsen. We would electively choose to start bigger from the beginning.
So we will require Dr. Bajal for the reconstruction of the porta, for that especially has come. So before that, we will shift to the room 3, where Dr. Neela Mehta is going to start the procedure, and we'll come back to Dr. Pramod Garg when he would put the tube again. Let him do the necrosectomy for some more time. So shift to room number 3. My colleague is going to give the history.
Sure.
So our next case is a 44-year-old man who is a known case of acute necrotizing biliary pancreatitis, now presented with persistent pain abdomen on regular oral analgesics, with history of early satiety and loss of weight of approximately 10 kg. CT revealed a large walled up necrosis of approximately 10 into 8 into 9 centimeter in the lesser sac. So our plan is to do US guided drainage of the wound.
Over to Dr. Neela.
You are not audible.
Can't hear you, sir. Mic. Mic is on?
Yes, not audible.
Am I audible now? Yes. Okay. So you heard the history, and this patient has a WON and it's a symptomatic WON. So are you getting EUS picture? No. Okay. Can they get EUS picture? They need to have EUS picture. Yes. Aya? Yes. Okay. So basically you see all fluid over here, but when I shift, you will see the necrosis. Now you see the necrosis.
It's around, I would say 30 to 40% of the cyst cavity. See, we always talk about necrosis, 30, 40, 50, but I also think that the size of the cavity is also important. So what you see is a big mountain of the necrosis, and also you see another, where was the pointer? You also see some necrosis attached to the wall of the WN, walled up necrosis cavity. You don't have to worry about this necrosis, which is attached to the wall of the WN. What you need to care about is this necrosis, which is lying free or which is like this mountain-like. That is what you need to remove if patient becomes symptomatic. Now, what I'm going to do is doing a WON, and as discussed before, yes, you can use plastic stent, but metal stents are better. Why? Because it gives you a bigger diameter, procedure is faster, resolution is more, complications like bleeding and perforation are less. Of course, migration is more. And if you want to do necrosectomy, the total sessions are less. I started doing a necrosectomy early in 2007. That was my first necrosectomy. I used to do 2 to 3 hour session for like 3, 4, 5 sessions. Now with this metal stent, maximum I do 1 session. Only rarely I do 2 sessions. So that is the difference. So what I'm going to use is hot Spaxes. Manoj is going to help me, and under the guidance of Sudipto. Sudipto, please come. Sudipto is very shy. He says 2 people is too much for the audience.
Sir, Nikhil here. In this
Yeah.
case, you will go for step-up approach or you will plan for
I
endoscopic necrosectomy?
usually don't go for step-up approach. I know Sandeep has shown beautifully how to go about step-up approach. My approach is put a metal stent, wait. If patient does not have symptoms, just don't do anything. Why? Because there is a study that where 27% of patients with necrosis would not require anything else. You don't have to do any direct necrosectomy. But if patient has a problem, I straight away go for direct necrosectomy. I do step-up approach if I'm doing early necrosectomy. Meaning if patient has 4 weeks and I have done, or sometimes I have to do it at 3 weeks when there is an incomplete wall formation. There I do a step-up approach. But like this patient, 3-4 months, I don't do any step-up approach. Patient has symptoms, go in, do a direct necrosectomy. That's it. That would solve the problem.
Nilay,
Yeah.
how would
So-
you choose your site for
How do I choose my site?
for posture? Yes.
Yeah.
Do you
So-
have the scope near the
Yes.
junction, or
Yes,
would
yes.
you go inside?
Always below the G junction. Of course, you can do it above the G junction, but I would not prefer it because you don't want a metal stent into the esophagus and have a esophageal fistula. Second, how would you know that you are beyond stomach? So one is, of course, fluoroscopy. And can you start fluoroscopy? Can you see the fluoroscopy picture over there?
No, we can't see.
Okay. So fluoroscopy, please. Now can you see fluoroscopy?
No, still not.
Still not. So that is one. Otherwise, you can always give some air and see whether your endoscopic ultrasound has crossed the G junction. But yes, it has to be crossing the G junction. The more the pseudocyst or WN towards the body and tail, you have a higher drainage. More towards the head, you have lower drainage. Right now, we are very comfortable. Another thing is you have to have sufficient cyst wall in relation to the stomach. Third thing is you have to have less than 1 centimeter distance between the pseudocyst wall and stomach wall. Here we calculated it's around 7 millimeter. Third, you don't have to have any intervening big vessel. And how would I know? By starting Doppler. And I'll max out and yeah, sorry.
Can you switch to?
Yeah, there is a
larger
vessel
image?
there. So how would I avoid this vessel? By doing up, down, lateral movement. So now there is no vessel, or there is still vessel.
Can we have a large US image? Yeah.
Okay, let me pull a bit and then the vessel should go. Yeah. I'm sorry, someone was asking.
So, Dr. Nilay, what should be the WON position in your monitor?
Yeah, it's constant. So this is definitely artifact, and That is also because of the elevator. Let me.
Yeah, I think
Do-
delay, when you put the Doppler off, you will not see any anechoic structure there. So that is an artifact probably which you have seen.
I think it's an artifact. Yeah. So yeah.
When you make your big knob away from you, just remove your big knob away from you.
Yeah, it's a vessel.
Look at that.
Okay.
flow that is.
Okay. Yeah.
So using a single step device, can we do this procedure in EUS room without fluoroscopy?
You can, but I have kept it fluoro because I want to show the markers of hot access over here.
Your hand movements is not visible if you are putting the hot
No,
exhaust.
I'm not doing anything. I'm just trying to go away from this vessel. So that I'm doing pulling the scope and doing right and left movement and see. Till yeah. Yeah. Yeah.
Yeah, it disappeared almost.
Almost. This is okay. Yeah.
That's good
Rajesh,
position.
are you okay with this? You left. Yeah. Sorry? लगा के होगा? Okay. Yeah.
So can you tell us the difference between the axial system and the Spaxis? We are more commonly averse. to-
Yeah, so both are lumen opposing stent. Both have hot cautery system available. And both have different sizes, 6 at 15, 20, 10. The delivery system is different. This is more like our conventional stent. Hot access was shown before, and you know that how it worked. This is more like, if you can focus it over here. Manoj, can you show them? Yeah. Can anyone focus over here? So this is more like a conventional stent system. So it has like, this is what we have selected is 15 millimeter stent. The total length is 2 centimeter, but if you see the shaft, that is between the length between the two flanges, it's 7 millimeter only. So it's even less than 1 centimeter. And the second thing is the flanges are 31. And it has a good holding power. It's a lumen opposing stent. I'll just yeah, I want a Doppler once. Yeah, once.
On the floor again once more.
You
put on the Doppler, it will come back.
Yeah, always. That is
Nilay?
the story. Yeah.
Yeah, would you preload
This is
this system with a guide wire?
You can, but why do you want to do that?
No, just in case there is
Something happens.
Yeah, some
Yeah.
deployment or something, you have a guide wire to.
Yeah, do you? I don't know. Do you have a guide wire? Yeah, but yeah. After puncture. Yeah. Okay, so now I'll put my foot on the pedal and would start. And so the current is auto cut, effect 1 or 2, and 80 to 120. Normally I keep around 80 to 100. Sorry, am I good? 400 रखा है? नहीं, ये तो Vio 3 है. I don't understand Vio 3. No one understands Vio 3. Okay, so I'll just. So I'm in. Can you start fluoro? Okay, so now I'll show you the marker. You can see fluoro, please, fluoro. You can see one radio opaque marker that is distal, and second radio opaque marker which is in the middle.
Okay.
And I'll take out the stent further if I can show you the third, but no, that it will be too much. Yeah. So why it is important that you have to pull the stent to the middle marker. Can you do that? Lock. So you have to unlock it, right? You have to unlock it and then pull. Pull slowly. We are not in a hurry.
Can we
Can
see
we have
ये
a-
मार्कर और वो मार्कर साथ में मिल जाना चाहिए. फ्लूरो चालू रहना चाहिए.
We see the endosono and
Yeah.
your hands, please.
Fluoro. हाँ करो करो चालू करो बोल रहा हूँ हाँ yeah 5 minutes.
And we
Just
have
a
the
minute.
US image also.
खोलो 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 हाँ खोलो 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 चिंता मत करो खोलो 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 और खोलो 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 चिंता मत करो खोलो खोलो और खोलो it's open yeah so now I think you need to now lock it still you can open it more little bit yeah abhi I am pulling the stent entire delivery system towards me so that the stent is impinging on the stomach wall. That is very important. Okay. Now to take out the further stent, you can do two things. Either you can start the endoscopy picture or you can open the stent into the channel. So I'll do both. First, I'll start the endoscopy picture. Endoscopy picture is this. And I'll put some air. I'll have fluoro. You locked it, right? Yeah. Big wheel away. Slightly torque and then pull.
This maneuver, Dr. Nila, is very important. Please explain
Yeah.
it again when you are deploying the stent.
My colleague will explain because he knows better.
The maneuver is big wheel away, air in circulation. Big wheel
Not audible.
Hello, can you hear?
Not audible, I think.
You're not audible?
Can you hear me?
Fluoro?
Yeah.
Am I audible in the audience?
Yeah.
So the maneuver involves the puncture site is usually to the right and upper quadrant. So it's a big wheel away from you, slightly torquing your body to the right and big wheel away from you with air insufflation.
Okay. So
Air
now you can
insufflate, big wheel away from you, slightly torquing your body to the right.
पकड़ो ना, scope को ऐसा पकड़ो ना.
And gently pushing the stent delivery system out.
खोलो खोलो धीरे धीरे खोलना. खोलो खोलो धीरे 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 खोलो पूरा खोल दो फ्लूरो
Now push it out.
खोल दो पूरा.
Lovely.
So the stent is out. Fluoro. Yeah.
Will you put the plastic stent inside? Dr. Nilay, Dr. Sudipto.
No.
Yeah, there's a bit of a debris inside. What do you think, Nilay?
Yeah.
Should we put a bit of
You want me to?
I think we'll put a double picture.
Basically, why do you put a double picture stent is the necrosis will come and
impinge on
the lumen and it will block the stent. But I've seen even in spite of putting plastic stent, it does the same thing. I would rather go in and do the necrosectomy. Yeah.
Thank you for the nice demonstration. And we'll shift to room number 1, where Dr. Vinay Dheer is going to start the procedure. I request Dr. Bimal to present the history. Over to Dr. Vinay.
So 62-year-old female presented with jaundice, pruritus, and clay-colored stool for the last 2 months with significant loss of weight and loss of appetite. In lab parameters, her bilirubin was 10.3 and CA99 is significantly raised. And MRCP suggestive of a mass at the hilum encasing the portal vein. And CT abdomen also corroborate with the MRCP findings. ERCP has been attempted twice elsewhere, but it was failed. So our plan was to do US guided antegrade biliary drainage. Over to Dr. Vinay Dheer.
Hello, can you see me?
Yes, sir.
Can you hear me?
Yes, sir.
Okay, so this is the situation. Many dilated radicals. See, this is the left. Here is going all the way. Segment 3 and segment 2 both can be seen here. And then we come down. My God, this is massively dilated.
Respected chairpersons,
And then
thank
there
you for your
is a
support.
picture.
I would now like to invite as chairperson Dr.
So
Amit Bhasin,
passing a wire
Dr. Ashish
is going to
Agarwal,
be a challenge
Dr. Amit
here.
Kumar Agarwal, Dr.
These are the
Vasudha
lymph
Goyal,
nodes which are
Dr.
blocking.
Neha
See
Bedi,
that?
and Dr.
Multiple
Shaheen
lymph
Asi.
nodes. I think there is a tumor blocking the bile duct here. Here. So puncture should not be problematic. Acha, can we turn a flat slowly, carefully? But it is the flat on the back. Slowly, aram. So I feel the problem here will be because the radicals are so dilated, our wire is going to rotate inside. That's it. That's it.
Vanessa, how will decide we go for an antegrade stenting or a hepaticogastrostomy in such a patient?
So I always try antegrade first.
Okay.
And my
Because
hepatogastrostomy is only, see this, you can see both right and left radicals.
Right.
Yeah, see this, very nice anatomy.
Beautiful.
So,
So
a
you want-
hepatogastrostomy is only reserved for me. Doppler.
Because
So-
that's more physiological, you feel.
Yeah, I like that, and also the stent is cheaper.
Right.
Can we show the fluoro position?
Sir, is there any preference?
So
in
this is
punching?
important before you start the procedure. Look at the fluoro.
Right.
See that your scope is looking towards the hilum and is a little bent upwards. Okay, stop the Doppler. Now we will use a 19 gauge needle. Which one are you giving me? Olympus. So we are using the Olympus 19 gauge needle. The axis at which the needle punctures is also important, because if you puncture it in the direction looking towards the periphery, then it becomes problematic. So these small things are important. Patient is not happy. Why?
For antegrade, our aim has to be segment 3 puncture.
Yes. But in this case, even this segment 2 radical is very nice.
Very nice.
Sir, is there any preference in puncturing segment 2 or segment 3?
I prefer segment 3 because if I have to do HGS, then I don't want the stent to come in the esophagus. Segment 2, if you puncture sometimes, suppose you have to do HGS, although in this case, if you see,
Yes.
segment 2 is looking very, very inviting. Very inviting.
So that's
Maybe I go for segment 2 and see what
okay.
happens. Doppler
Yes.
once more, please. So be in no hurry.
Right.
Small radicals are okay. You don't need a big vessel here. Stop.
So, sir, is there some minimal amount of hepatic tissue that you want before at the site where you are puncturing?
You're already in.
Yeah.
Sir, fluoro image. Can we get the fluoro image?
Aspirate.
Excuse me, can we get the fluoro image, please?
White bile.
So we are getting white bile here. Okay. So we have aspirated about 10 cc's. Now inject little bit. See what's happening.
Sir, you are not audible, please.
Audio का कुछ करो भाई. Okay. Inject.
Audio team.
Inject. Okay. So now we have to find out where is the stricture. That is another issue. See this? Can you see? Saline डालो. Fluoro. You see that? That is where it is. So you have to take a turn. It's not going to be easy. Turn लेना पड़ेगा एक. चलो. This is why antegrade procedures are not very popular, because passing the wire can become a challenge.
What is your preference for the guide wire, sir? Vanessa?
Any specific tricks, sir, to pass the wire across the stricture?
So first and foremost, be gentle. Don't pass too much of wire at one time. Use
Right.
your thumb and index finger to rotate it often.
Right.
Once you find a place, then only advance. If you advance unnecessarily, then if you have to withdraw, you will shear the wire.
Okay.
That is a problem. So we have to be really slow, methodical, careful, trying to look at the angles. Fluoro, please. Aram. You have to go from here up and then down. Ah, nice. धीरे धीरे अब rotate कर. Rotate. हाँ, very, no, नीचे आने का है. हाँ, नीचे. राइट में चले जाएगा तो. आराम से.
Yes, beautiful.
Very
Wonderful.
Try passing it across if we can go through the stricture. I doubt. Other rotate, rotate. हाँ, अभी जा.
Yes.
Rotate
Right.
more. हाँ, गया. Rotate again. Very good. Rotate. Very good. हाँ. First class.
Very.
Keep rotating. Please show below the fluoro. We have not crossed the papilla yet. But now we are in control of the situation.
Okay, very masterly demonstration of a very complex act in a very simplified fashion.
Yeah, actually, I am just holding the scope. Bibin is doing everything. Yes. Without your assistance, you can't.
Vinay?
बस ठीक है. Sister top.
Vinay, yeah.
Who is it?
Yeah, Pankaj here.
Pankaj.
Yeah, would you change to a cystotome at this moment and then try
Yes,
the
now
rest of the wire?
I am doing the cystotome now. So here we have punctured from segment 2 because it looked like straighter. Nikalu? Segment 3 would have been more complex because the whole system is very dilated. Fluoro करते रहो यार बीच में. Don't lose the wire. ठीक है? We are using a 260. निकालो. धीरे.
So what is the wire that you are using here?
It's a 032 Terimo. It's a very slippery wire. Yeah. So now we have to use, water through the syringe because the wire is very short, 260 centimeters. So that is the next challenge. So Bibin is using saline. If you can show his hand, Bibin ka हाथ दिखाओ. आराम से. That is for passing the Terimo. Screen, fluoro, निकालो. Continuous screening. So you see very fast. I have taken out the needle. So this saves time. Now we will use a 6 French cystotome over this wire. And then we go across the papilla. It's also important in between to keep seeing that your wire is seen on the ultrasound. If you don't see on the ultrasound, then that means your scope has shifted. And that's a big problem. So we are using Endoflex 6 French cystotome.
So what was the reason that you punctured from the segment 2? You had you told that you didn't use segment 3 in this particular case.
See, the anatomy of segment 2 radicals was very inviting. So I thought if I puncture from segment 2, segment 3, then probably I will find it very difficult to see. Now I am at the stricture. See this?
चलो पैपिला के पास आगे जाओ.
So is there some way on EUS when you did the earlier part, you felt that puncturing at segment 3 will be difficult to predict
No, no.
that it would be difficult?
Puncturing in segment 3 is not difficult. In
Like
this
negotiating the
case,
wire would be difficult, you felt.
in this
Why?
case, because this biliary dilatation is quite extreme, negotiating the wire across would have been difficult because the intrahepatic biliary radicals are massively dilated. So the wire could have just rotated. आगे जाओ. ये ले. Yeah.
Can we take 1 minute? Dr. Pramod Garg wants to show the partition again.
Go ahead, go ahead.
So go to room number 2, please, Dr.
Yeah.
Pramod Garg. Dr. Pramod? Dr. Pramod?
वहाँ नहीं है. क्या बात है?
Dr. Pramod, sir? Yeah, you are online.
Okay. So what we have done is we have done some necrosectomy, but some large amount of necrosectomy with this necrotic debris is still inside. And now I am using this. Can you focus on this? I am using a ultra thin endoscope, and I have mounted it 32 French chest tube drainage over this back channel over this ultra thin endoscope. So this will help me place the tube under vision at a place where we wanted to place it. Okay. So earlier we could go only till this point, and right now I am at about 12 centimeters. But with ultra thin, we can go deeper into this cavity.
Endoscopic view, please.
Right here. So now we are at about 20 centimeters. So we are deep into the collection here. And this is where under vision, we can place the tube. So can you focus on my hands? Can you focus here? Can you see this tube being placed over the ultra thin endoscope? This is under vision, so I know where exactly it will go.
So Dr. Moon, we can see your hand and you are putting the tube inside.
Okay, yes, okay. हाँ? कितना आ गया? नहीं तो 20 तक चलो धीरे धीरे. अच्छा वो आगे भी है? नहीं अभी आई नहीं वहाँ पे नहीं आई है. Okay, now can you see my tube? I am withdrawing the scope here. And there are multiple side holes here, which will help drain this pus and some of the smaller liquid, smaller debris also. So this way you know where exactly the tube has to be placed, and you can place it under vision. And once you place it, then just connect with the Euro bag.
Dr. Pramod?
Yes.
Can we shift to other room now?
Yeah, please do that.
Shift to Dr. Vinay's room, please.
Yes.
Dr. Vinay?
Can you see us?
Dr. Vinay?
Yeah.
You are online.
Fluoro image, please.
Inject contrast. So you see, we are in the duodenum now.
Right.
We have exchanged the terimo for a stiff wire. Now I am getting some contrast here to see where is the papilla. That is another important step for us. Contrast. We are right at the papilla. Little more. See, we are right at the papilla there. Yeah. So this gives us an idea of where is the papilla. Now the last step is putting in a stent. So why I like these procedures is we can use an uncovered, cheaper stent rather than a specific, EUS specific stent, which are comparatively more expensive.
Right.
This saves money for my patient.
Can I, sir, what is your preference for the exchange guide wire? Which wire you prefer?
It is enough.
Just the length of the.
So this is a subhilar stricture.
Can we have
I mean, even 6 should be okay, but 8 de do, 8 will be safe. Uncovered.
So, Dr. Dhi, in your practice, have you ever used a plastic stent for antegrade stenting?
Sorry?
Have you ever used plastic stent because sometimes patient is.
I have used plastic stents for benign strictures.
In
Not for
antegrade
malignant.
stenting.
For benign stricture, we used plastic stents so that they work as access. Next time when you want to come and dilate the stricture, you go by the side of that stent and then you can again dilate.
So would you be using an 8 centimeter or a 10 centimeter long stent in this
Yeah.
case?
Boston? चलेगा कोई बात नहीं ले ले हाँ 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 ये ज्यादा टाइट नहीं है पहुंच जाएगा. See, if it is very tight, then RX system can give trouble because it is softer. But this looks like not a very tight. No, but RX, yeah, RX 10, it comes in RX. 8, you will have a full wire. I'll have a problem, yeah. Little problem. Let's see if it bends. See, the angles that we have got now are pretty good because of segment 2 puncture. So I am getting a little more adventurous. Thoda wire nikal le.
Sir, I believe it is a 6.5 French delivery system, so maybe further dilatation is not required in this case.
Stuck at the stricture. Okay. So see what Bibin did here was he pulled the wire when I was stuck at the stricture. So all those small things are very important. Now I think I am just across the papilla.
Right.
Open it up a little. Open. Yeah. Open little more. This is good. Yes. Deploy.
Sir, which
So it's
stent are you
nicely
using,
opened
sir?
in the duodenum, you see?
Yeah.
And it's nicely opening now in the bile duct. The stricture area is now.
Yeah.
This is the stricture. And then again you will have a dilated area.
Wonderful.
Yeah. So this is nice. Now the last part of the thing is to remove the catheter. You have to be careful. Sometimes the catheter gets stuck. Okay.
Wonderful.
Thank you. Thank you.
Thank you, Dr. Vinay. I think it's an excellent show.
Thank you.
Am I audible in the hall?
Yes, you are audible.
So I think the next case is one of the kind of the case where I think the surgeons wants to do the right hepatectomy, and with the help of interventional radiologist Dr. Bajal, we were able to salvage this lady, and Dr. Bajal is going to demonstrate how we have salvaged this lady, and we are going to do the reconstruction of the porta. So I request Dr. Bajal and my colleague to present the history.
Hi, good afternoon, everyone. So, this was a 47-year-old lady who had a post-lap chole bile duct injury in November of 22, and about 20 days after that underwent endoscopic stenting, which we saw on imaging was a plastic stent placed into the left lateral segment. She continued to have 200 to 300 ml of bilious output through a surgical drain which had been placed in the subhepatic location. She had an MRCP from outside, which showed that there was no confluence between the right and the left hepatic ducts. And we thought that there was a deficiency of about 2 centimeters length between the upper tracts and the lower CBD when it went down to the ampulla. So that's the MR image, which you can see that the green arrow shows the right anterior system. The blue one shows the left lateral system. The red circle shows the deficiency in the middle. The lower CBD is seen connecting to a collection which drains externally through the surgical drain. And the right posterior can be seen in between, faintly tracking towards the left, not a very healthy union between right posterior and left side.
So a GI surgery consultation happened, which is as the norm for any benign biliary stricture before any definitive therapies are given. And the surgeons opined that in view of the intrahepatic injuries and the inability to do a clean and clear HJ of all three systems, they preferred to offer a patient a right hepatectomy with a left-sided HJ. That wasn't too appealing to the patient and to us, and we all thought that we should try and salvage this right lobe of liver if we can, and therefore went about trying to get the reconstructions done. So biliary tract punctures were done through the right anterior, right posterior, and the left lateral segments. You can see in this that the right posterior is joining the left side. The stump is about just 8 millimeters long, not a very healthy stump. And the arrow will show you. This is the stump between the right posterior, this one, and the left lateral. The right anterior is the faintly opacified structure which lies separately, completely separate from this system. So that's on label, as you can see, the right anterior and the right posterior and the left lateral. So we were able to accomplish an internalization of this, and we, using catheter guide wires from the antegrade approach, got systems across the rent in between and went down the bile duct. Purposely deployed internal external catheters fashioned for this patient, which had a cluster of side holes in the intrahepatic segments, no side holes in the region of the collection or the breach, and then a flower in the duodenum, so that there were no side holes straddling the central part of the traumatized section of the bile duct, so that there would be no leak into the surgical drain. Over a period of time, the surgical drain dried up, and now we have these 3 catheters in C2. So then the discussion happened about whether converting this patient into an endoscopic plastic stent exchange program. But the patient now was quite fed up with repeated procedures and interventions and asked for a short procedure and a short indwelling system if it could be offered. And hence the strategy now is to place a retrievable metallic stent in the right side, place 1 retrievable metallic stent into the left lateral. The right posterior PTBD would stay in C2, and then a few weeks later, the whole system would come out. So that's what's going to happen now, and probably will be shown to you live.
Thank you, sir. Over to Dr. Binay, Dr. Dheer. Dr. Sudip Dhar.
See the
Sudipto, you are
Malikov
on. Sudipto, you are on.
Hi, can you hear us?
Yes, Sudipto.
Hi. In the room guiding me, we have behind me Dr. Nilay, Dr. Brishit from Interventional Radiology. You heard Dr. Bajal give this history, which is a bit complicated. I hope everyone could understand the anatomy of this unfortunate lady. And so the plan here is to place 2 metal stents so that we can reconstruct the porta. Now, as of now, what we have done here is I have intubated the duodenum in the supine position. Dr. Brishit has put in a cannula into the duodenum, and he's now going to exchange the previously placed Malicot for this cannula. Can you hear me still? Yeah. So he's going to exchange the previously placed Malicot for this cannula. Now we are going to do a PTC rendezvous procedure. So if you are you getting the fluoro images in the hall?
No, we are not getting.
Okay, can we focus on the fluoro images, please? This is very important to get the fluoro images here. More than the endoscopy, the fluoro images are very, very important here. Are you getting the fluoro images now?
Yes, yes.
Okay. So as you can see, the guide wire is in the duodenum now. So once I get the go ahead from the interventional radiology team, I will start doing the rendezvous and I'll pull out at least one guide wire out.
I'll give you the mic. Input is
Okay. So
Sudipta, Sandeep here. Would you like to cannulate this white catheter with a wire instead of pulling the wire all the way back to the channel?
Dr. Sandeep, we couldn't hear you in the room. Can you repeat what you're saying? Sorry.
So instead of pulling the wire all the way back through the accessory channel of the duodenoscope and then putting a stent, would you like to cannulate this white catheter which has been pushed by the intervention radiologist?
That's a very small caliber one, I think, and they've already pulled it out, I think.
Okay.
They'll give it.
Give it back, don't worry.
Okay.
Sometimes that exchange is a problem.
Yeah, that exchange is much easier that way. Can someone hold the scope here, please? The scope को पकड़ लो, please. Easy रहता है.
Sorry, yeah, he's putting a mic on you. So that, just.
चलो ये हाथ हिल रहा है.
So yeah. So now we have the cannula back in.
So this white one, for which the wire comes out,
right?
If they pull back the wire and you cannulate this with a wire, then that all goes up into the hilum and can come out to the skin. Then you have a both external and internal control, and you don't have to pull it back into the channel.
उधर sheath in situ है?
Just a
Right
thought.
anterior का कर रहे हो ना?
Right anterior.
हाँ, ठीक है, कर दो.
No, that's
हाँ, निकाल लो ये निकालो.
You can rotate it to favorably to your direction, and that works like a papilla now. It's a papilla which can go in and out.
Yeah,
Tube.
I understand what you're saying here. So shall we go ahead with that plan, Dr. Bejal, or
whichever way you want?
Okay.
You want me to drop a wire through this?
Anything is fine. I think you can drop a wire also. That's also fine. We'll drop a wire.
I think we've already been given 2 wires.
Dr. Bejal, you don't have to put a wire in this. I think Sudipta can put a wire in this white one, and it'll come back to you.
Yeah.
Give me a sphincterotomy, please.
Whichever way you guys want.
Now it's a very favorable direction now. It's looking at you. Sudipta, it's only looking at you.
I'm looking for a sphincterotomy now.
So, Sandeep, give us some credit. I'm doing the rotation of that catheter.
That's right. So
ये तो बोलो.
Sometimes it's
You
very
are the
rarely
best.
चलो.
it's rarely that you have a papilla which is pointing towards you.
Are you going to put a wire?
Yeah, I'm going to put a wire. I'm just looking for a sphincter. I think they don't have a sphincter. They're gone to get a sphincterotomy. I think we'll just
put the wire?
Put the wire. Okay, while they get the wire. Huh?
That this will be if you give them the wire,
Okay, let them get the wire. आगे क्या sphincterotomy? आगे. They've got it, sir. Okay. It becomes a bit of a mess.
मैं पकड़ा. शीत इन है, पूरी इन नहीं है. कर दो अंदर. दर्शन जी फ्लोरो. You want me to do something?
Yeah, just a little bit back, sir.
बहुत सिंपल डेंसिटी वाले एक्टिविटी वाली ये मेटल से चीजें फुली कवर्ड मेटल आ गई. हाँ, फिर बाद में निकालना. हाँ, लंबा होगा हाँ. ओके.
You want me to point it out?
No, just yes, sir. That's all, sir.
लंबे लूप वाले कौन से आते हैं? लंबे लूप वाले कौन से आते हैं?
Pull. I'll rotate it.
So it's too many wires inside, sir. Just let's give the wire, sir. It will
Should I give the
yeah,
wire?
yes, sir. It will be. We'll be wasting too much time on this, sir.
यहाँ पे तुम कंपी डाल लो, तुम्हारी शीट टोटली है ना, परफेक्ट. Okay, here comes. Here, okay. You want to grab this?
Open snare, please. Open. Open, sir. Can you pull it back a little?
Yeah.
Open, open. Open.
Okay.
Yeah, now close.
Yeah.
Close the
So
snare.
would you like to hold the wire from the floppy tip or from the body of the wire?
So feed, sir.
Feeding,
Feed, sir.
feeding.
So open the snare, please.
You have it?
I have the wire, sir. Oh, here. Hold it, please.
Sedation people?
Okay, full cover, full cover.
तुम्हारा कैथेटर बाहर नहीं आना चाहिए किसी भी हालत में.
Catheter of course.
Yeah, remove it now.
Dr. Sudipto, can you hear us, sir?
I can hear.
So where would you like to hold the wire with the snare? I believe you should save the floppy tip because it
Yeah,
damages the
well,
wire.
here actually particularly because it's a rendezvous procedure and both the ends are secure, I'm not particularly worried about the floppy tip per se. Both the ends are secured in two hands. One intervention radiologist is holding, the other end is being held by the thing. So you're holding. Okay.
We have plenty of wire. So you can take.
Okay. It's okay.
Okay, stop.
Stop. What do you need that? Only key. Okay. So I'm just coming out now, sir.
Sure.
I'll just come out now, sir.
Sure.
I'll just come out now. Just
Sir,
give me a-
can we get magnified view, endoscopic view? And
It's just a
simultaneously,
bit-
can you just give us the detail what you're doing, trying to do? Actually, we are not able to see properly.
Second long wire.
Oh, you're locking. दे दो। I'm not gonna do that.
Fluoro. तुम्हें दिख रहा है? Where's your company? Okay. So I think you're too far in, no? So ले आओ, कंपी को पैपला के पास ले आओ. So
आ गया सर, आप पीछे कर दो.
हाँ, तुम अपना पीछे लाओ.
You'll have to pull the white cannula back a bit. Pull it out gently. Okay. Opening of the snare. Opening the snare. Opening the snare. Now pull the push the white cannula in again.
But he has to get rid of his wire. अपना wire withdraw करो. See on fluoro. Fluoro, please.
So the white cannula in. Yeah. Okay, just sorry. We'll just reposition it again for you. Okay.
It's too far in.
No, we are a bit positioned a bit differently. We will position it. Okay. Now can you pull it back? once more?
You should withdraw your wire first and then re-send it. Yeah, come back.
Pull
You're-
back, pull
you're
back,
too
pull
far
back.
in. Come back all the way into the tip.
Pull back. Pull back.
With the snare.
Pull back.
Lao. पीछे तक.
Pull back.
Just enter into the cat. Okay.
Okay, lovely. Now pull back a little bit more.
Withdraw.
Lovely. Thank you. Now just hold it there. Just hold it there. Should just hold it there. Hold on. Just a minute. Huh? Open the snare. Open the thing. Now close. I'm not sure whether I'm holding that, if I'm holding.
Sir, during rendezvous procedures like these, what is the accessory that you use to hold the wire? Is it always the snare, or
Are you
you can
feeling?
use a forceps or something to hold just the tip?
We're using a snare here.
So you
to
can,
hold
can you use a forceps or something like that?
The
just to hold
forceps
the
tend
tip
to
of the
slip off. The guide wire tends to slip off.
slip?
A braided snare is always preferable.
Open. Thank you. So we have now both the snare, both the wires. One from the right anterior and one from the left system. So, would you like to put some contrast just to define the anatomy? So we now inject a bit of contrast to define the anatomy before we.
Can we get the fluoro image now?
Focus on the fluoro, please.
छोटा सा ही वायर रखो यार बस हमें इतना ही चाहिए let them take as much wire as they want, just leave a little bit.
हो गया ना?
Contrast 50-50.
अरे रुक जा, रुक जा। और ले लेते हैं? Wire is there, no length is there, no wire.
Yeah, we've got. We're holding.
Sure. Thank you. Thank you. Okay.
Darshan ji, fluoro करेंगे?
So we'll just do some fluoroscopy just to get the images now.
So that's the right posterior and the left side that's getting opacified. Can we have थोड़ा सा oblique करेंगे? आ रहे हो? हाँ करिए. Okay, but that's fine. That's fine.
No, first time, no wire.
Centering कर लेना to the right side.
It's in a loop, not.
So we've just made a little RAO projection, a right anterior oblique projection, which shows the right posterior and the left lateral with that stump there. And below that comes the right anterior insertion. So since we have the right posterior PTBD catheter, which is
yeah.
Sir, we are moving our camera to the next room where Dr. Rajeshwari is performing this for a few minutes.
Okay, just before you go, can you just have a look at this last image of the thing, because Dr. Bajal is just explaining the anatomy.
Sure, sir, no issues.
So you have now the opacified system is the right posterior coming from the right, and the left lateral from the left, confluencing just above where the right anterior wire goes down. And the common stump, therefore, of the left plus right posterior is approximately about 8 millimeters as we measured it before the interventions had happened. But there is no fear of jailing the right posterior because the internal external catheter of the right posterior is going to stay in C2. So very comfortably, the retrievable covered metallic stent can be inserted into the left side. The segment 4 duct is very much upstream and therefore no fear of jailing that either.
So Dr. Sudipta, should we move now?
Yeah.
So our next case is a 37-year-old male who is a case of acute pancreatitis onset on January 2022, presented with pain abdomen and abdominal distension since 5th April 2023, without any history of jaundice, vomiting or fever. On perabdominal examination, it is suggestive of ascites. His ascitic fluid analysis shows amylase of 9,000. CT shows multiple pseudocysts and moderate ascites. MRCP also shows dilated PD with a pseudocyst. US shows dilated PD of approximately 5 mm in the body region, intrapancreatic collection. MPD is continuous with the cystic collection and gross ascites. Patient underwent ERCP for PD standing elsewhere, but cannulation attempt was failed. So our plan was to do US guided PD drainage. Over to Dr. Rajeshwari.
Good evening, everyone. I am audible in the hall.
Yes, sir.
Yes, sir.
Am I audible in the hall?
Yes, sir. Yes, sir.
So I think the time is short. So if I was able to complete in next 10 to 15 minutes, otherwise we are going to start the lectures there to keep the program on time.
So you have heard the history, young patient has alcoholic pancreatitis with a disconnect in the head and neck of the pancreas with the evidence of chronic pancreatitis. And my scope is in the second part of the duodenum. And I'm just going to show the area of disconnection. And Dr. Gaurav Chawla and Dr. Vinay Dheer and Vikas is with me to help me during this procedure. So can you put the Doppler, Bhagwan? So this is the area of disconnection. Dr. Adolf. This is the area of disconnection. You can appreciate here. This, we can see the pancreatic duct distal to this. So in the neck of the pancreas, there is a disconnect. Can you appreciate the put the Doppler? So this is the pancreatic duct.
Can we zoom in into the EUS image, sir?
Can you see now? So this is the hypoechoic area which is visible is disconnected area. Pancreatic duct is visible here. And proximal to that in the head region, we cannot see. And as we withdraw our scope, this is the pancreatic duct. You can see my cursor is there. And as I withdraw, you can see the cyst. And just distal to the cyst towards the body, you will see the pancreatic duct which is dilated. I'm going to demonstrate now. Can you appreciate the duct Doppler? This is the Doppler. So this is the duct. Remove the Doppler. So this is the duct which is dilated going into the pancreatic fluid. Can you appreciate here?
Yes, sir.
This is the duct. So the plan is to puncture this duct. If I am able to cross through this cyst into the head, it is okay. Otherwise, I am planning to do the pancreaticogastrostomy or a pseudocyst drainage going through the path of the pancreatic duct. And if I look at the diameter of the duct, can you measure the diameter of the duct? Yeah, the only thing is you see the lot of pancreatic parenchyma in between. Is that okay? There's a lot of pancreatic parenchyma here and lot of inflammation is here. You have to go through the long distance. If I puncture the duct, I have a two advantage. One, if I can cross across the head stricture, I may be able to preserve the head of the pancreas. That's one advantage. And second is the distal duct, we are not very sure how going to behave. If you only drain the cyst, then it will depend in the future, because if you see in the tail of the pancreas, there's a changes of chronic pancreatitis and lot of inflammation is around. So what I'm going to do is I'm going to puncture the using the Olympus 19G needle. If you look at my scope is in the straight position, directing towards the head of the pancreas. Can you enlarge the image and put the Doppler?
Rajesh, Sandeep here. Would you, Rajesh, can you hear me?
Yeah, Dr. Sandeep, I can hear you.
So would you like to drain the cyst instead of the duct?
Dr. Sandeep, cyst is quite far away. The Vikas has asked the same question.
But crossing the, puncturing the duct.
Dr. Sandeep, can you speak little loudly?
Okay. Can you hear me now?
Yeah, I can hear you.
Okay. So do you think the wire would cross the stricture and reach the papilla? It's
So,
very unlikely. It's going
yeah,
to bounce back on the cyst itself.
I agree. The plan is to do the cyst drainage. If you look at, there's a lot of inflammatory changes and long pancreatic parenchyma inflammatory changes. If I go through the stomach, what you are saying, Dr. Vikas has raised the same question. If you do a cystogastrostomy, putting a plastic stent, yes, that is feasible. But you look, there's a lot of inflammatory changes. So if I puncture the duct and put my stent inside, then I can create an alternate passage.
Can you try
Yes,
once through the duodenum in a long position? This is a short position. If you try in duodenum, maybe you'll compress that soft tissue also, and it may be.
So you are talking about the duodenobulbostomy?
to the cyst.
Cyst we
Cyst
can
drain to the
see from the head of the pancreas. I will show you. Let me just go to the duodenum. Look at here.
Ascites too.
Yeah, there is a drain placement done,
So
and
why not
daily
wait for
around
it
1
to-
liter of the fluid is coming.
Would you not like to wait for some more time to inflammation to settle down and then try interventions?
Sandostatin, Dr. Sandeep.
No, not
doesn't work.
sandostatin. Waiting for the inflammation to settle down.
Yeah, that's one of the possibility. I agree. That's absolutely agree. We can wait for some time.
Another conference will come soon.
Is already tried. There's a disconnect in the neck of the pancreas. So, Dr. Sandeep, that is a well-valid point that we can wait for some time. And if the audience feels that we should wait because of the lot of inflammation, definitely we can wait. But you see my scope. Can you put the scope? So my scope is just in the pyloric antrum. Can you appreciate?
Yes, we can see that.
So from the duodenum, we cannot do.
No.
Can you appreciate?
This looks quite.
So what is the consensus in the audience? Should we do or we should not do?
Okay.
Should we do?
I think Neha can take a poll from the audience. Neha, you can do the audience
If
poll.
the audience says no, then I will withdraw. If the audience says do it.
The audience for this. So all those who feel that we should wait, kindly raise your hands.
Welcome,
please.
sir. No, what is the audience poll?
All those who feel that we should go ahead with the procedure.
Should we go ahead with procedure?
So the audience says.
Most of the audience feels we
Most
should
of the
wait.
audience feels we should wait.
I should wait.
That's what the poll says, sir.
I can wait. Is absolutely fine. So consensus in endoscopy room is to proceed.
What are the exact symptoms?
Can you speak loudly? I can't hear you. Dr. Sandeep?
Yes, Rajesh. Go ahead. What do you think is right for this patient?
No,
I
no.
think
What is the audience?
So it's Congress versus BJP here.
Can you show the fluoro? So my scope is directing towards head. I have taken out the sheath. I will withdraw the scope little
So
bit.
let's ask the people who have the maximum experience.
Yes.
Okay, so let's just hold on for a second. Let me
Yes.
take to the two giants sitting here. Dr. Sood, Dr. Reddy, and also Anthony T, who has a reasonable experience. Dr. Reddy,
Yes.
what do you think?
So Rajesh.
Yes, sir.
So I think the thing is, how symptomatic is this patient?
How?
Symptomatic, the indication for the procedure?
Indication of procedure is patient has a pancreatic ascites.
Okay.
Patient is on the percutaneous drain,
Okay.
daily draining around 800 to 900 ml of ascites.
Okay. So you think by draining this, you can going to decrease that?
Yeah, because the reason is that on MRCP, we have not documented the site of leak. But there is a possibility patient has a leak from some site and patient has a disconnect in the head of the pancreas.
Yeah.
So no drainage of the pancreatic juice from the papilla is draining in the abdominal
but
cavity.
MRCP, did we see the drainage come from the duct or from the cystic area?
So MRCP we have shown, it has not shown it is going towards the cyst because there is a disconnect in the neck of the pancreas.
So what are you now draining now? The duct?
So my plan is to drain the pancreatic duct and the cyst.
Both.
Both. Through the pancreatic duct.
No, through the pancreatic duct into the cyst.
Yes.
Oh, I'm not able to understand that exactly. So wouldn't that increase the leak?
Yeah, my feeling is.
Reason why I'm saying that is that there's a lot of literature now to suggest that if you have a pancreatic ascites and a pseudocyst bone, whatever it is, draining the bone does not affect the ascites, how it's forming and so on. So if you're going to drain the pancreatic duct itself, then I agree. Selective drainage of pancreatic duct, I would agree. But if you're going to drain the cyst and cyst through the duct, I find it a little more difficult to get the physiology part. So I would, the bottom line is I would probably wait. Unless it's very, something that has to be done
So
very,
Dr. Reddy sir, the question is how we are going to stop the pancreatic ascites? For how long we are going to wait and what should be the approach?
Pancreatic ascites, the continuous drain has been put.
Yeah, patient is a continuous drain and daily draining 1 liter, which is an amylase level of 3000.
And put on octreotide?
No, I don't think in our experience in the literature also doesn't favor that putting the patient on the total parenteral nutrition and the octreotide is going to benefit. It take long time, doesn't shows the good outcome.
So anyway, I think you already put the needle in.
No, sir, is not the issue. If you feel the only point is how we are going to decrease the ascites, that is the point.
I agree. It's a dilemma. I think it's a very difficult case, a difficult dilemma that we all face in daily practice. My feeling is that if the duct is big, you can drain the duct. That would be the ideal thing. I would not interfere with fluid collection. Yeah.
Yeah, sir, the reason is that, Dr. Reddy sir, if you see, this is the duct.
Yeah.
And this is the cyst which is going on.
Yeah.
And if I do on the tail side,
yeah,
I hardly find a significantly dilated duct. We are going through the pancreatic duct and the pancreatic juice from the tail as well as the remnant body will come here and is going to drain. That is the thought process.
You want to?
The duct is communicating with the system.
I think Randir.
Yeah, Rajesh.
Yes, sir.
You know, draining the cyst or the fluid collection is justified when it's a chronic pancreatitis, a cyst which has leaked. And then of course pancreatic ascites will respond. But in a patient of acute necrotizing pancreatitis, it's ductal disruption, which will invariably heal over a period of time. And so either we drain the duct alone or we wait. Because draining the bone through the duct, I don't know whether that will help or not.
So can I put my viewpoint on this case?
No, Anthony is here. I think we'll have his views.
So how long has the ascites been going on for?
So ascites is going from the last 1 month.
And the output has been all the same? Like
it has not decreased. Patient was on the percutaneous tube outside the hospital for 15 days. It came out and from the last 4 days we are draining. First day 2 liters, now around 1 to 1.5 liters per day. And my concept, which I feel, we are going through the duct means we are draining the ducts. We are not draining. One part of the stent will be in the cyst, a part of the stent inside the duct, and the part of the stent in the stomach. So we are not draining the cyst, we are draining the duct plus cyst. And as patient has a disconnect in the head of the pancreas, the fluid is going to continue to leak. When we talk about the chronic pancreatitis, there is a spontaneous healing.
Rajesh sir.
The failed PD cannulation.
And where is the percutaneous drain? Is it very close to your collection?
Can you again repeat?
Where is the percutaneous drain? Is it very close to the collection?
Can you again repeat? What is the question?
Where is the percutaneous drain?
Where is this place? It's in the iliac fossa.
Can you
It's in the iliac fossa.
iliac fossa?
Yeah, right iliac fossa. So here the people say we should do it. So I think we should not. Let's take a call. Should we do it or we should leave? I think we are getting 6:30 p.m.
We should do it. We should.
You
take
are
a
holding
call.
the scope. You decide.
Because this is the last
So
thing
I
we
think
can
it's good.
do for him.
So we
It's
will-
already been a month, sir. I think you have waited. We have waited already a long time now, and probably we should go ahead with the procedure, sir.
Okay, so let's go to Dr. Basil room and let me finish the procedure here.
भगवान देखो मैं कर पाऊंगा दो कर्सर हटाओ हटाओ डॉपलर
So you say I am in the pancreatic duct. Yeah. Can you put the dye? Fluoro? Can you put the dye now?
Picture.
Sir, during PD cannulation, do you put in directly the contrast or did you also aspirate?
We aspirate, but the most important thing is we make sure that these patients should
Can we
not
the
have
fluoro
a
picture, please?
thin PD. Not going.
Can we
Fluoro
get the
picture, sir?
fluoro picture?
Can you enlarge? Yeah. Can you show the fluoro?
It is going into.
कोई बात नहीं. Fluoro.
Also the small EUS image, please.
Can you enlarge the fluoro, please? Can you see the cyst is filling through the duct? Pardon? What is it? No, that is outside.
So, sir, your needle is right now in the PD. Not it has not. You have not drained it into the cyst yet.
No, my needle is in the PD. Yeah. Done. Can you see the pancreatic duct now? This is the leak part. Can you see the leak part on the fluoroscopy?
So I think, Rajesh, if you just drain the duct, you will get very good effective, because you see the whole thing is draining from the duct. So if you can stent the duct, I think you will have a very good result in this case.
Put the wire. Put the wire.
The challenge here would be to advance the guide wire into the duct and not into the cyst.
Yeah, from the duct, it will going to go into the. You see, there's a duct which is there. Can you see just above that there is a duct? Right. डॉक्टर बैजल के रूम में जाना हो तो चलेगा डालो ग्रेजुअली So the fluoro, please.
Sir, where is the leak exactly on the fluoro?
The wire has kinked. Slowly. So this is one of the trick. When your wire is stuck, I have taken my needle into the pancreatic parenchyma. Huh? Huh? You see, this is a pancreatic duct. Can you aspirate the cyst first? Will you aspirate the cyst? Aspirate the cyst. Aspirate the cyst. You see the dyes coming to the duodenum? Can you see the dyes going to the peritoneum? Can you appreciate on the fluoroscopy?
Yes, sir.
Can you see the dyes going into the peritoneum?
Yes, sir.
Yes, sir.
See the leak from the distal body, sir.
That is some track. It's not peritoneum. It's a track only. Peritoneum, it would have diffused and disappeared by now. The previous dye disappeared, which possibly the duct emptied there. I think now we can just drain this cyst off. And
Yeah, we are aspirating the cyst fluid, Dr. Sandeep.
okay. And then
we are putting the plastic stent. I'm going to put the, can you show? This is the fluid which has come. Is the fluid visible?
No, sir.
Sometimes if you
Can the camera-
aspirate this fluid out, you get a favorable anatomy at ERCP. You can do a transpapillary thing. I can see the color now.
Yeah,
It's hemorrhagic.
so can we aspirate more?
You can empty it, and then if nothing works, maybe try transpapillary once again. You will get some duct to go deeper in.
But you see the dye has leaked definitely. Just, it's okay. वो लो, hydrophilic wire लो, देखो. What is the time? What is the time?
6:30 exactly.
So, sir, why are we exactly aspirating the cyst? We are planning to advance the wire across the leak into the.
Yeah, we are seeing that if it is possible, that we are trying. That is the thought process. Can we shift towards Dr. Bajal side?
That is in the leak. That is in the leak outside peritoneum.
Yeah. Can you show? Yeah. No, put the guide wire. Don't pull. Don't pull. Push the guide wire. Let's see where it is going. Good.
Sir, where is this guide wire?
Yeah,
Going?
we have to check where it is going. Show the fluoro. Yeah, I think we can check cystotome, na? Withdraw. This may be the site of
Is it
leak.
duodenum or is it peritoneum?
Yeah, we will just check. Aspirate.
Yes, sir.
Take the wire a little bit. I will finish it over.
Bowel, duodenum.
Yes.
So we're shifting the camera to Dr. Dhar's room.
Okay, you can save. Can take the cystotome.
Dr. Dhar, you are on.
Hi, so now what we have done is we've pulled back the Malicot catheters, and now we have placed one fully covered metal stent into the left duct. You can see the one of the fully covered metal stent just above the clips. Place that, and we'll start. Can you see that on the floor? Yeah. So we'll start.
Yeah. Now we are getting.
Okay.
And
Now we'll start deploying. Yeah. The fluoroscopy image is more important in this case. I think we'll stick to that. That is very, very important to have an idea of the anatomy that we are trying to treat. So can you get the fluoroscopy images there?
We're getting it.
Yeah. So you can also explain actually while it's going on. So we'll start deploying the stent.
So they're deploying the stent in the left lateral segment, and the plan is to have the distal end, which is inside the liver,
Just a minute.
beyond the insertion of the right posterior, which is protected by the right posterior catheter anyways. नहीं और अंदर भेजिए.
What is the size?
It's already deployed inside.
Already deployed.
Already inside, the deploying inside. Sir.
Okay.
Yeah,
I can. Okay, I think I can see it. Okay,
It's deploying inside.
Yes.
Am I audible?
Yeah, I think it's a 1080 they are using.
Sir, have you first taken access to both the systems via wire, or you are doing one by one?
Can you see the upper end of the stent?
Yeah.
There's an echo of the sound.
Can you zoom on to the top?
Zoom.
So do you have wire access in both the systems?
I pulled in a little bit. That's fine. Now start. No, it's fine.
Pull, I'm saying.
The upper end of the stent.
Yeah, upper end of the stent is.
Don't take it back. Don't take it back.
It's fine.
Otherwise, that part is diseased. If it hits a diseased CBD, it will just give way.
Okay. So we just deploy it at that level.
So we need a healthy landing zone. The right posterior is protecting the right posterior. So there's no fear.
So we'll just pull it back. It's okay. It's fine actually out there. So
we'll
start
even
deploying.
higher also. No problem.
Deploy.
Okay.
It will not.
So you're taking out everything?
No, sir. Would you like to keep the malicot there, no, sir? Or something there?
No, not everything. On the wire, the stent is.
No, sir. One second.
So you want the wire?
No.
Yeah.
You would like to keep something inside, no, sir?
Because,
So this is a
actually,
fully covered
but it's-
stent,
Yes.
Yeah, it's a fully covered stent.
10 mm diameter.
Yes.
So the discussion is that as a security, should we keep a catheter before pulling it out? That she's been there with the catheter for so long.
We can clamp it and see how she does.
So for fear of losing access, we can keep a small catheter and then pull out the guide wire. External
Other
catheter.
two tubes will remain.
Yeah, we just keep a small external catheter dangling inside
Okay.
the stent just for access.
And what about the right anterior duct? Which is
Now we are going to do the right anterior, Dr. Sandeep.
So, Sudipta, with the normal bile duct accommodate 10 mm diameter stents fully covered.
I know.
Yes.
Fluoro?
Just a minute. So
Fluoro?
you okay, sir?
Just a minute.
Just a minute,
I'll
sir.
just deploy the
Just
external
let me,
catheter.
let me, sir, deploy the external catheter. Okay, sir.
Okay, that's it. Now you can, you taking the wire?
Shall I take out the wire? No, there's a sharp end.
This
That's it.
stiff end is on
Sir, we'll
this
take out
side.
the wire.
Ah.
Sir, wire nikalenge. The wire has to be pulled out from the
Percutaneous
percutaneous root because the sharp end is on that side. So the wire has to be pulled out from sir side. No problem.
Are you going to feed?
I'm going to feed, sir. I'm going to just extend this and feed. Feed. Just hold on. Now I'm going to feed the wire while you exchange it.
Yeah. Okay. ले लो आप जोर से मत खींचना आता जा रहा है तो आप लेते जाओ हाँ नो पुल्स हाँ आप निकालते जाओ ओके ओके You're still feeding?
Yes, sir. It's already done, sir.
Okay. Chalo, le lo.
So can you tell us what you're trying to do?
Getting rid of a guide wire on the left side. So now they're going to deploy the right side, right anterior.
So now the challenge is to get it on the side. So those are the two stents that are available. Hopefully I should be able to. Because there's traction on both the sides, that's the advantage here. So hopefully we should be able to get in. Let's see.
Wire pull karo. So we are intermittently giving a little pull on the percutaneous side. The side is protected with a sheath, so there's no fear of cutting the liver parenchyma, just helping the stent come up.
Can I get a bit of fluoro, please? I just don't know.
There is, you are virtually there.
Just a
You're nearly
little
there.
bit more. So the point that we wanted to show, can we just show to put a bit of contrast to show exactly where you wanted to deploy? So we'll put a bit of contrast, and you can see there's a leak happening.
You see that vertical branch which is going up? So we don't want to jail that. So the metal stent will just finish at its mouth.
Okay. At this point only, where the clip is.
Just beyond the clip.
Yeah.
We have a few millimeters of safety.
Yeah.
So we just want to go a few more millimeters more.
And then pull back.
Yeah. So now I need a bit of traction. Can I get a fluoro, please? Okay,
you're beyond.
I'm beyond it, but it start coming out. So
okay.
Once you start deploying,
sure.
Nilay, what do you think of the stent position?
Zoom कर सकते हैं? Zoom. हाँ एक step zoom कर दीजिए.
एक और step zoom. एक मिनट बहुत दूर नहीं है ये रहा ये Yeah.
All right.
We are fine. थोड़ा इधर रहेगा तो कोई प्रॉब्लम नहीं.
ये थोड़ा बाहर रहेगा, कोई प्रॉब्लम नहीं. Can you just do a bit of? अच्छा, एक मिनट. Just have a look at this stand position. So what do you think of stand
Yeah.
position? Should I pull it a bit
So
more?
you'll have to,
Not right now. Not right now.
so subsequently you'll have to pull
Pull
it.
back.
आप open होने के बाद pull करके.
So can we start deploying?
So can you give
Start
us some
deploying?
practical tips simultaneously so that we should not lose excess?
So now we are going in. Now we're just pulling it a bit more. Just pulling it.
थोड़ा सा pull.
Just a minute. I want continuous flow,
Okay,
please, and hold the scope.
that's it.
That's it.
Now no need for further.
Yeah.
You were in the safe position.
Yeah. Now hold the scope, please. Yeah. Now can you deploy?
Very nice.
Sir, I
Deploy.
think for the sake of time, we
Oh, it's going in again.
we will
Just
start
going in.
the talks here. And towards the end, when we are finished, we can show the results for both the cases. Is that okay? Yeah. So
Very nice.
I'll just
Keep on pulling.
like to start the last session for the day.
Stays here,
Yeah.
maybe a millimeter more back.
I would
if
like
you
to thank the
can.
chairpersons for the
fine, sir.
contribution.
ठीक है, चलेगा.
Now for the most
chalo,
awaited
karo,
session,
karo.
the state of the art lectures. I would like to invite as chairperson, Dr. Randhir Sood sir, Dr. Anil Arora, Dr. Mohesh Goenka, Dr. Amit Miglani. I would also like to request Dr. Nijavan sir to please join as chairperson.
Good evening, friends, and I think towards the end of the day, we have very exciting talks by the stalwarts in the field. The first talk is by a dear friend, and everybody knows him, Dr. D. Nageshwar Reddy. I was actually delaying it because he was having tea, so I thought he would let him have at least half a cup. So Nagi is speaking on the era of US. Are we traveling from ERCP to US in Pancreato biliary interventions? And he's the most appropriate person to deliver this talk because like me, he's also going to lose his job because if you are traveling from ERCP to US.
Yeah. So thank you, Randhir. I'd like to thank Rajesh and Manoj for giving me this opportunity to talk on this, I believe, a very evolving subject. So I've started ERCP 40 years back. And is it going to be that we are becoming dinosaurs? Actually, 4 of the moderators are like me. Started very long back. I think it's a little younger person there. So you must be doing both. Yeah. So you see, it's a very senior panel sitting here and wondering whether we are going back in history and that the era is over. So I contemplated on this and thought, let me look at it in a more balanced way. When US started in 1989, it was not a very popular procedure. It was predominantly diagnostic, although I think this afternoon Adarsh was emphasizing to go back into this, but I think we've gone beyond that. We're now gone into therapeutic US, and therapeutic US is more exciting, more rewarding, and probably this is the era that is going to guide what's going to happen in pancreatico-biliary area, as you've seen in several demonstrations that came. The first therapeutic US biliary drainage was done in 2001 by Mark Giannini. He was actually trying to cannulate the bile duct on ERCP, failed on 1 or 2 occasions, got frustrated, took out a EUS scope, and then drained the bile duct and reported this. This started the whole era of EUS guided drainages. Soon after, Marty Freeman and Mallory Sean reported a series of rendezvous procedures that they did in patients with difficult biliary cannulation. Marty, of course, was an excellent ERCPist. He couldn't get in, so he called Mallory, who was a good US guy, and together they did the rendezvous procedures, which was reported as a series at that point of time. In 2004, meanwhile, 2002 actually, Pierre Depre from Belgium reported the first well-documented, earlier Japanese had done, but this was the first well-documented pancreatic duct drainage. They used again the rendezvous technique for a difficult pancreatic duct cannulation. So this, about 20 years back, set the era for pancreaticobiliary drainage using endoscopic ultrasound, which was never imagined when endoscopic ultrasound first came. So what happened at this point of time was that as these procedures got better regularized and became more common in practice, we shifted from PTBD to US. And this was okay for the endoscopists because it was the radiologists who were getting hit. So it's okay, we shift to US, and we now know, based on several studies that have come, that US is definitely superior to PTBD in several ways. In terms of clinical success, adverse reactions, and re-interventions. And this was the famous meta-analysis by Ream. So in fact, an editorial at that point of time suggested that we should stop doing PTBD. I think Bijal is their other side, so you won't be happy about it. But the suggestion was that we should switch over completely to US, except a small group of patients who have right hepatic ductal obstruction. We should do US guided obstruction. In fact, the ESGE in the latest recommendation suggested that US guided biliary drainage should be done preferably over PTC in patients. They put a local expertise there, but I think this has become local expertise available everywhere. So US. So therefore, now it's very clear that PTC or PTBD is undergoing a death phenomena being overtaken by US. Again, it was okay for ERCPs that this happened. So the initial indication for US has been failed ERCP. And this again is very acceptable for everybody here that this has to be done. And we have had several talks on the techniques of how this is done. US guided hepatogastrostomy, choledochoduodenostomy, transgastric rendezvous procedures, and the different things that we can do to drain the bile duct either from the bulb or from the stomach, and techniques that are. Similarly, I think Sandeep gave an excellent talk on how the pancreatic duct can be accessed and drained routinely. And we just saw a procedure now that Rajesh has done accessing the pancreatic duct. Again, they become very standard procedures. I won't go into the details. But a little game changing occurred with this paper from Vinay Dheer, which came again about 10 years back, when in their center they showed that if you have, instead of doing a pre-cut, you do in EUS, or if you fail at pre-cut, you do an EUS, quickly go to an EUS, then of course your success rate increases, the adverse reactions are less. There's been debates about this article because nobody actually reproduced this completely as it came. One of the issues was the size of the bile duct. If the bile duct size is small, as in many of the cases, can you have a nice success rate with the EUS? But at least it put into the mind of the ERCPs and endocrinologists that don't try too hard with all these pre-cuts and all. You can immediately go to a rendezvous procedure to succeed, causing less adverse effects. And this was the concept that came in by this paper. So the main indications for bile duct drainage till then were that patients with obstructive jaundice failed attempt at ERCP because of duodenal obstruction, post-surgical, or you can see the last one which came because of this paper, failed selective cannulation. Now, this is very difficult to define. How do you say failed selective? There are, I think, 4 experts here at least who have done so many ERCPs that for them failure is be very, very small. The others in the audience in whom failure would be 2 ERCPs and so on. So I think it depends, a very, very difficult term to define, although if you look at all the guidelines, they'll talk about 5 times, 5 minutes and so on. I think that's not practical in true sense. At this point of time, the European Society gave these guidelines that indications for bile duct drainage should be at where expertise is available. Biliary leakage is a problem and this should be tackled. There should be PTBD mandatory backup, which is one of the things emphasized, which was not there earlier. The biggest problem with US drainage even now is the lack of good accessories. We don't have proper accessories which are available specifically for this. All of them are mainly borrowed from, till recently, borrowed from the ERCP guys and using the same guide wires and same things and so on. And also, I believe very strongly that those who are doing EUS should have equal skills with ERCP. It's not just going to be EUS alone. That era is gone. It's going to be pancreaticobiliary endoscopy, as rightly emphasized in this workshop. Of course, indication for pancreatic drainage, Sandeep has emphasized, and this has become very standardized. And what happened in the last 5 years is that accessories have started developing specifically for US. And this happened because the industry saw that there's a market. Okay, they saw shift towards the US, they saw a market, but still the growth is very, very slow. As you can see, specialized stents that are coming up and so on, but it's occurring slowly over a period of time. So if you look at what's happening in this field, you have first EUS for failed ERCPs, which is established. Everybody here, all the endoscopists are happy that this what should be done. We have EUS for assisted ERCPs. I'll show you that again. And this we know is something that came in because the paper that Vinay published, it became much more easier to do this. And finally, we come to the last point. EUS instead of ERCPs, it makes all of us redundant, at least the ERCP guys. So if you have difficult papilla like this, you can't get in, then you can go US, put in a needle, and then put in a guide wire through that, and then of course pick it up at ERCP and finish the rendezvous process. So this is an EUS assisted ERCP, which is accepted, okay? In fact, the ESG in the latest guidelines suggests that the US guided rendezvous techniques should be done after failed second ERCP. This is interesting. What we would do earlier is we do an ERCP, fail, we go to second ERCP, fail, sometimes 3-4 times also as ERCP guys. But now the guidelines say don't do it so many times. Fail once, go quickly to US. So little difference in your thinking, the strategy has changed a little because of this. Of course, there are other areas how US assists the ERCP, and this is the edge technique where if you have a Roux-en-Y bypass and the stomach and the pouch are separated, you can put in a lamps and then go through that and do an ERCP. This is one of the examples of how they're coordinating. So we come now to this point. I want to spend a few minutes on this primary US. Now, there's been a debate about an hour back, a lively debate where I think Praveer and Amol presented their both sides of the argument very nicely. So I want to add a little more spice to this and probably look at some of these points again to see what we should, because this is a very, very important issue. It's going to change the trajectory of what is going to happen in pancreaticobiliary endoscopy. That's why I emphasis on this. The reason why US drainage was suggested is that traumatic papillary manipulations are avoided. Of course, so that acute pancreatitis doesn't occur post-ERCP. Even when you can't reach the ampulla very easily, you can do an US drainage. And because the stent is placed away from the tumor, biliary infiltration is not there. This is the argument for this, okay? I think very appropriate argument if you look at it actually. There have been 4 studies in this, 4 studies, randomized studies, and it's been discussed. But what has not been discussed is out of these 4 studies, only 1 study actually reached the primary endpoint. The rest of the studies were all did not reach the primary endpoint. The rest of the studies showed equivalence, that ERCP is equivalent to US. Now, that's a different argument. If the equivalence is there, should we abandon the old age, what we're doing for maybe 40 years and then take up something just because equivalence is shown? Again, this is a question. If you see the first study that came, which came from Korea, didn't show any difference. Small number of patients didn't show any difference between both the groups in terms of success rates and so on. But this is the interesting. This is the only study which showed superiority, in my opinion, superiority of US over ERCP. And this was the Pike study where they showed the stent patency is much longer with EUS, and therefore the quality of life is much better with EUS. Very strong argument. In fact, if somebody had to convince me about primary EUS, I take this study because the prolongation of the stent patency and quality of patient doesn't have to keep frequently come to the endoscopist. But look at this study a little more. Post ERCP in this study was 14%, and all of them were distal tumors, pancreatic cancers, 70%. 14% ERCP rate in pancreatic cancers, to me, looks a little, dicey. And more important is 0% complications in the US. Anthony, 0%, somebody more expert than you here. 0% complication rate with EUS. So with this study becomes a little, I mean, I wouldn't put too much faith on that. In fact, if we dissect it further, in 70% of the cases, it was a pancreatic carcinoma where they produced this pancreatitis. Of course, at that time, they did not use rectal NSAIDs, which is again a point against. And as I said, it was a 0% complication rate, which I don't think any endoscopic procedure, maybe flexible sigmoidoscopy may have 0% complication rate. So it was a non-inferiority comparison study. So I was getting a little worried about this study. So this came. And then, of course, came sham study, which was done typically in patients with distal tumors, but 5 of the patients in each group went actually for surgery. And then this is again something interesting. They showed equivalence. Both are equivalent. There's no difference. When you look at 5 of the patients who went for surgery in both groups, the surgeon actually found it more difficult to resect those patients who had an US biliary drainage. Why? Because there was a little biliary leaks. When you put in a trans bulb stent into the CBD, invariably small amount of bile leaks. There will be small amount of bile leak. And this bile leak is very fibrogenic. And Pankaj is agreeing with me as a surgeon that there's severe fibrosis produced around that area. And the surgeon finds it very difficult. So if you're doing it in a patient who's going for a surgery, forget it. Kindly don't do, because so the surgeon is going to curse you. So this is, in fact, at that point of time, I was asked to write an editorial in GI endoscopy, and I titled it as "Not at Prime Time." So that is still good. That is still going to, is still not prime time. And then came the mother of all RCTs from Anthony's group, which was suggested, the latest one suggested that although both the techniques were equivalent, the technical success, of course, with the ERCP was low because they're dealing with distal tumors where you can know the technical success is low. What they actually had, the primary endpoint in their study was actually stent patency. And you see, stent that was not met, stent patency was similar. This was because more, if you actually, in spite of the fact that they use the lamb stent, I'll come to that a little later, but this is very interesting that procedure time less. All the 4 papers that say procedure time is less. Now, for me, it doesn't make a difference whether I drain the patient. It takes me 11 minutes or 17 minutes, as long as it's a good, safe procedure. So just because ERCP is taking 5-10 minutes extra doesn't mean that it's an inferior procedure. It's just that the whole technique of ERCP is different from US, where you see a cavity, you jab in and put a guide wire and stent. So much more straightforward with ERCP. So that is one. But there are 2 other important things in Anthony's paper. Maybe we discuss it later. They were, if you see, look at the ERCP complications, 2 perforations, which is 3% perforations. 3% perforations. I know earlier on he was asked the same question, and Anthony said there's different centers, so it's difficult to say, but I think that is significantly higher than what you would expect. The other thing is the size of the bile duct, and this has not been emphasized. This is what we should talk about. And even in his paper, Anthony has talked about, if the size of the bile duct is less than 16 millimeters, it is more difficult to put in the stents, more complication occurs. So I think very, very important point to emphasize to all the audience that kindly do these procedures only if you have a dilated bile duct. Don't try it if the bile duct is less than 12 millimeters. You'll produce a complication, especially with lambs, you'll produce a complication. So what do you have? The alternative is to put the standard covered stent in these patients if you have non-dilated duct, and then the migration rate of the stent is very high. So therefore, this dilated bile duct is a very, very important concept to understand, that why success rates are differing so much. And one should, and I think Anthony's ultimate analysis was very balanced in their conclusion in the article. They said that this article suggests that we don't suggest that you go to US directly, but if you anticipate difficulty in form of a little edematous papillary area and so on, if the bile duct is dilated to more than 16 millimeters, then you have this. So it's not primary. It is secondary. After you assess that primary one is going to be difficult ERCP. This is very important to understand. And of course, there have been, based on these studies, there have been meta-analysis. I generally don't give importance to meta-analysis because meta-analysis are done by people who never hold endoscopes. They're done by the research students, a PhD student, they do meta-analysis. And this meta-analysis showed, of course, that clinical success more. And again, procedure-related pancreatitis naturally will be more with ERCP. There's no need of analyzing this data. It's going to be slightly more. But I think this meta-analysis, I don't know how much significance one should give that to. You know that tumor growth is going to be more with stents and so on. So this gets us this question of, if you are going to push primary US even for a small indication, without knowing that you should choose it for dilated, because wise people like Anthony know that you have to use it for a dilated duct. You have to use it only when you're going to anticipate difficult ERCP. But for the other general crowd, it's like, watching an IPL match and thinking that that's the right thing to do. So for the other crowd, they think. So that's the reason why ESG had, in fact, long back had this concern that they might be used as a substitute for poor ERCP technique. I think this is a point that Amol is also emphasizing. You should not use it as a substitute for poor ERCP technique. And because of this, again, the famous study, which has been quoted earlier, that only very small percentage in expert ERCP actually require US. Now, based on these studies, the ESG's 2022 recommendation is that ERCP for primary drainage of biliary ducts, but US guided biliary drainage can be considered in a setting of inoperable patients. Keep this in mind, inoperable. If a patient is likely to go for neoadjuvant therapy and surgery, don't think of USL, think of ERCP. In high volume center, they recommend. So very carefully worded statement that ESGs come up. And this is very important because this has a lot of narcissists put into this that we don't realize when you're looking at the articles, unless you analyze these articles. So is the ERCP fading out? I think I've argued saying that no, doesn't. The argument is strongly no. And interestingly, just yesterday, I was with the person who started all these arguments, Mark Giovannini in Rome. We're together in Rome and I was telling him that I'm going tomorrow to Delhi to have this talk and what his opinions are. And he gave some very nice suggestions. And of course, we know that ERCP especially has to be used for right-sided hilar region. I think in pancreatic cancers, although this is one of the indications for US, still ERCP has several other advantages too. For example, we now know if the patients have pain, which is postprandial in nature and so on, even stenting the pancreatic duct is helpful. And of course, this concept of adverse events in US versus ERCP are not comparable. US causes adverse events which can be more difficult to manage and treat than post-ERCP managed problem. Because post-ERCP causes mild pancreatitis in many of these distal tumors. If you perforate so many times, you stop doing ERCP. And of course, US produces biliary leak, which can be very not only problematic. Again, a point I think Amol emphasized earlier, the adverse effects of US are more risky. So what we should do in all these studies is to actually analyze the adverse effects of each of these procedures and see what happens. So I think we are in a situation which is very interesting. So what I thought is I'll give my wisdom because I've got bald. So some wisdom comes with baldness. So I'll give my wisdom on this, that if you look at pancreaticobiliary drainage, definitive indications for ERCP, of course, very clear, failed for US, failed ERCP and inaccessible papilla. I think this is no-brainer on that. Definite indications for ERCP, in my opinion, are choledocholitis. One should never try. I've seen people actually try and do primary US for choledocholitis, sometimes even in workshops. Of course, hilar malignancy with accessible papilla becomes, I think, a definitive indication for ERCP. And this is very important. This is the area where we are and very interesting to watch what's happening. We are primary drainage for distal bile strictures, I think is still evolving. We have to do a very careful analysis of some more studies. We agree that Anthony's study is very important, but what people don't realize is that Anthony's study actually said the other way around. It said do ERCP, and if you feel that the duct is very dilated, if there's edema and all, then think of US. So that was a message. So we require more studies. And very important, this is not realized much. What about rendezvous procedure? Should we quickly go into this based on this whole article, or should we again think of doing pre-cut, wait, go for second ERCP and so on, what we traditionally do? Again, this is a very evolving area. So this is my sort of balanced view. So I think we're still not Randhir, you agree? We still not, Mahesh and everybody agrees. Now we are still not old enough to become fading out of this field in ERCP. Still, there's a lot of value. And finally, probably in future, we may get a scope like this where you can combine both the procedures. So you become an expert in both. Thank you very much for your attention.
Thank you, Nagi, for a wonderful overview and the review of literature. Manoj, are we having questions in this? We know. So, a couple of questions allowed. Anybody in the audience wants to question Nagi?
Question.
Good evening, sir. Now, sir, what about using linear US scope for ERCP? It will save cost also because you don't to buy two scope. Apart from AMC will be also for one scope only.
So the present linear ERCP actually has a linear view, an oblique view, not a side viewing. So it's, I've seen occasions where they've cannulated the papilla with this, but it's extremely difficult to do so with this linear US scope. So currently the technology that's available is not good enough to do routine ERCP because of the oblique view. But both Olympus and Fuji are coming up with scopes where what happens is when you go to the papilla, you can turn the lens up and the channel comes up, and then you can actually cannulate like a side view scope. The only problem for that was that once this recent infection problem came with FDI, they stopped work on this area. They're not going on, but hopefully in future something like that will come, especially with the single-use scopes. I'm sure they can do this technology very easy, but market is not big enough for them to work on this.
So you mentioned a definite indication, hilar stricture with an accessible papilla.
Yeah.
So do you mean that there's no role of PT-BD now? Because
If
is going to both sides, then.
So hilar stricture, if you have said type 4, then you can, of course, you're talking about PT-BD, but there also it's many times combined with ERCP in these cases. I'm saying definite in terms of US. If you have a hilar stricture, one would always think of first doing an ERCP if you have an accessible valve rather than going for US. Again, because there is some people who would try to drain the left duct through the US, saying that if we drain 50% of the system, that's okay. So that should not be there. The definite indication is if it's an accessible papilla is ERCP, and if you fail or if you have a type 4 or type 3 complex stricture, then you can think of PT-BD combined with ERCP in this case.
Thank you.
I just wanted to simplify it because this would become more complex to talk about.
Thank you, Nagi, for wonderful discussion and overview. That it's my privilege to invite Professor Pramod Garg for the next talk. Pramod needs no introduction, but let me tell you that he's doing excellent work as a director of translational health sciences at Faridabad. And he has been associated with All India Institute for a very, very long time as a professor. We have all read his research work and have learned through those research works over a period of time. Pramod.
Thank you very much, sir. And I'd like to thank Rajesh for this kind invitation. I'm very happy that such a distinguished panel of chairpersons are here, and hard to follow Dr. Reddy after his wonderful talk, but I'll try my best. So I'm going to talk about endoscopic management of walled-off necrosis, and the title given was standardizing the protocols and optimizing outcomes, a rather difficult topic. And then it says, can we have a consensus? And my short answer to that is, forget it. I mean, obviously you can't have a consensus when you have, a galaxy of experts who do all kinds of procedures for walled-off necrosis. So this is what everybody wants to see. This is what you aspire to do. Those who are learning EUS guided procedures, you have a nice large collection in the lesser sac, very well formed wall. You have a hot axios with you. Just go in and you drain it. In a workshop, they'll be clapping, and you think this is touted as a cure for acute pancreatitis. But reality is, of course, much different. And that is the reason I will spend a couple of minutes on something else rather than on drainage of the fluid collections. So acute pancreatitis, as you all know, is associated with both local and systemic complications. And it is this local injury, if it is much more, which leads to systemic inflammation. And systemic inflammation, if it is severe enough, it results in organ dysfunction. And what I'm talking about is about 10 to 20% of patients would qualify to be labeled as severe acute pancreatitis if they have organ dysfunction. So fortunately, 80 to 90%, depending on the series, depending on the setting, will have mild pancreatitis, and we are not yet, worried about them. So whenever we discuss these issues, we are referring to those patients who have moderate to severe disease and have worse outcomes. So organ failure is a major problem. And many years ago, we showed that those who develop this kind of severe organ failure very early, within the first 3 to 4 days of illness, they have a very worse outcome. In fact, 11% of our patients accounted for 44% of all deaths within the first 8 days after hospitalization. And this was at a time when necrosis, fluid collections, and infection were either absent or just about evolving. So suggesting that early persistent organ failure is a major issue. And this is the comparison of 3 series. One is from our center, one is from the Dutch pancreatitis group, the other is from Spain. And if you look at the mortality in those with persistent organ failure, it is around 40%. In fact, slightly higher in the Spanish series, but it's about the same. So this is a major determinant of survival. And the reason I'm emphasizing this point is that we have to work harder for those patients who come in early and have organ dysfunction, systemic inflammation, rather than worry about draining the fluid collection with an EUS guided procedure and placing a hot axios. And I think we have largely failed to decrease mortality in such patients. Now, coming to the fluid collections, so it depends on whether a patient has got organ dysfunction or not at the time he presents to you. What is the timing of this from the onset of disease? And is there necrosis within the collection? And is the collection infected or sterile? And of course, every one of you should know that pseudocyst doesn't contain necrosis. The best way is through MRI. A T2 weight image will show you the black thing here is the necrotic debris within it. And the reason it is important is if you do a drainage, you should be prepared that this can get secondarily infected and will require further endoscopic necrosectomy. And another modality, in most patients, you are actually able to do transabdominal ultrasound and assess whether or not necrotic debris is present. So what you should know before you decide to drain a patient with pancreatic fluid collection. What are you draining? Pseudocyst or walled off necrosis? Always easy to drain pseudocyst. Just put 2 plastic stents and you are done with it. 95%, no problem. Are you draining sterile collection in a patient who has recovered from pancreatitis and is now presented with a large collection? Or you are draining infected collection? Infected collection, of course, has much higher morbidity and, of course, mortality. What is the underlying disease? So many times people get confused. In patients with chronic pancreatitis, you only have, I would say, more than 90-95% a pseudocyst. There is no necrosis because most patients, even when they develop fluid collection, it is pseudocyst without necrosis, rather easy to drain. But important point here is that in such patients with chronic pancreatitis related pseudocyst, you got to do a transpapillary drainage as well and place a stent, as opposed to acute pancreatitis, where we don't put a transpapillary stent. And I think now there is enough evidence also that a transpapillary stenting may not be required in majority of cases. And whom are you draining? Does this patient have organ failure when it presents to you, when you want to drain it? Mostly in patients with infected necrosis. And I think this will require a little bit different approach versus a stable patients where you are okay to drain EUS guided. The next point is, should you really drain? Not everybody with a large collection will require drainage. Even if there is a walled off necrosis about 8 to 10 centimeters in size, you don't really need to drain everyone. Patient should be symptomatic with either pain, obstruction, or infection. And if it is not symptomatic, but you find on serial follow-up that the cyst is enlarging, then I think it's a case for drainage because some patients might actually have leakage of the cyst. So in the first week, no drainage, nothing to be done, right? Now, if you're in the second and third week of illness, what do you do? How do you treat these patients? So this is an example of a lady who came with acute necrotizing pancreatitis. She had early organ failure, in ICU, improved, developed fever in the second week of illness. And that's the classical presentation. And you diagnose strongly suspected infected pancreatic necrosis. The question is, should you drain? This is in the second week of illness. She had fever, she has high counts. So recently a pointer trial was published. from the Dutch group showed not much difference between those who went in for early drainage within the second and third week and versus those who had delayed drainage. The only issue with that study was that in the early drainage group also, the mean time to drainage was 21 days. So they were actually towards the end of third week, not really in the second or early third week. So I would suggest that, we have to consider that timing also. In stable patient, generally wait till 4 weeks. But if patient is worsening, sepsis is not getting control, even in late second week or third week, you are okay to drain it. And most of the time it is percutaneous drainage. We are also doing a randomized trial. The inclusion of patients is rather difficult, very slow recruitment, but hopefully we'll have some data in the near future. So in the third week, the patient continues to have fever, counts are high, and now you find there is worsening of organ dysfunction. This is what we call as secondary organ failure. The primary organ failure is in the first week, and secondary occurs when you have infected necrosis because of sepsis. Should you drain now? Of course, yes. So whether it is late second week or third week, patient is worsening, go in for drainage. And in this situation, if you often find collections like this, away from the stomach, deep extensions in paracolic gutter on pelvis, then the only recourse is to put in a percutaneous drain. And fortunately, most patients improve. In fact, the first trial, the Dutch published in 2007 showed 1/3 of patients could be managed only with drainage and antibiotics. The latest trial from the Dutch group showed 1/3 of patients can be managed even without drainage, and 50 to 60% improve with drainage and antibiotics. This lady also improved with that. So this is the current paradigm in most patients: conservative treatment first, followed by percutaneous drainage, and then followed by minimally invasive necrosectomy in those who do not improve. So many years ago, again, we showed in a study that if you compare surgery versus conservative treatment approach, we find the mortality in the conservative group was lower, although statistically not significant. But at that time, the concept was everybody with infected necrosis goes for surgery, right? Right now, we know it is not the case. And a meta-analysis done at that time also showed that 64% patients can improve with antibiotics and drainage, 70% requires catheter drainage, and necrosectomy is required in about a quarter of them, and mortality of about 12%. So gradually the paradigm from surgical necrosectomy for all comers with infected necrosis changed to a conservative first approach. This is a second patient who is a young man, acute necrotizing pancreatitis, 5th week of illness, fever for a week, rising TLC. Classical wall duct necrosis, which is infected, and this is what you find. And you go in, Sandeep Laktika is here, he will say, okay, what are these issues? Nothing, just go in and put a metal stent and you'll be fine. And I agree with that. But the issues are, if you have facility for another invasive, minimal invasive technique like laparoscopic drainage, that also can be considered. Whether you put a metal stent or 2 plastic stents, again, the issue is still alive. It's not done with yet. And the others, of course, technique, you have seen the drainage and all. I think one of the, you must have been shown this live procedure also. This is how you put different kinds of stents. And of course, you can do necrosectomy through that stent. Coming to the comparison of endoscopic versus laparoscopic drainage, we published one of the earlier randomized trial. We showed that both the techniques were by and large similar, but the infection, secondary infection rate in the endoscopy group was higher compared to the laparoscopy group. And in this study, we had placed only plastic stents and not a metal stent. And majority of patients have wall duct necrosis, but there were stable patients without infection. Then we did a second randomized trial because we found a higher percentage having secondary infection. And here we tailored the type of stent used to either a plastic if the debris was minimal, less than 1/3, or a metal stent if the debris was more than 1/3. And again, compared it with the laparoscopy. And here we found that both groups were similar in terms of success rate and complications, but the procedure time and this overall stay in the hospital was somewhat lower in the endoscopic group. So suggesting that you can prefer endoscopic therapy for patients who have walled off necrosis with a higher amount of necrosis and those who have infected necrosis. We have just finished the third randomized trial, and I hope within the next 2 to 3 months, it should be somewhere in one of the journals. This is the third example where you have another young man, infected necrosis, large collections, multiple organ dysfunction. What do you do? And you see the types of collections here. We can't do a peroral direct endoscopic drainage and necrosectomy. And these are very difficult patients to treat. We wanted this, but often the situation is very, very different. One of the cases that I demonstrate today falls in that category. So patients in the ICU with organ dysfunction, you have tried conservative therapy, you have placed percutaneous drains, 1, 2, upsized the drains, still sepsis is ongoing. And there is no room for peroral direct endoscopic necrosectomy. And that is where the role of percutaneous endoscopic necrosectomy comes in, which is what I showed. So initially you place a 12 French stent, upsize it to 16 or 18 French, and use an ultra thin scope to do lavage, take out the liquid pus, and you can use this tract, the sinus tract. Once the patient stabilizes, then you can dilate the tract to about 12 millimeters with a balloon or gradually by other dilators. And then you can do a lavage and necrosectomy using a standard upper GI endoscope, which is about 9 millimeter in size. And small chunks of tissue will come out. So don't think that you will take out large amounts of tissue. You have to be very, very patient. This afternoon when I did that procedure, very small amount of necrotic debris we could take out. So you have to be patient and you have to do it in multiple sittings. That's an advantage of the procedure. So this was the first series of 15 patients that we published in 2015. That was very select group of patients. So everybody improved and but it was very encouraging. Now, with a large collection like this, my colleague Soumya is here and he does this procedure regularly. This is one of his cases where he performed, endoscopic percutaneous necrosectomy by placing a metal stent. If you have a large debris inside, it is better to place a metal stent and do necrosectomy in the second and third sitting. Sometimes you get very large tissue. And you see, this is the cavity which is clean after the procedure, and large collections before, and this is post drainage, all the collection is now gone. So this was the second series we published, 177 patients, and the overall success rate of this was 80%. Still 20% didn't improve, by the way. And those are the patients who have organ dysfunction. So one of the things we should always look at when we see randomized trial. This is a Miser randomized trial comparing endoscopy versus minimal invasive surgery. They assessed 168 patients and only 70 of them could be randomized. Majority did not qualify the inclusion criteria. Same way, if you look, the tension trial was published earlier. They screened 418 patients for that randomization for endoscopy versus minimally invasive. Only 98 could be randomized. So large majority do not qualify for the type of treatment the randomized trial is planned for. So for those patients, you have to have other strategies. And that's why I showed in the beginning that hot axios in a very nice collection is not the answer for majority of cases. So I would suggest that all the postgraduates should read this editorial, what Soumya has written last year in Gastro, summarizing the whole thing about the treatment modalities for infected necrosis. It depends on the location of the collection, the timing, the wall maturity, the infection, the presence of organ failure. So many other things you have to take into consideration before you decide whether I'm going to do a peroral drainage or percutaneous drainage, pen or ward, or whatever other modalities we have. So ladies and gentlemen, I'd like to summarize by saying that acute fluid collections without necrosis resolve on their own. Don't touch them. Acute fluid collections with necrosis determines the outcome and they usually persist. But if they're sterile, we do no intervention in majority of cases, although there is some data emerging, a couple of studies from China showing that even if you drain the fluid from acute necrotic collections, you might improve the outcome, but we need more randomized trials. If you have infected necrosis, conservative first approach or step approach, antibiotics followed by percutaneous drainage or endoscopic drainage, depending on the location. And then you can do minimal invasive necrosectomy. For walled off necrosis, which is symptomatic, you can do either endoscopic drainage or laparoscopic. Thank you very much for your attention. Happy to take questions.
Thank you, Pramod. We can take a couple of questions if the time permits. Pramod, how early can you go with endoscopy?
I would say third week you can go in, but a CT would be very important. Even if your collection is partially encapsulated, it's okay to go if the patient is not improving.
My question is, the basic problem with pancreatitis is a huge collection, which is necrotic, which is a burden on the body. Once you have an access to the necrotic tissue, why do you remove it in different bits? Why not remove in one go?
So the question is, how do you remove in one go? In one go, you have to do surgery.
Whatever is visible.
So in one go, it is surgery. But the problem with surgery is, of course, collateral damage, and it puts a lot of stress on the patient. And that's the reason why you have to go for minimally invasive. And when you do minimal invasive for DEN also, for PEN also, you can only take out small bits. But you go in again after 2 days, after 3 days, and repeat the procedure. Even for ward, you see when they undergo procedure, small bits of tissues are taken out. They take 2 hours, maybe longer sometimes. So it has to be a very, very slow procedure. So you open it up and take out everything, but patient will die of something else, not the necrosis.
Promote in patients where you're doing it early, maybe in partially organized or partially encapsulated one or acute infected necrotic fluid collection, will you ever put in a metal stent, or will you always put in a plastic stent in 3 weeks? Say if you have to intervene at 3 weeks, not after mature.
Per oral?
Per oral.
So per oral, if I find that the opposition is okay, and even if it is partially encapsulated, but there is necrotic debris or infection, I would prefer to put a metal stent because it's covered stent, and I think the chances of other problems because of the immature wall will be less.
Dr. Pramod, does the addition of nasocystic drainage and lavaging it with antibiotics and maybe hydrogen peroxide, does it help?
So there are 3 things here in your question: nasocystic drain, antibiotics, and hydrogen peroxide. So we don't put nasocystic. I don't think it is useful. A very small 7 French tube doesn't do anything. In fact, you can put a Riles tube. So that we have done sometimes. You take a 14 or 16 French Riles tube and put it orally into the collection for lavage. It can help. That is okay. Antibiotics lavage, I don't think has been shown to be beneficial. Hydrogen peroxide, some people have used. We've been using for a while, but now we have stopped it because I found in 2 of our patients they developed peritonitis, probably because of the increase in pressure. But small amount of hydrogen peroxide you can put in. Now what we also do is inject hydrogen peroxide 1 ml, 2 ml, 3 ml into the necrotic debris, hoping it might help. Not sure about that though. Can you put my slides once again?
So I have one last one question here. So the use of endoscopic step-up approach and for Vaughan and necrosectomy based on 1 or 2 one trials, and that changed our complete management. But do you feel that doing an endoscopic management in 3rd week, 4th week versus a laparoscopic management, and with endoscopy we are actually increasing the morbidity cost to the patient versus a laparoscopic, and I'm not talking about a full open surgery, but a laparoscopic approach?
So I agree with, that's why I showed you in our 2 randomized trials that laparoscopic treatment is equally effective. Complications are similar. If you have an expert laparoscopic surgeon, go in, especially if patient has biliary pancreatitis. So those having biliary pancreatitis and a wall depth necrosis, we generally prefer now laparoscopic drainage, and at the same time they do cholecystectomy. In infected necrosis, surgeons may be a little reluctant to go in and do, but we have done a randomized trial. We'll show you that. I just wanted to show you and invite you all for this meeting this September, organized by International Association of Pancreatology and Indian Pancreas Club from September 15 to 17 in New Delhi. All of you are welcome. Many of you might have already received the invitation as faculty, and also call for abstract. And Dr. Nageswar Reddy is the chairman and president of this Congress. So I hope all of you will join us. Thank you.
Thank you, Pramod.
Thank you, Pramod. Our next talk is by Professor Anthony Thieu, who is the president of the World Congress of US. He is the professor of upper GI and metabolic surgery at University of Hong Kong. Since morning, thanks to Rajesh, we have been looking at the positive, exhilarating, and scintillating aspect of the US. But as clinicians, we know it all comes with some price. there is always I do not call it an ugly side, but I think it is an integral component of anything and everything you do. So Dr. Anthony is going to talk about the so-called ugly side, which I think is an integral part of our day-to-day procedural activities of endoscopic, especially the interventional EUS. Professor Anthony, please.
So thank you very much for your kind introduction. So it is very exciting to be sitting amongst the audience to listen to all the big leaders in endoscopy discussing about your publications. It is very enjoying. So I think right now we are at a juncture. So when I was starting to learn interventional US, all these procedures are very difficult. You know, you see experts struggling during live demo, trying to change all sorts of different devices, trying to get the devices into the bile duct or somewhere. But now, many of us have done this for 10 years. You know, we are getting very specific devices. So we are really see a big progression in terms of interventional US. And, you know, for my juniors, they are so used to these single step systems. Like they don't learn this multi-step process, which you insert a guide wire, cystotome, balloon, and then stent. And they find it quite cumbersome to do. So, but it is some skills that you actually need to know because every now and then you run into issues. So I think what I'm about to talk to you in this next 20 minutes is also very important because we are moving forward towards a primary intervention ES procedures. So definitely you need to learn how to deal with issues encountered. So nightmares in US, when I started doing these procedures, one of my predecessors told me, you know, when you succeed, you are a hero because you are successful in doing all these very difficult procedures that no one has succeeded. But when you fail miserably because, you know, you end up with a major complication, which may require surgery. When you deal with complications, I think when something happens, for example, there's a misdeployment or the stent migrated, you have two problems to deal with. One is to deal with the initial problem, and then the second problem is the problem that you have created. So you need to really ask yourself whether you are the person that should be dealing with, whether you should continue with the procedure. Can the patient tolerate another failure? Is there someone in your unit who could do a better job than you? Should you involve that person? And of course, whether you should inform your friends in radiology or surgery the soonest. In terms of potential complications in interventional ES, I broadly divided this into several categories: stent misdeployment, migrations, blockage, perforation, foot impaction, and bleeding. I think nowadays, with growing experience in dealing with these issues, I think most of them could be dealt with endoscopically. And occasionally, we may need IR intervention for bleeding. And nowadays, I think rarely surgery. In terms of stent position and migration, this is often the most common thing that would be in our mind when we are doing these interventional ES procedure. I think it happens usually during your initial learning phase. When you see something, you don't recognize the danger in the procedure. This is a video taken from my book, which would be introduced later. This is a CDS, and it also highlights what Nagi said about the problem with CDS. So this is from Emeritus Center. They were using a big size hot axios 10, and they are doing a primary puncture. You can see right here, the position is very bad. The stent delivery system is very stiff. It's just pointing towards the opposite direction. And the stent actually deploys backwards. So you need to have the stent delivery system very deep into the bile duct in order for a stent to backward deploy to be inside the bile duct. So in this situation, the stent was deployed outside the bile ducts. So the delivery system punctured a hole in the bile duct. But as she opened the stent, it was between the bile duct and the duodenum. And in this case, because in the States, they didn't have the 8 and 6, they were using a 10, so it's way too big for the CDS. So you can see the wire, only at this point, they insert a wire, and then it was going down, and they deployed the stent anyways. So they tried to cannulate through the stent, and luckily the wire went through the CDS and back into the bile duct. So once they have a bile duct access, they can do a stent on stent. So they had a balloon catheter. It was going through the axials and going in bile duct, and with contrast, you show the bile duct. So at this point, you know, one could be pretty sure that you could do a stent on stent and bridge the opening at the distal CBD. So several learning points in this case. If you have a small bile duct, don't do direct puncture. Insert a needle first, insert the guide wire. If you want to use the hot axials, make sure the delivery system, the puncture direction is in line with the bile ducts rather than perpendicular. And always insert the delivery system deep into the bile duct. And if anything happens, the guide wire would always be your savior because you can always do a stent on stent. And I think if you are successful in doing a stent on stent, most of these patients can do quite well without any major complications. Okay, this is the cholangiogram showing no leak. Another case of a edge procedure. So for the edge procedure, one would need to insert a luminal pulsing stent between the excluded stomach, do a ERCP through the excluded stomach, and complete the procedure. So in this case, again taken from my book, a case from Cornell Ream. So first part is to puncture the excluded stomach, inflate the stomach with saline, and then do a US guided gastrostomy. Deploy the stent. And nowadays, there are many ways of doing this. Some people would suture the stent with an Ovesco overstitch. Some people would do it a few days. So place the stent first and then do it a few days later. Okay, so in this case, I think Ream did it as a primary procedure. All went well. They did a ERCP. And then afterwards, the metal stent was inserted. Okay, and then here, as she was putting back, you can see here, this is in the peritoneum. Okay, the axial stent has been pushed out from the gastric remnant, and this is all extraperitoneal fat. So this is a problem with doing it at a primary puncture. So there's a risk of always pushing the stent out. So at this point, she decided to do a stent on stent. You have an alternative of pulling it, trying to pull it back into the excluded stomach. But of course, you always have the chance of pulling it out from the distal end. So at this point, she did use a esophageal stent and bridged the two stomach together. So if you are able to bridge the two openings, most of the time these patients do quite well. USGJ, stent deployment. So this is with a freehand technique. So water infusion, you can see this is the jejunum. At this point, I think I had a pretty good puncture site. It's very close to the stomach. And the direction is also quite well. On hindsight, I think it's a little bit not well inflated. And here you can see actually it's moving a little bit away from the stomach as well. So also makes me think that maybe it's not so well distended. So at this point, I pushed in. You lose view. You don't know whether your delivery system is in the duodenum or not. So anyway, I deployed the distal end. And after I deployed, I'm sure I'm not in the jejunum. And you see some fluid outside. So probably we had a small perforation in the duodenum or in the jejunum somewhere. So at this point, decided to pull out the stent altogether. Don't panic, reassess. Okay, you can always have the option of doing a duodenal stent. So issues, small bowel not so dilated, small bowel may be moving. When I punctured, the image was lost. You're not sure where you're in the duodenum, jejunum, or just outside the jejunum. So you have to decide whether you want to deploy or not. So afterwards, we try to inflate the small bowel again. There's some free fluid, but it was still inflatable. So we decided to try to repuncture. And again, if repuncture is successful, most of these patients actually do quite well. There might be a small hole somewhere. You fast the patient for a bit longer, and these holes tend to close by itself. So with a proper deployment into the jejunum, and also deployment of the proximal flange, so the drainage was reestablished. So you can decide whether you want to insert a duodenal stent, or if you are quite confident, then you can retry a gastrojejunostomy. So again, this illustrates the fact that if you encounter problems, try to correct your problems. And the most important point is try to establish drainage. So if you can establish drainage, you will be okay most of the time. So with this study published in GIE, they classified misdeployment of GJ stents into type 1, type 2, type 3. So most common type is the type 1, where there is a misdeployed distal end. Type 2 is a opening of a small enterotomy in the jejunum. Type 3 and type 4s are very uncommon. But if you look at the management, type 1 and type 2, most of the time, these are mild complications. There is one fatal complication, which is type 3, and then type 4, most of the time, these are moderate complications. And in terms of management, majority can have same session USGE or a same session duodenal stent. Okay, how about in HGS? Again, HGS is sometimes difficult, as you can see in my case today. Small bowel ducts, definitely an issue. Guide wire manipulation. Stent placement, landing site is a very important consideration. Sometimes the ducts are very angulated, your stent doesn't go through. And then, of course, stent-related complications. This is a very important sign you need to recognize. Two dents, one here, means this part of the stent is in the peritoneal cavity. This is the, some people may say the cotton candy sign. So if you have a cotton candy sign, you need to be very careful. You have a long segment within the peritoneum. Sometimes the stomach edge side of the stent may be very short. So how to prevent stent migration? At least have 5 centimeters in the stomach. Methods to salvage: stent on stent, stent with anti-migratory properties, crisscross anchoring of stents, clip flat method. So crisscross method is to apply 2 PD stents in like a cross manner, so as to prevent the stent from migrating. These are all from Isayama. Applying clips, trying to create a flap to prevent it from migrating out. Not so sure, but maybe useful. Perforation. This is a case with a gallbladder drainage. we did for a high-risk patient. So first part is very stable. Everything went well, stent deployed. And here, I was trying to do something more. I was trying to push the stent so that I can look into the lumen and try to aspirate bile. So, but the stent is at the D, maybe lower end, D2, almost D3. So I was trying to do this maneuver, trying to turn into the stent. Oops, sorry. And when I turned here, you see peritoneal fat, okay? So I didn't know what happened, so I pull back immediately. And then I see a lot of blood. So a bit panicking. So you can see a small hole right there, actually right next to the stent. Here, okay? It's adjacent to stent. So this tells you any newly created anastomosis between using EOS is very fragile. Try not to do many manipulation. This is the contrast showing the leak right here. This is the gallbladder. So at this point, change to the gastroscope, try to identify the perforation site, and luckily we were able to apply a few clips. This is really between the stent and the duodenum. So these newly created anastomosis are fragile, so don't try to do too much. After stent placement, if you are happy with the position, just leave it there. If you want to do intervention, maybe do it the next day or the day after. So the view wasn't very good, but we applied a few clips right at this opening. And then finally, we did a contrast. I was very happy because there was no more leak. Unusual case. This case highlights the importance of a landing site. Very unusual. So you can see this is a patient with pancreatic cancer, failed cannulation, quite a dilated segment 3, which I thought 7.8. We puncture with a needle, contrast going through. So at this point, I still think it might be, a relatively smooth HGS, the scope position is okay. Puncture site is here, segment 2, maybe segment 3, right at the left intrahepatic duct bifurcation. And then maybe here is the common bile duct. So maybe I could land the stent somewhere around here. So the wire went down. And then finally coming back up. At this point, I insert a cystotome. So I thought my stent could, go through this curve and maybe land around this area. But we need to be aware I'm in magnification here. So my scope was length, this is 1.5. So this is actually quite short, maybe around 2 centimeters, at most 2.5. And with the 10 centimeter geoball, we need at least 3 centimeter landing site. So this is actually not enough for landing. But anyways, we didn't realize at this point, so we insert a cystotome as per usual. Okay. So here we are trying to insert a stent. Okay. Wait. Okay. Okay, here. So here is the difficulty. We insert the geoball. This is the uncovered portion. Very long. The wire is a bit bent. This is not going down as planned. And then we kept pushing. And then suddenly it gave way. And then we retract the wire. It's going to here. So this didn't look good. So even if we went to this side. So we suspect with force tract. So we pull back. We know part of the track is in the bile duct, part of it is outside. This is the force track. So at this point, there are several options. You can try to place the stent back here, or just go for a PDBD. Okay. Somehow we were able to remanipulate the wire back into what we think is the bile duct. So we decide to insert the geo-ball and then a fully covered stent over this area. On hindsight, we probably should have inserted a fully covered stent from maybe from here to here, but we might risk covering some of the side branches. So here is the geo-ball again, but we deployed right up to this area and try to stay away from the force track. So this uncovered portion is definitely outside the living parenchyma. And then we reinserted a fully covered stent. Even this part is difficult. You can see the geo-ball is buckling, it's moving away. It's very difficult. The two metal stents are not passing through very well, but finally we managed. So we did a stent on stent covering the covered portion of the geo-ball. And then contrast injection, showing no leak, but opacification of the bile ducts. So again, with correct placement of stent, we were able to salvage this procedure. Okay, tips and tricks. So most importantly is to have good planning. Decide where to puncture. So this morning we were assessing a long time. Where is the puncture site? Is very close to the stenotic area. So we decide to move away a bit more. We anticipate the potential problems, try to have plan B. If plan A doesn't work, there's no room for error. There's one-shot procedure, have good preparation, have a good assistant, always accessorize yourself, have all the devices you need. And now, of course, if you have backup, always look for backup. So in conclusion, complication in interventional ES can be terrifying. Make slow, cautious steps in learning US. Be friends with radiologists and surgeons. Initial learning best done in the presence of experienced endosonographers, but there are great rewards in successful cases. So thank you for your attention.
Thank you, Professor Anthony, for such a nice and lucid presentation regarding the complication of interventional EUS. Now the house is open for any questions. Sir, I want to ask one question. The most common procedure we do is in interventional endoscopic care. EUS is EUS guided cystogastroscopy and necrosectomy. How to deal with patients who bled during necrosectomy from the base of the necrotic material? Do you go for directly IR, call the IR people, or do something by yourself?
Yeah, so I think there are several areas that it can bleed. If it's bleeding during the procedures, so at the gastric wall, which is very often seen. So in those cases, inserting a metal stent is quite useful. If it's still bleeding, you can always use the balloon to dilate it and compress on the bleeding side. I think that is also helpful. Sometimes if you insert a plastic stent, there might be some vessels in the wall. So once you remove the metal stent, you might see the vessel. In those cases, it might still be quite difficult to control bleeding endoscopically. So again, metal stent can be useful. If during the procedure, of course, you need to recognize that sometimes the splenic artery or branches of the artery or the splenic vein is around that area. So, always do it cautiously. Don't try to remove too big of a chunk of material. If you think it's really stuck, then just leave it for next time. If you encounter some arterial bleeding, spurter, we will try to control it endoscopically if it's controllable. But of course, if you see a big gush of blood coming out, you're just wasting time endoscopically. I think that it's probably wise to move on to IR drainage. It's very common to see a bit of like venous oozing every now and then. I think those tend to stop by itself with time.
So when you're planning EUS CDS, you're planning to have 10 lamps. What should be the ideal size of CBD for the proper deployment of that lamps? Because in good space, what should be the ideal?
Yeah. So for lamps, we try to use the 8 and 6 millimeter. And in general, the flange size is around 2 times. So it's around 16 and also 12 millimeter. So that's why our minimum duct size for the lamps is 12 millimeters. But it's not so much the flange size, it's probably the direction of puncture. So if the bile duct, if you puncture like this is very short. So if you open backwards, sometimes the stand flange will be between the bile duct. So you need to puncture at the direction. So sometimes you would need to insert a needle first to get this direction, or change the scope of the direction of the endoscope so that you can puncture at the direction along the CBD, so you can insert it
It should
deeply.
not be perpendicular, it should be like tangential going through the
Yeah,
proximal.
so it should be more at an tangential direction, so that you can insert it deeper.
Perfect, thank you.
Thank you.
Sir, I wanted to ask for CDS, you are advised to put wire after puncturing through the lamps catheter, or you want to preload the wire first with the needle and then change it to the lamps catheter?
Well, I think if you're using lamps, it's always safer to have a needle and guide wire first. But once you are used to the puncturing direction and all that, then many people do a direct puncture.
Thank you, Anthony, for an excellent talk. Thank you so much. Close the section now.
So I request chairperson to stay for 5 more minutes. And I think we are able to finish our program on time. And bear with us for 5 more minutes, then we have a gala dinner. And I will, after this, update about the 2 cases. So the 2 fully covered metal stent was placed side to side to reconstruct the porta. And in my case, we can see a trace of dye was going into the head of the pancreas. So we drained the cyst with the plastic stent. And we have a book launch for 2 minutes of a book written by Professor Anthony Theo, which we are going to start. And tomorrow there is a very interesting session by the young endosonologist, and have an open forum discussion at 8:15. And I would like to invite for the 2 important function. One is exactly after 1 month, and I request to play the video, and the next year EndoCon. So can we play the video and then we do the book launch? A small video for the next year EndoCon done by Medanta. Thank you, and would invite Dr. Nageshwar Reddy. Dr. Nageshwar Reddy sir, Dr. Pramod Garg, and if Professor Mustafa is here, and the chairperson to launch the book, which is written by Anthony Theo. He's an editor, which is an atlas for the interventional endoscopic ultrasound. I will just say a few words. Anthony can speak about that, and we can have a launch of the book.
So thank you very much for the Mandanta team. So it is my great honor to be here. This book is not written by me. So actually a lot of the authors are here tonight, you know, Vinay, Sandeep, and everyone has helped contribute to this book. This book has been written and published maybe for some time. And actually it's been downloaded for more than 9,000 times already on the internet. So it's one of the biggest seller from Springer. So hopefully it'll be useful to all of you. And I thank Dr. Puri very much for arranging this ceremony. So thank you very much. Yes.
Now you all are invited for the gala dinner, and there is no musical program. Thought of going to make it a complete educational program, so you can enjoy and interact with each other. I think that was the main purpose, because most of the time, because of the music loud, you cannot interact. So we can start with the dinner.
Yeah, so I think scan this.
Eh? O leite da mãe é branco. O branco da neve. A pureza da luz. Consciência é o futuro. Purifica.